Sir, one second.
Yes, sir.
That is because all the speakers are on.
ನಾವೆಲ್ಲ ಇಲ್ಲೇ ಇದ್ದೀವಿ.
Yeah, actually, I got it. I called up Nami.
Okay. Morning. Good afternoon. ನೋಡಿ ಕೇಳ್ತಾ ಇದೆಯಾ ಅಂತ. Good.
Because we wanted somebody to handle because one of the lady who was trained, she was on leave today. So we wanted one more person to be trained and it has to be. And we had some challenges like it was not working on iPhone. Then I came to know that actually it is not working on iPhone. So that is why we would have called you.
ಸರ್ ಸುಮ್ಮನೆ ಬರಕ್ಕೆ ಹೇಳಿದಾರಂತೆ
ಯಾವಾಗ? ಸಾಯಂಕಾಲನ?
ಇವತ್ತು ಮಧ್ಯಾಹ್ನ.
ಓಕೆ, ಬಂದರು ಸರ್.
Sure.
ಲಂಚ್ ಆಯ್ತಾ ನಿಮ್ಮದು? ಕೇಳ್ತಾ ಇದೆಯಾ? ಓಕೆ. ದಿಸ್ ಪುಳಿಯೋಗರೆ, ವಡೆ,
Yeah, I'll check it.
ಬಿಸಿ ಬೇಳೆ.
I was worried about the. I got
Sir,
this.
mute.
Huh?
Sir, mute.
Good afternoon. I see everybody ready on the first. I see all the speakers and the chairpersons. Good afternoon and welcome everybody. But we have still 5 minutes to go live. Uh, yes. Welcome to ADORE 2021. This is the 9th edition of ADORE. I am Dr. Sanjay Reddy, one of the organizers of this meeting. Along with me, I have Pooja and Hall Hay will coordinate. Dr. Pooja will coordinate and take you through the day, and I obviously will be around here. Thank you all for joining us. Just a few words about ADORE and Cure Trust. ADORE we are doing the 9th edition of ADORE. Initially, it was planned for physicians and basically educators and diabetes practitioners. But over the years, in the last 2 years, we've become virtual and we've been lucky. It was a physically held meeting for one day. Now we've moved it to 1.5 days due to the virtual space, and we have a lot of international faculty also joining us, giving us some cutting edge research and research to clinical practice. Now, ADORE and Cure Trust. Cure Trust is a trust run by Diacon Hospital, and the main functions of it is basically into postgraduate, to run a postgraduate course in diabetology, and it supports that post-graduation course. And also, the other activity of Cure Trust is type 1 diabetes children, and along with Primary Academy of Medical Sciences, cater to a lot of type 1 philanthropy. We take care of children with type 1 diabetes and basically the economically privileged. They get every assist test, insulin, strips, educational support, and so on. This has been going on for a long number of years. And also, it is the trust is also part of educating a lot of diabetic educators. Over the years, I think thousands of diabetic educator nurses have been trained over there, both physically and in a different format, where they learn different types of, who learn to support patients who have diabetes. I've been there for, and Dicon is the first diabetes hospital in Karnataka to have set up a comprehensive diabetes facility more than 30 years. With these few words, and I would also encourage all of you to stick to time, and thank you all for joining. We have another couple of housekeeping announcements. So the moderator will take the session through, introduce the speakers, and our MC will introduce the moderator for the talk today. We have first a couple of symposia, which both the program is run simultaneously in Hall A and Hall B. We have more than 1,500 registered delegates for this meeting, and this also, as the day 2, we have also lifestyle and education programs, which are also streamed and live for people, for patients as well as diabetic educators and dietitians. Now, what we have another couple of minutes before we start the program, so I would like to hand over the mic to Dr. Pooja. Dr. Pooja is a fellow in diabetology at Diacon Hospital. She will try and run you through this, take you through the program for the next couple of hours. Over to you, Dr. Pooja.
Good afternoon, everyone. Thank you for being here with us today. I would take this opportunity to introduce the first chairperson for today's conference, Dr. Suresh Krishnam, consultant physician and diabetologist at Health Station, Bangalore. Welcome, doctor. Over to you. Thank you.
Yes, Dr. Krish.
Hello.
Yeah.
Let me introduce today's speaker, Dr. Dwijraj Hegde. He has done his MBBS, MD General Medicine, DNB Endo, and is a consultant endocrinologist at PSA and KES. Welcome, Dr. Hegde.
Thank you, sir. Am I audible? Should I share my screen?
You can, doctor.
Yeah, you can start.
Are my slides visible?
Yes, doctor.
Can I start?
Yes.
So at the outset, I would like to thank ADORE committee for giving me this opportunity to speak
Sir,
about
you
time.
should put it on, Dr. Hegde, you should put it on slideshow. So,
Yeah, is it visible?
yeah, it is visible. You need to put it on slideshow.
Actually, I already put it on the slide.
Okay, right, perfect. Go ahead.
Yeah. So sorry for the interruption. I would first of all thank ADORE committee and Sanofi for giving me this opportunity to speak about time in range clinical implication and role of generation 2 basal insulins. And I'm as introduced by Dr. Suresh. Thank you for the kind introduction. So I'll be speaking about these topics, that's concept of TIR and clinical implication, review of global recommendations on TIR, addressing the TIR with basal insulin therapy and comparing generation 2 basal insulin analogs in the light of time in range. So as we all know, earlier was the concept of glycemic triad, that is fasting blood glucose, postprandial blood glucose, and HbA1c levels. So with the advent of newer technology, so we have glycemic hexad, that is fasting blood glucose, postprandial blood glucose, HbA1c, and other than that, we have glycemic variability, nocturnal hypoglycemia, and hypoglycemia. So starting with what is glycemic variability. So glycemic variability basically refers to the fluctuation in blood glucose, both peaks and troughs. So it can be
Doctor,
yeah.
Dr. Hegde, you
Yeah.
need to put it on slideshow and your slides are not moving. If you can.
Actually, it's already in the slideshow.
Now it is moving, yeah.
Yeah.
Okay.
So glycemic variability basically refers to fluctuations in blood glucose, both peaks and troughs. So it can be within day or day to day. Within day is intraday variation and day to day is interday variation. So as we all know, glycemic variability basically leads to high oxidative stress and it increases the chances of hypoglycemia. So these are the three scenarios. On the left side of the screen, as you can see, there are three patients, and this is an just an illustrative example. So first patient has only 18% of the time his blood glucose is in the range, that is 70 to 180, and in 24% of the time it's below range, and 58% of the time it is above range. And second patient has 63% of the time in the range and 29% of the time above the range and 8% of the time below the range. And third patient has his or her blood glucose almost 100% of the time in the range. So all three patients have HbA1c of 7%. So we can see a stark contrast between the type 1 and in the patient number 1 and patient number 3, wherein patient number 1 has both huge hypo and hypers happening, and patient number 3 has most of the readings in the normal range, even though deceptively the HbA1c looks normal in all three patients, that is 7%. So on the right side of the screen, we can see that the blood glucose varies throughout the day. As we all know, it is not a static parameter, it's a dynamic parameter. So after in this graph, you can see that after breakfast, the blood glucose is peaking and it's going around 250 or so. And just before lunch, it is going to the hypo level. And again, in the around 4-5 p.m., again, it is going to the hypo level. So these variations are happening, and but the blood glucose HbA1c may be normal. So we'll speak briefly about what is time in range, what is time above range, and what is time below range. So the time in range, it can be set for different patients, different levels. For in high risk patients, we can keep the time in range at a slightly different level. But for majority of the patients, time in range is the level between 70 to 180 milligram per deciliter. So it is expected that at least 17 hours a day, the blood glucose levels should be in this range, that is between 70 to 180. And we should try to minimize the time above range. Above range is anything above 180. So it can be 180 to 250, we call it as type 1 hyperglycemia, and more than 250, we call it as type 2 hyperglycemia. and anything less than 70, we call it as time below range. So between 54 to 69, it is level 1 hypoglycemia, and less than 54, we call it as level 2 hypoglycemia. So we should try to minimize time below range as much as possible, but according to criteria, less than 4% is the cutoff. Whereas,
Sorry to interrupt, Dr.
yeah,
Dvijaraj.
yeah.
Sir, slides are not moving.
So madam,
There's
from
some
my
settings
side,
on your.
from
Now,
my
yes.
side, it's in the slide share mode only. I don't know.
Yeah,
is
but
it
I don't know
moving?
what's wrong, but every time maybe you'll have to do that
Is it
when you go to
moving
the
now?
next slide.
Is it moving? Is it moving, madam, now?
Not yet, Max. Not yet, sir.
Sir, select slideshow presentation, sir.
Sir, it's in the slideshow mode only.
No, sir, it's not on the slideshow. The percentage where it is featuring as 116, you click just beside that there is a button. Click on that icon, sir.
Sir, I already clicked it. It's in the slideshow mode only. For me, it is showing in the slideshare mode.
So can I give it to the technical person to help you?
So that's what Rakesh told is correct. You want to click on the slideshow, but it's not clicking.
Sir, you have to click on
Sir,
this button, the arrow button which I'm showing.
Sir, you unshare and reshare the slide, sir.
Yeah.
You please unshare and reshare the slide.
Yeah, go to, yeah. Share screen.
Yeah,
now
now
it's
it's
fine.
Now
perfect.
it's-
Good to go, sir.
Yeah. Thank
Yeah.
you. Sorry for the interruption. So we were speaking about time in range. So anything between 70 to 180, we call it as a target range, that is time in range. And more than 180, we call time above range, and less than 70, we call it as time below range. So we should try to keep almost 70% of the blood glucose in the time in range, and less than 20 to 25% time above range, and as low as possible in the time below range. So we will see what is the criteria for time above range, time in range, and time below range. Yeah. So what if the blood glucose levels are not in the time in range? So studies have shown that time in range deranged by 10%, it increases the retinopathy risk by 64%, and nephropathy risk by 40%, and neuropathy risk by almost 25%. So these are all the microvascular complications, classical teaching, and for microvascular complications to develop, it needs longer time. So we need much longer data to comment about with respect to time in range. But the initial evidence also shows the increase in the surrogate markers of macrovascular complications like abnormal carotid intima media thickness if the time in range is deranged, if it is not in the normal range. So we will look at the global recommendations on time in range. So time in range is relatively a recent concept. So with the advent of CGM, that is continuous glucose monitor, so the criteria for time in range has been established, and only in 2019, ATTD, that is Advanced Technologies and Treatment for Diabetes. So it set the international consensus on time in range, and in 2019 ADA supplement, CGM increases the treatment satisfaction and increases the time in range was proposed, and in 2020 ACE and ACE suggested that continuous glucose monitor assists in reaching the glycemic goals safely, and in 2021 ADA has recommended that CGM as an important tool for hypoglycemia prevention. So the ATTD 2019 recommendations for time in range for different diabetic populations are as below. So for type 1 and type 2 diabetes mellitus in the normal population, not in the high risk zone, so we should keep the time in range in approximately more than 70% of the time. It should be in the time in range, and less than 25%, it should be time above range. It can be time in above range, and we should try to minimize the chances of hypoglycemia, and we should try to keep it in less than 4% of the time in the time below range. So for the high risk population or the older population, the time in range can be at around 50%, and time above range can be at around 50% of the time. And we should try to keep again the time above range less than 250 in even in the very high risk population. And we should try to see that there is no hypoglycemia in very high risk population, because hyperglycemia is slightly acceptable but not hypoglycemia. So we should keep in less than 1% of the time. So with respect to pregnancy and type 1 diabetes, the time in range is should be more than 70%, and time above range less than 25%, and time below range again less than 4%. And in the gestational diabetes mellitus, or those who have pre-existing type 2 diabetes mellitus, those who become pregnant, so we should try to keep time in range more than 85%, and less than 10% of the time in the time above range, and less than 4% in the time below range. So this is the recommendation by the ATTD and again supported by ADA regarding the time in range for different population. So ADA recommendation says that the time in range, as we discussed, it is associated with increased risk of microvascular complication, and it can be used for the assessment of glycemic control. And additionally, the time below target and time above target are useful parameters for the re-evaluation of treatment. So we will speak briefly about time in range with the basal insulin therapy. So in the clinical practice, it is not always possible to put the patient on CGM and to monitor the data, either because of the cost constraint or because of the lack of awareness or the education. There are multiple factors which plays out during the clinical practice. So we should try to put the patient on a medication which maintains the blood glucose in the normal range and reduces the risk of hypoglycemia and prevents the glucose exertion. So the patient who fit in the above criteria, many of the patients can be put on basal insulin, and which reduces the glycemic variability and again maintains the blood glucose majority of the time in the time in range. So when the basal insulin is initiated, so it reduces the glycemic variability. It takes care of the peaks by controlling the fasting blood glucose, and after that we can add the medication which target the postprandial blood glucose effectively. And again, the basal blood glucose, basal insulin, it reduces the drugs. It, as we have seen in the previous studies, it lower risk of hypoglycemia with the glargine compared to the NPH insulin, and lesser variation of blood glucose with the glargine versus the premixed combination. So we will see the comparison between the generation 2 basal insulin in the light of TIR. So this is a euglycemic clamp study. This is the gold standard study basically for comparing the studying the pharmacokinetics and the pharmacodynamics of any insulin. So with this study, they have compared glargine 300 versus the degludec insulin. So in both the groups, 0.4 unit per kg insulin was given. So it was seen that with the glargine 300, there is 20% lesser within day variability compared to the degludec. So this is another study, again a clamp study, which basically compared glargine 300 with the degludec. So with the glargine 300, there is 22% greater insulin peak with the degludec versus the glargine 300. And glargine 300, there was 23% lesser within day variability compared to insulin degludec. So when we compare the glargine 300 versus insulin degludec in the CGM study, so this is a study where 30 type 2 diabetes mellitus patients were taken, and they were on once daily glargine 300 or degludec, and with the CGM we could calculate the percentage of time within the normal range, time above range, and time below range. So in this study, which was published in Journal of Diabetes Investigation, it was seen that there was no much difference with respect to time in range, whereas for time below range, so the glargine 300 was much superior compared to the insulin degludec. As you can see in the figure, so anytime hypoglycemia was much less statistically significant compared to insulin degludec. Nocturnal hypoglycemia again was lower with the glargine 300 compared to insulin degludec, and the incidence of severe hypoglycemia again was much lesser compared to insulin degludec. Means to say, for time in range, both the insulins are almost similar, whereas for time below range, the chance of hypoglycemia is lower with the glargine 300 in this study. So with the flash glucose monitoring, again, a similar type of study was conducted, where you can see that the percentage of time in the nocturnal hypoglycemia with the glargine 300 was much lower than the insulin degludec. So this is real world evidence in type 1 diabetic patients using CGM. Basically, they compared glargine 300 versus insulin degludec, those who were on basal insulins. And after that, they were switched to either glargine 300 insulin or insulin degludec. And there were 104 patients in the glargine 300 group and 95 patients in the insulin degludec group. And both the groups were almost matched with respect to age, duration of diabetes, HbA1c, and the daily dose of insulin. So the primary endpoint was percentage of time in the time in range, and secondary endpoints were percentage of time above range and percentage of time below range, and again the safety parameter. And the results have shown that in the daytime, there were similar time in range, time above range, and time below range profiles between glargine 300 and insulin degludec. Whereas nighttime, as you can see in the chart, the time in range and time above range were much superior with respect to glargine 300 compared to insulin degludec. As you can see in the bar diagram, in the bar diagram, the insulin degludec, the time in range were statistically inferior compared to glargine 300, and time above range also, the chances were lesser with the glargine 300 compared to insulin degludec. So the key message from this talk is that glycemic variability and time in range is associated with increased risk of severe hypoglycemia, diabetic complication, and reduced quality of life. As time in range is important, yet seldom measured, as discussed because of the variety of reasons, it is recommended to go for treatment solution which take care of TIR, that is time in range, even though not regularly monitored. Second generation basal insulin demonstrate improved glycemic variability than other insulin regimens. And among second generation basal insulins, glargine 300 has demonstrated lesser risk of hypoglycemia during the titration period and better time in range profiles. So with this, I will conclude my talk, and I will once again thank the organizers for giving me this opportunity to speak on this topic. And if there are any questions, it is open for discussion.
Hello, thank you, doctor, for the very lucid presentation. Now let me introduce Dr. Lakshmi Gowda, Associate Professor of Medicine and heading Endocrinology Unit, MMCRI, Mysore, Academic Chairman for successive 3 years. And you will be speaking on basal insulin optimization approaches over last 2 decades in India. Over to you, sir.
Good afternoon, everybody. Am I audible?
Yes,
Am I audible?
Yes, sir. Yes, sir. Yes, sir. You're audible.
Slides are visible?
Not yet.
Not yet,
Not
sir.
yet, sir. You should share it.
Not yet?
Not yet, sir.
Okay.
Sir, share screen.
Sir, share screen.
Okay, okay.
ADORE question answer and birthday.
Where can I? Okay.
Bottom center button.
Yes, sir. Here. Sir, wait, I do. Share screen.
ಮೇಡಮ್ ನೀವು ಮಾಡಿದ್ರೆ ನಿಮ್ದು ಬಿಡೋದಿಲ್ಲ ಆಗೋದಿಲ್ಲ ನೀವು ಮಾಡಿದ್ರೆ ಅವ್ರು ಮಾಡಕ್ಕಾಗುತ್ತೆ
ಅಲ್ಲ ಅಲ್ಲ ನಾನು ಮಾಡಿ
ಹೇಳ್ತಿದ್ದಾರೆ
so any confusion still?
the question next. Take up the question.
So you're on mute, Dr. Lakshmi Gowda, sir. You're on mute.
Sri Harsha, you are there? Sir, you are on mute.
Sir, can I help you to navigate? Yeah, there you go.
ಇಲ್ಲಿ ಬರ್ತಲ್ಲ ಇದು ಬೋರ್ಡ್ ಬರ್ತಲ್ಲ ಇಲ್ಲ ಇಲ್ಲ ಮೇಲೆ ತೆಗಿ ಒಳ್ಳೆ ಮೇಲೆ ತೆಗಿ ಅದರ
Sir, you need to go to your PPT.
Okay, one minute.
Yeah, right. Please allow it.
1 minute.
Yeah.
ಶರತ್ Is it visible, madam?
Yes,
Yes,
sir.
yes, sir.
You're all
Thank
good.
you. Sorry for that.
Sorry for the delay, but we are on time. Go ahead, sir.
First of all, thank you very much for giving me the opportunity to speak on this dais. I thank you once again, Sonapi, as well as ADORE team for having given me the opportunity to talk in this podium. So today is my talk is evolution of basal insulin optimization approach over 2 decades in India. So let us understand how the basal insulin initiation in diabetes management. So all of us know insulin is the very important treatment option to achieve glycemia after failure of all oral OADs and all of those things. So do this, what option to have to give optimal glycemic control without hypoglycemia? That one dose fitted to all. Conventional approach to decide basal insulin initiation dose depending upon 2 things. One is the HbA1c level and the body weight. Look at this. Anything HbA1c less than 8, the requires optimal dose, initiation dose is 0.2 unit per kg. If it is HbA1c is more than 8, it is usually 0.3. Invariably, our patients belongs to this group 60 to 75 kg. Invariably, it needs 10 to 12 or 14 units initiation therapy. This is what after this, you have to titrate to optimize, achieve hypoglycemic control. So what are the recommendation on basal insulin initiation Indian expert opinion? So this is a very, very important. The two expert opinion, one is B Smart expert opinion and Delphi expert opinion. So what they say? So look at this. The basal only regime, most convenient initial insulin regimen. The dose is almost 10 units per day or zero point 0.1 to 0.2 units per day, depending upon the degree of hyperglycemia. If hyperglycemia is more, you can use 0.2, or hypoglycemia, very small dose can be initiated, or 4, 5, 6 units, whatever it may be. The open door patient communication helps to achieve good glycemic control and also reduce complication and improve quality of life. This is one thing. And this is Delphi expert opinion also. It is similar, but 8 to 12 units of basal insulin ideal initiation. Start with very small dose, like 4 to 6 units. This is a very, very important. Starting very small units, especially in remote village people, very illiterate people, starting the hypoglycemia cannot be addressed immediately. This is the ideal dose to start with. So first 2 weeks or 3 weeks, whatever it may be, 4 to 6 units is the ideal. Then ask the patient to follow up with 1 to 2 weeks after initiation of insulin, assessing need of titration. This is that is what starting at low dose is acceptable, provided there is no subsequent systematic and sustained dose of titration. So what are these? Look at this case scenario. This is a very, very common case scenario you come across already after some OADs and 3 or 4 OADs and insulin, glargine, 10 units, bedtime, all these things. Till after 6 months of evaluation, still HbA1c is 8.5 and fasting is 175, postprandial is 230, some dyslipidemia is there. In this study, in this patient, what are you going to do? Should we consider increasing basal insulin dose? Yes. Then how many units? This is a very, very important aspect. How do you go with? How do you achieve glycemia? How do you achieve HbA1c less than 7? It's a very, very important part of. Look at this slide. This is a very interesting slide. Look at this. So this patient almost comes with 9.3 and 211 of fasting glucose. Start with 8.5, 8.6 unit initially. Over a period of 24 weeks, they achieved gradual increase of insulin up to almost 14 units. So they achieved over the end of the 16 hours 6.6 of HbA1c and 113 of fasting glucose. It's a very, very important slow and steady. After 4 weeks, 8 weeks, 12 weeks, every month, slow and steady. Okay, so incremental increase of basal insulin is a very, very ideal to achieve. This is what this slide says. So, glargine dose and fasting plasma glucose and observed in the patient achieving HbA1c with a glargine dose of almost more than 8.5. That means minimum requirement of this one, glargine is required is more than 8.5. You can anywhere between 14, 16, whatever it may be, depending upon the patient's response. So what is the significance of being a glycemic target in current scenario of the COVID-19? You are all evidence and witnessed what is COVID, what is the mortality and morbidity. After especially patients uncontrolled diabetes, came into the hospital admission and all. So all these studies, these are all Chinese studies, Yang, Gao, and what all studies. What they experienced is the poorly controlled versus well-controlled diabetes, the ARDS, acute kidney injury, and heart failure. Almost significant, almost 50 to 80%, 100% more. ARDS, look at ARDS, almost 14.8% versus 7.2%. Acute kidney injury similar is 3.2, 0.4. Acute heart failure also 6.8 and 1.8. What it says. So adequate glucose control is a very, very important part. So especially in the acute management, especially ICU management, all of us know, especially in COVID. So what is the lack of insulin titration is the prominent cause of poor glycemic control. Evidence says from global and national studies. So that is a national health and nutritional education so study as well as IDMPS. International Diabetes Management Practice Study. What this says, achievement of glycemic goals less than 7 was suboptimal among adults with diabetes. All of us know, even with whatever said and done in all clinical practice, hardly 30 to 35% people achieve less than 8.7. All of us know. then almost half of the study population did not reach glycemic goals. And similarly, IDMP study also shows glycemic goals targeted by treating physician achieved by 32.1% of type 2 diabetes. Lack of insulin titration was perceived to be a prominent cause of poor glycemic control. So what are the lack of insulin titration as a prominent cause of glycemic control? Evidence from global nutrition studies. So top 5 physicians perceived these are all the causes for the bad euglycemic control. Look at this: the patient reluctance, unwillingness to consider basal insulin treatment, the patient non-adherence to the existing medication regimen, patient inability to self-monitor their blood glucose with sufficient frequency is a very common mistake that they do. Patient concern about out of packet card is also one of the important issue when patient is very poor and come from village. Patient lifestyle, including diet and exercise, these are all things. The most important surveys, the barrier is the most important is so the patient cannot escalate the insulin dose according to the need. This is a what is. What is it mean by titration inertia? Is a reality? Is a reality or is it a let us look at this. The titration inertia means a key barrier to achievement of desired glycemic control with insulin therapy. What is that? The first and foremost is progression of type 2 diabetes and increase also of comorbidities eventually necessitate insulin therapy in the majority of the individual. All of us know. Despite use of insulin therapy, large prospective studies have shown that the clinical practice desired glycemic control is not routinely achieved. All of us witnessed, only 30% people achieved. Insufficient dose adjustment of insulin is termed titration inertia. This is very important. Starting dose is not sufficient, so adequate dose. So the periodic incremental dose of insulin, basal insulin, is a most important part to achieve euglycemia. And the last one is suboptimal insulin dose titration is a key barrier to achievement of optimal insulin therapy. This is a very important, all the 4 most titration inertia. So what are the factors contributing to titration inertia is according to the reluctance by healthcare physician as well as patient. This is very true. So many people say hesitant to titrate the insulin because of fear of hypoglycemia. And most important, weight gain, the fear of hypoglycemia, and lack of flexibility. Complex titration algorithm. Some if you start a basal bolus 4 times insulin, definitely the patient complex titration algorithm is there. And lack of constant self glucose monitoring. Self monitoring is most important. You have to address the patient with a self monitoring, very important. So that is why timely and proactive follow-up is a critical for successful dose titration to overcome the titration inertia. This is what very important factors you need to address to titrate the insulin dose. How do you address the unmet need of hypoglycemia risk with basal insulin? Basal insulin was a premix insulin. Hypoglycemia. Look at the hypoglycemia. It's almost 2.8 in the glargine, and premix insulin is almost 13.3%. You look at this, the same thing, 50% lesser risk of overall hypoglycemia with a glargine compared to premix insulin. See, another important aspect. This is a very important and need to in basal insulin in glargine hypoglycemia is a very less. Similarly, look at this. Basal insulin was a co-formulation insulin. Hypoglycemia, almost gas and glargine, is significantly difference is their hypoglycemia. And similarly, right side, the patient achieved HbA1c less than 7 without confirmed hypoglycemia is much more in a glargine. Look at it, 23.5 compared to gas is 20.9. So that is what the overall confirmed hypoglycemia rate was significantly higher with gas once daily dose. So addressing the unmet need of titration algorithm complexities with basal insulin are, look at this, these studies says, if you go with the stringent up-titration algorithm, reason behind hypoglycemia with the basal insulin, inside, landmet and did all these things, they said, so more aggressive insulin dose adjustment or titration leads to higher rate of hypoglycemia. This is what? And from stringent and simpler algorithm evaluation of up-titration of strategies with basal insulin is very important to combat this hypoglycemia episode. Look at this. Focus on up-titration insulin glargine for optimal glycemic control without pushing the patient so much as the cause of hypoglycemia. This is what use glargine with a simple algorithm with an active titration leads to significant improvement in glycemic control with the people type diabetes. What is that? This is a very, very important slide. The patient-centric basal insulin up-titration strategies, recent Indian expert opinion. Look at this. Recommendation are, if it is fasting glucose between 80 to 130 or 3 times our average, no need of change of basal insulin. If it is less than 80, reduce to 131 to 160 or 2 and 161 to 180 or 4, more than 180 or 6. This is the simplest. Okay, either it depends upon lowest fasting glucose or mean of 3 sample of fasting glucose. If the mean of lowest and mean, if you adjust this, you can prevent hypoglycemia. This is very, very important. And SMBG and basal insulin titration during COVID-19 pandemic, this is what you're doing. Okay, so the continuous monitoring SMBG at least twice a week is very, very important. R2 plus, R2 minus, depending upon the glucose target, less than 120 is achieved. Initiation with 2 weeks of insulin titration, especially in COVID pandemic. Does patient empowerment facilitate target achievement in Indian setting? Definitely, yes. Look at this. This slide shows patient-led titration arm. This one. Blue is physician-led titration arm. Look at this. The both are. So definitely greater decrease of HbA1c and fasting plasma glucose in physician-guided patient lead titration group is much more than physician, because it's a patient-oriented. Patient can do SMBG, he can titrate as early as possible, even 15 days, 1 month, whatever it may be. That is what this says. Patient-centric, guided by physician, the titration is better than all what physician spent. So what are the barriers to patient-centric approach in India? Look at this. You have to address these. These are the barriers. Low levels of awareness among the patient, low rate of adherence, and constraint of patient time and resource, insufficient glucose monitoring using self devices. The developing education self-management program using simple titration algorithm essential for optimizing the clinical outcome of people with diabetes. This is the barriers to patient-centric approach you need to address when you're treating the patient. How do you implement? Implementation of patient-centric approach in India, the possible solutions are: the importance of SMBG has been highlighted by both national and global guidelines for effective glycemic control in the people of diabetes. This is very, very important. Self-monitoring is a very, very important. That is what you have to educate, you have to encourage self-monitoring of the blood glucose for each and every patient. Lack of structured patient education and patient support program amplifies the challenge of optimal dose titration. To encourage better adherence to insulin therapy, the patient support from the providers, diabetes support program should be promoted, and all other things you have to titrate according to that. Developing simple titration algorithm will help optimizing the basal insulin therapy. So these are the barriers. You have to break this barrier to patient-centric approach. So at the end, key messages: titration inertia due to fear of hypoglycemia and weight gain leads to inadequate insulin up-titration and poor glycemic control. Systematic yet patient-friendly dose of titration strategies with a basal insulin help to achieve glycemic control. And simplicity and convenience, once daily regimen with basal allow patient to empowerment of effective insulin dose management in Indian setting. With this, I'll thank you once again, all of you, for having given me opportunity, and thank my sir, Shekhar sir, my mentor, my sir, my teacher, my professor. Thanks for joining, sir. I always adore because he is a main mentor of all my studies and whatever today I am, because of Shekhar sir and Shekhar like my teachers. Once again, thank you, sir. Thank you very much. If any this one you have to correct, please. Thank you. Thank you once again.
Thank you,
Over
Dr.
to
Gowda,
Dr.
for a beautiful message what you gave regarding the glargine. What is your personal experience, sir? Without CGM monitoring, what is the titration? How you are handling your patients?
That's what, sir. Only this, what is this? At least it is not everyday monitoring. At least once in 3 months, once in 2 months, whatever it may be. Sir. If a patient is self-monitoring glucose, you have to take average of 3 low level or average of 3 days fasting glucose. If it is, you have to achieve at least 80 to 130. And also you have to look at the HbA1c level. If HbA1c level is not achieved, incremental dose, as I already said, incremental depending upon the what average of 3 days fasting glucose and HbA1c, depending upon that, you have to adjust.
Okay, sir. Any questions? Sir, one more question. How do you differentiate between the hypoglycemia by 2GO compared to the other basal insulin, sir?
Definitely hypoglycemia with glargine with optimal dose is a very minimal, sir. According to my patients, a lot of patients are taking, so very minimal according to the compared to basal bolus or mixed insulin. Okay, basal mixed insulin, basal bolus, all these basal insulin with glargine definitely is low.
Okay, sir. Thank you, sir. Can I ask Dr. Hegde a question?
Yes, sir.
Hello. Hello.
Tell me, sir.
Sir, how can be TAR possible to measure in the practical situation, sir, if there is no CGM possible for all the patients?
Means to say you are speaking about time in range, how the patient is faring with
Yeah.
the
Yes, sir.
the best way in Indian scenario will be to train the patient to self monitor the blood glucose. Usually, I train them depending on the insulin regimen, of course, to check the blood glucose fasting, pre-lunch, and pre-dinner. If the majority of the readings are in the normal range, then patient is doing fairly well.
I take this question on behalf of Dr. Hegde, which I can throw some more light using different technology, and Dr. Shekhar is here, and we appreciate his comments on the same. What we do is now we have a lot of apps which help you to calculate TIR by using your glucometer reading. Or even all of them are open source. If you can upload, depending on the glucometer they use, these are all free. You ask, now they have an instant TIR. Whenever they measure the blood glucose, if they enter it into this app, once they come to you, it can give you a TIR range depending on whichever day or time of the day which they enter. But I'll go one step further. We've developed something where it talks to the EMR. Meaning, if you have the patient in the EMR, whenever he enters the blood glucose reading, it goes into an app, it goes into the EMR directly. So whenever, if the patient comes back to you at the visit whenever he's coming, it also gives an alert. If it goes below 50 or 30, there's a critical alert both to the doctor and to the patient. This is using technology. Just by using simple glucometer readings, we're able to calculate this TIR. The pilot we've already done, and then using it with one type of EMR, which we have working the last 6 months. So this, by just using the, I know and understand now the abort personal has become more expensive than the Libretto, which was earlier there, which used to cost $2,500. If you want to do a continuous glucose monitoring and have a reading, now you need to spend $15,000 to $20,000, buy 4 of the sensors and 1 reader to do continuous glucose monitoring with the TIR. Simple algorithms, and using technology, you can definitely get the TIR of this patient and also look at the blood glucose profile as you go on. So if anybody is interested, you can contact me. I can help you out.
Thank you for the information, Dr. Reddy. Sir, Hegde sir, what is your personal experience with the 2GO in TIR?
You're asking the question, sir. Is it for me?
Yes, sir. Shall I repeat the question, sir?
No, question I got it. So
Yeah.
basically, definitely as shown in the studies, even my experience correlates with the same. So with the 2GO, the chances of hypoglycemia is much lesser. So basically, I prefer that insulin whoever is available and whoever is elderly and frail type of individuals where the chances of blood glucose fluctuations are much higher. And of course, in the type 1, it is better. We get better results with the glargine 300 compared to glargine 100.
Okay. So, thank you, Dr. Hegde. So, if there are no questions, I thank both Dr. Hegde and Dr. Gowda for lucid talk. We can end this session here. Thank you very much.
Thank you, sir. Thank you, Dr. Hegde, Dr. Suresh Krishna, and Dr. Lakshmi Gowda for this talk on time and range and basal insulin optimization. Now, I would ask our Dr. Pooja to take over and go on to the next session. I think Dr. Shekhar, who's the moderator for the next session there. Before that, we would like to thank the sponsors of the first symposium, Sanofi, for their contribution towards making this symposium possible. Now, we have a couple of minutes before Dr. Rajpal joins us, and I'm handing over the session to Dr. Rajpal has joined. So, over to Pooja to introduce us.
Good afternoon, everyone. Welcome, Dr. Shekhar, sir, to today's session. Dr. Shekhar, MA, former professor of medicine and head of the department endocrinology, MMCRI, Mysore, consultant diabetologist, Apurva Diabetes Foundation, Mysore. Welcome, sir. Over to you, sir.
Thank you. Thanks a lot for this opportunity. I should say good afternoon, or we are in the last leg of the afternoon and going into the evening part. So good afternoon and good evening too. It's my pleasure to be a part of this ADORE 2021 and this Novartis sponsored diabetes symposium, where Dr. Rajpal Singh and I will be, talking about the concepts, certain concepts in diabetes. And also it's my pleasure, my personal pleasure, to introduce Dr. Rajpal Singh. He is a senior interventional cardiologist and heart failure specialist from Fortis Hospital, Bangalore. He was interventional cardiologist at Wolverhampton Heart and Lung Center, UK, and is a recipient of the prestigious European Society of Cardiology WG10 Interventional Fellowship for 2005 and 2006, and recipient of Clinical Excellence Award, the National Health Services 2011. Great pleasure to have you, Dr. Rajpal Singh. And he will be talking on heart failure in general, HREF, and the bidirectional activity of diabetes and heart failure. I would like to invite Dr. Rajpal Singh to go ahead. Thank you.
Is Dr. Rajpal Singh there? So I think there is some, I don't think he's logged in as yet. We're trying to get hold of him. So we'll wait for a couple of minutes. Meanwhile, we can continue a dialogue. And if he's not coming in, I would request you to move on to the next talk, which is talking on game for improved evidence. And probably Dr. Rajpal will join. We'll give him, because it's 2 minutes past this time. I think there's somebody's logged in for him. We're not sure who it is.
We still have about 1.5 minutes to 3:20.
Wait for him. So before that, just going into, we'll put in a dialogue and say, so let me start the conversation. Now, we have moved about, what's interesting in the last decade or so, and I know you've seen more decades than me. They've taught so many people on how the evolution of diabetes practices and the understanding of pathophysiology of diabetes has changed over the years. We have moved from glucose-centric approaches from different organizations and different guidelines which were targeting only HbA1c, HbA1c is this much, you do this too. Now guidelines talking about you have heart failure, cardiovascular disease, you have renal dysfunction, more so based on comorbidities and diabetes. What is the next line you would see in an AD algorithm or an RSSDI algorithm? Now, there's so much of talk on heart failure. So I was very interested in one of the slides that said, okay, now you have heart failure, renal dysfunction, if weight is a concern, cost is a concern, and the next one I want to see is NSLD and what we do. So probably next is, and there's so much of change which is happening in different molecules probably flooding and also becoming affordable, and that's the key, yeah, especially in our country. How do you think this is going to? Just your opinion. I know I regard your opinion as one of the best in the country, so I would look forward to see how, in your thought process, what else would you be saying before you start off with adherence, which is very key thing. Or before Rajpal talked about, Rajpal is going to talk about heart failure.
Okay.
You never thought about heart failure and diabetes. Actually, 5 years ago.
Sanjay, you're always in the global perspective of diabetes. I'm very happy that you have brought up a very, very important insight that all physicians, astute physicians should have. My personal feeling, let me experience, the experiences that I have, let me share. When you remember, diabetes became a very important disease entity or a disorder entity in the field of medicine. It started as saving lives. A diabetic tried to save life. Slowly, there was a divergence into microvascular and macrovascular diseases. And in microvascular, again, it diverged into so many concepts of nephropathy, neuropathy, retinopathy. Macrovascular, you know the story. But post 2008, the divergence that happened, save lives, prevent complications, then save lives, then prevent further deterioration. Now time has come, they're all coming together to a concept of saving life again. Doesn't matter. So when you look at kidney failure, they can go on and for many number of years. It's my personal feeling that I'm trying to talk about it. Please do not mistake the way I said it. People who have neuropathy can go on and for that, but heart failure is an end of the road concept. So if you ask me, you should put a little bit more stress on heart failure and the bidirectional disease of diabetes and heart failure. That's it. But having said that, you already mentioned, I will be talking in this thing, but let me preempt here. Extraordinary research has occurred in the field of diabetes in 3 major fields, if you ask me. Pharmacology, as far as physicians are concerned, as far as the patients are concerned. In pharmacology, bioequivalence, PK/PD, etc. And due diligence has occurred with every drug that has been put into market in these reasons. And as far as physicians were concerned, safety, efficacy, etc. came in. And they have come in? Dr. Rajpal is here?
No, sir, no, sir. Please go ahead, sir.
And as far as patient is concerned, resource setting, there, you know the story, the 6 concepts of education level, not literacy level, then resource setting that they live in, their ability to buy, compliance, etc. like that. But when it comes to putting them all together in a single basket, let's not worry about the pharmacodynamics and kinetics of the drug, because it's extremely well suited for all the drugs we are using. Let's not worry about safety and efficacy. Almost every drug is safe enough and efficacious enough. The time has come to worry about the patient activity. We really have to focus on what patient goes through. I keep telling my youngsters, in a 24-hour period, when a patient visits Sanjay or Shekhar or Arvind or whoever, they spend 10 to 15 minutes. Next 23 hours and 45 minutes, they have to spend with themselves. It's time we focus on how to improve the patient activity when he or she lives with diabetes. And foremost in that is not a resource setting. Somehow we can manage to get them drugs, but it is compliance and adherence. How to make them.
Sir, I'm working in that area which I'll discuss with you. Once you finish your talk, probably share some interaction. I think Dr. Rajpal has joined. If Dr. Rajpal has joined, Dr. Rajpal, over to you. I think Dr. Rajpal Singh has joined. We have introduced Dr. Rajpal Singh. So,
welcome, Dr. Rajpal. I've already introduced you.
Dr. Rajpal, are you there?
I'm here. Give me a minute.
Okay.
There's some issues with
Yes, go ahead.
Let me just find the document. Okay.
Dr. Sanjay?
Hello, sir.
Sanjay,
I think there is a problem with Dr. Rajpal's.
What we will do, I'll go first.
And then you can ask.
Some breathing time for Rajpal to come later.
Yeah, that I think that we can do, sir. Right, sir. Please go ahead, sir. Dr. Rajpal, we'll have Dr. Shekhar speaking.
Yeah, that will be great because I think I just have a slight problem with my
I think we'll
opening
do that.
up my net. I'll do that. Yeah, you can start off, sir. I'll join.
Okay, thanks. Shall I? Okay. My slides are visible, right?
Yes, sir.
Yes, sir.
Right, thank you. Shall I go?
Yes, sir. You're good.
This symposium is about how to enhance adherence in your type 2 diabetic. And let me come to it further down the slides. My disclosure. Now, this would be the timeline for me. I will take about 15 minutes, hopefully. Introduction. Diabetes is a major concern among Indian population, not in the world or in South Asians. Failure to achieve adequate glycemic control, lack of adherence, and Galvez OD as a concept to put all these three into perspective. Let me explain here why diabetes is a major concern in Indians. We all know it's a major concern all over the world, wherever you are. But what are 1 or 2 points that makes it a very big concern in Indian setting? Then why there is a failure in achieving glycemic control after 30 years of all sorts of tight RCTs, etc., talking about 7%, 6.5%, etc., like that. And probably one of the major reasons is adherence, lack of adherence, and how Galvus OD, once a day dose of vildagliptin, fits into this scenario. Okay, this would be my talk about this. And we all know India has seen an exponential increase in number of people of diabetes in the past 20 years. Hands down, we will have to accept that. But why is the question? Probable answer has been South Asian phenotype. You all know South Asian phenotype. They are not very obese, normal BMI, or even sometimes lean individuals, but they have high triglycerides, low HDL, and high glucose, especially so postprandial. You all remember Monier's concept of HbA1c. Lower levels, postprandial, higher levels, fasting components. But in India, postprandial definitely has, whether it is on the lower level of HbA1c or higher level, it has a say. In other words, postprandial hyperglycemia, most probably the dietary habits of South Asian people, especially so Indians, has it got a connotation to make India as one of the capitals of diabetes? We all know about it. But issue is, urban South Asians are 5 to 9 times more likely to exhibit dysglycemia and dyslipidemia in the healthy BMI range. We think they are healthy as far as BMI is concerned. They do not have a tummy, their weight is fine, etc. But still, 9 times at worst and 5 times at best, dysglycemia and dyslipidemia. You have to accept this. That's why it has become a major problem in India. In addition, Indians are predisposed to increased clinical and biochemical measures of insulin resistance. They have increased predisposition to insulin resistance, down the road insulin deficiency, and higher levels of postprandials, and highest global rates of pre-diabetes progression to type 2 diabetes. Got it now? Why India has a major problem with diabetes, South Asian phenotype, higher dysglycemia and dyslipidemia. As an Indian, increased clinical and biochemical measures of insulin resistance and systemic inflammation, though they are not fat. You know, obesity is inflammatory, but not being obesity also higher chances of systemic inflammation and much faster conversion from diabetes to diabetes. This we have to really swallow our pride and accept it and move forward. Type 2 diabetes onset, the second paradigm, the double whammy, single whammy, I've already said. The second whammy that has occurred is, it occurs nearly 20 years before a Caucasian counterpart. If it is 40, 45 years, it can be 30, 35 years in India, or probably a little bit lower, 50 years and 30 years. So it occurs much earlier in Indian setting. That means they are diabetics at much earlier age when they are very active and they are exposed to hyperglycemic milieu for a longer period, leads to chronic vascular complication and psychological morbidity. Young onset diabetes. The second negative point, or double-edged sword, or double whammy we talk about. This third or triple whammy that we face in India is more than 61, nearly 61% of type 2 diabetic patient load in India are above the age of 60. Number one, they are at higher chance of getting diabetes because of 1, 2, 3, 4 I just mentioned. Number two, they develop diabetes at a much younger age. Number three, more than 60 years, 60% of them are above the age of 60 years. They've already reached 10, 20 years of diabetes and they are above the age of 60 thanks to the medical assistance that we have been giving. But this has made a very major paradigm shift of getting into trouble as far as micro and macrovascular complications in type 2 diabetes. This is the fertile setting that I would like to go further. And the second paradigm that we have to understand is nearly 45% of type 2 diabetic patients fail to achieve adequate glycemic control. Short term, long term. Short term, probably very short term, we can achieve glycemic control. Give 6 months, 1 year, many of them start moving up and down. Longer term, nearly 45. In other words, 1 out of 2 type 2 diabetic patients are not in adequate glycemic control. You know the story: increased risk, morbidity, mortality, emergency room, outpatient costs, all the things add on. Last would be adherence. Is the single most important modifiable factor. Why? Because why are they not in adequate glycemic control? Not because the drugs are not efficient, drugs are not safe enough. It's because of adherence. They need to take it 30 days a month or 31 days a month for 12 months, 7 days a week. You know the story. And adherence has become a major problem, which we have to really focus and address in a very nice manner. For this, you need the patient as the leader and doctor as the guide. What are the factors that contribute to poor medical adherence? Treatment complexity, dose frequency, fear of hyperglycemia on one side, called as treatment burden. Treatment-related beliefs, perceived treatment efficacy and physician trust, perceived, educated people, Google doctor, all those WhatsApp universities, etc. But let's take out this and focus on treatment burden of treatment complexity and dosing frequency. And of course, with the newer drugs like SGLT2 inhibitors, DP4 inhibitors, fear of hyperglycemia has significantly come down. But treatment complexity and dosing frequency remains still a bugbear for adherence. Increased dosing frequency, decreased medication is a simple equation. You have to give it 3 times a day, medication adherence comes down. Twice a day, it is a little bit better. Once a day, very good. 3 times a day, or rather once in 3 days, probably better. Once a week, still better, but let me tell you, it's a J-shaped curve. Once a week, they may forget every week. They may take it 5 days or 10 days later. So it makes great sense when a patient is very happy to take once a day for best medication adherence. With this concepts of why we are getting into trouble in type 2 diabetes and why at least 50% or 40% of our type 2 diabetics are not under adequate glycemic control for a longer period. We'll have to address the medication adherence by whatever means. I told you, patient-centric, patient leadership is very important, for which we have to act. We have one solution, Galvus-OD, once a day concept. This is beyond me. Dr. Sanjay will explain it probably at the end of the thing, but simply put together, modified release formulations, vildagliptin, work. It works for 24 hours. Expanding the vildagliptin legacy OD formulation. We all know BD or IR, vildagliptin instant release 50 milligram tablet BD. Vildagliptin 100 milligram modified release once a day. Are they equal? In what? The pharmacological PK/PD study, physicians' safety and efficacy, and patients' perceived concept of adherence. Does it fit the bill? We have to look at it. Look at this. Mean plasma DP4 inhibition of vildagliptin was 91% and 95% with MR and IR formulations, respectively, at steady state. Day 1, day 6. When you look at that steady state from day 1 to day 6, 91 and 95%, very, very, very similar. If you ask me, they are very similar when it comes to mean plasma DP4 inhibition of vildagliptin, Plasma concentration, day 1, day 6, they are very, very similar. That's why their inhibition also is easily recordable. Is it proven similar safety? Yes, both formulations were well tolerated and found to be safe. Likely to be because 50 mg twice daily, lower dose, probably safer. 100 mg once a day, a little bit higher dose may not be safe. It is unlikely. Adverse events, clinical laboratory evaluation, vital signs, they are very similar, well tolerated and found to be safe. Both of them are safe. Vildagliptin 100 versus 50 when it comes to the diabetic subject's activity, inhibition, efficacy results. Safety is done, PK/PD is done, efficacy. Over 90% of DP4 inhibition was achieved with both formulation within 0.5 hours of administration. So, modified release, we think it's slower in action. Instant release is faster in action. It is over 90% of deep 4 inhibition within 30 minutes of administration. Efficacy means faster takeoff and a longer period activity. Safety results, both formulations were found to be safe. We have already mentioned about that. Similar in diabetic subjects, 100 mg OD, glucose area under efficacy or effect. We have to call it as AUC, we all know, area under curve. Area under effect is quite similar. Was measured to demonstrate DP4 inhibition with 100 mg OD comparatively. Both formulations demonstrate similar reductions in GLU-AUE over 24 hours, suggesting similar DP4 inhibition. This is another way of looking whether DP4 inhibition with 100 mg is as much as 50 mg twice daily. The answer would be yes. So to summarize, vildagliptin 100 mg OD, once a day formulation for better adherence, yes. Similar efficacy compared to vildagliptin 50 mg IR, yes. Similar tolerability and safety profile compared to vildagliptin IR twice daily, yes. In other words, safely you can give once a day vildagliptin and expect it to be safe enough, efficacious enough, and bioequivalence enough compared to 50 mg instant release twice daily. Why? South Asians, particularly Indians, have these triple whammy. Number one, they become diabetics because of their phenotypes. Number two, they are diabetics at an earlier age, exposed to higher blood sugar hyperglycemia for a longer period. Number three, 60% of people with type 2 diabetes in India are over the age of 60, where they have comorbidities and get into triple whammy concept. So with this, vildagliptin addresses safety, efficacy, and adherence. 100 mg OD. I hope I'm clear enough in my concepts. Galvus OD, an effective and safe mode of treatment for patients with type 2 diabetes, and may help improving adherence to therapy. May help will help probably after more and more people use it. Thank you. Yeah, can we request Dr. Rajpal Singh to come on? Unmute yourself, ready.
Yeah, sorry, sir. I don't think we're seeing him, so we can have a nice discussion if he's not there. But request somebody else also to join us till we go on with this. I think we can take on, we'll try and contact him, but anyway, I think he was here and he's not there. So nice, sir. Thank you very much for that nice talk. So just going on with sticking to adherence as one of the most important, and I like your talk focusing that our focus on the patient, the interconnect after the patient sees you in a chronic metabolic disease, the time after he comes to your clinic and before he makes his next visit, the duration he spent outside in between this is one of the most important thing in chronic care, which is not captured. Yes, could be adherence, could be adherence, probably some queries he has, something to do with medications. If it's insulin, there is something else. So these are many things in terms of his diet, whatever the issues which come in. Now, I think there's going to be a disruption in this space. We have never thought about it. And as doctors today, if we don't think about it, I think it'll be taken over by somebody else in between. So one of the important things was adherence. How to capture adherence on a day, to asking the patient whether he's taking the medicine rightly, whether he is. So some practical tips to everybody. And then I probably give you something new which is happening in that front to see if we can, if that's going to be a reality in future.
Okay. Let me tell you, it's not new because Germany was the first country, if I remember right, which brought this concept, and they developed a concept called as chronic care model. chronic care model, where how can we improve the resource setting so that we can help these people with chronic diseases like hypertension, heart diseases, cancer, etc., like that. And I urge many of the listeners to go through this chronic care model. It's fantastically done. And it has trickled into India with some of the companies trying to set up, what do you call,
Lines.
on-call
Helplines and stuff.
Helplines, correct. Helpline. That was the right word to use. I'm sorry. I'm an old man.
I forget better more than you said. It's okay.
But the issue is, when it comes to India, I'm proud and also probably a little bit frustrated to say Indians are totally different. Nothing works in India, which in the global setting works. Indians, as a patient, in the last 3.5 decades of my practice, they want it from the horse's mouth. The horse, unfortunately, is you and me. They don't want anybody else to talk to them about what to do. Helplines and others have not found any success. He has come back.
Rajpal, are you there? Dr. Rajpal? I don't know. I think it's frozen. Sir, you go ahead, sir.
Okay. So I've been telling my friends and whoever it is who asks me, and probably January 8th, we have from KRSSDA, the concept of empathy and compassion in clinical practice. So you need young doctors to get into this. Empathy and compassion in general is different. Empathy, clinical empathy and practical compassion is something the doctor should understand, which without our knowledge we have been doing. We need to go a little bit further. Simple concept I tell my diabetic patients is, I don't confuse them about the drugs that I'm going to prescribe. I don't tell them about, complicated matter of diet and exercise. The KISS principle, keep it simple, stupid. The stupid part is the doctor, not the patient. Keep it simple. Diet, 3 concepts: when to eat, what to eat, how much to eat. Exercise, simple walk whenever you want, 20 minutes 3 times a day or 40 minutes once a day, whatever. And when it comes to drugs, I tell them, please take your drugs. Doesn't matter, it is once a day, twice a day. We have prescribed you 3 or 4 drugs. Keep the 3-4 drugs in your mind. You want to color code it if you are a visual learner. You want to listen to it. If you are this thing, you can always record it, things like that. And over the last decade, it has given me very good results. In fact, I don't prescribe anything extraordinary from other doctors and all that. But since the clinical empathy that I bring into my clinical practice and the KISS principle I put in my clinical practice has given certain results as far as adherence and a better diabetes control is concerned.
So thank you, sir. I think that KISS principle is something I follow too, not to the extent with you, with your expertise, but to a certain extent. And we have Dr. Rajpal Singh who's logged in. I think we can. Dr. Rajpal, are you ready? Hello? Hello?
I see him.
Yeah, we see. Dr. Rajpal, are you ready to give your presentation? I don't know. I think it's net connection or something. Dr. Rajpal, are you ready to give in your presentation? Can we type out? Can you? Yeah, there is.
Rajpal, you unmute yourself.
Yeah. I think there's a problem with your internet connection, Dr. Rajpal. You need to unmute yourself, and if you're ready to give the presentation, we would love to listen to you. I think there is voice is breaking up. I think it's your internet, sir. Sir, you check your internet connection. Dr. Rajpal, our connections are fine. I think it's your internet connection.
You can ask them to send us slides. We can.
Hello.
Yes.
Surat,
We have the former people to.
no, you can see video. Comes, but I can't hear. I'm in my office. Hello.
Yeah, now we can hear you, Dr. Rajpal, if you can. I think there's some problem with this internet connection. Sir, can you share your slide so we can, and you can speak up if you take off your video, the connections will be okay. We can do that. Sorry for this, the technical disruptions. We apologize for the poor connectivity from one of our speakers, and sometimes it does happen to all of us. We rely on technology.
Sanjay,
Sir,
two often spoken phrases when it came to online activity was,
okay.
Am I audible?
You're absolutely audible, sir. Go ahead, sir.
No, I was just telling two phrases. Am I audible? My slides are visible. Audible and visibility.
Got me there.
But it's intermittent. No.
Anybody from Novartis? So what we can, sir, Dr. Shaker, sir. I think we can continue the discussion. This means.
I'm online. Hear you very. Yes, sir.
Okay. Now.
Can you hear me now? No, sir.
Even now, you're not clear.
And
going actually because audio is going and now slide is also.
it is also gone.
Yes, now it's coming, but it's bit distance. Yeah, continue, sir. Continue. Continue, sir. Yes.
Good afternoon, my
Continue, sir. Yeah, switch off. Yeah.
Noted.
apologies for ladies and gentlemen for I know that's internet. And stuff, and I have diabetes. As a comorbidity in patients, and we know diabetes, the risk factors, the presence of diabetes itself can confers an increased risk. About 25% of diabetics of chronic diabetics have diabetes. In fact, we have just operated on 52 because that and is only cardiovascular is the presence of diabetes for the past 11 years. Mechanisms by which diabetes acts, it's mainly the hyperglycemia insistence leading on to coronary more of cardio. Cardiovascular disease and as we do for a non-diabetic, the prokaryotic disease symptoms, thus leading myopathy. And once they pass that window period, of either thrombolysis, the onset of heart failure is demand and there is reduced supply cause and for an increased incidence of patients over the past 15 years. Hello. Well, yeah, that's the best we can do now. Presenting with ischemia. And its consequence. Now, we know that once you have heart failure, which is with reduced ejection fraction and independent risk in such patients is associated with presence of type. What are the outcomes? Control versus the outcome. The cardiac. Death. So it's something that is on the clinical outcomes of heart failure or mortality. That's cardiovascular mortality. But it's all wrong. It's not. Yeah. So type 2 diabetics, if you look at the data there, we don't talk much about heart failure per se, although should. It's important to unmask heart failure early to glucose. All these would have, they are not usually put under the process, and in general, isn't for to have a brachial ankle early. Now, if you look at the usually this gentleman is slump phase of exertional shortness of breath and a class 3 20 FR, which is of 1 point. Point 1, which again is good. Windows are quite high, 170 by a cardiologist or from a near. Now, when you look at the treatment option for the improving outcomes and also improving result. New drugs such as personal don't agree with that. For the it should like the first line drugs. The only key things to remember, oral drugs like atenolol, it can be used and remember the other thing that you need to go with or is the or the criminal anti-failure therapies such as XNP. That there is with these drugs, you have not more patients who are still symptomatic. So such as Vimada, or would you add SG SGLT2 inhibitors such as now, if you look like a patient like others days wherein you would start these patients recommended that you start an ACE inhibitor or an ARB inhibitor in all heart failure patients according to the American guideline.
Dr. Rajpal, we would like you to conclude the session because we're running.
Particularly so in patients who got NYHA class 2, class 4. And if you would ask me about, if you'd asked me Europeans with the RD drugs in the past 3 years, I feel the time has come now that when you've got a patient who's on an RD drug,
Dr. Rajpal, we request you to conclude because we're running out of time. Sorry to intervene.
okay, I've not started the video. No, man. Switched off. The video is already switched off. And if you likely make sure so that there is a washout period of at least on an who has been taking enalapril of more of less than grams, then valsartan on sacubitril valsartan twice a day. And after a check, they go on to 50 milligrams and then build it up. However, if you've got patients who've got good blood pressures and have already been on either enalapril or an ARB on a good dosages, and you can start them on 100 milligrams twice, but need to be titrated. So preaminometer speak to me in 10 minutes. Monitor the blood pressure. We definitely know excess drug in real life cases. I'll move on. Yeah. So sacubitril and valsartan is improved doing the glycemic control and diabetes to inhibitor is another drug. This again and we have got good ideas. And I personally, a vast majority of patients who are tolerating these drugs quite well. It is ARBs and a beta blocker along the from the renal function.
Doctor.
So I think there's good evidence that used routinely. Any drug.
Dr. Rajpal, we need you to conclude because we're running out of time.
ARB and then take any question.
Dr. Sir, good evening, everybody, and sorry for the technical hitch. I think there was a problem with connectivity from Dr. Rajpal's office. And
hello,
hello. Sir. Yeah, thank you for finishing it because there was poor audibility, so we wanted you to finish it earlier. Over to Dr. Shekhar Dr. Shekhar to conclude. And
it was such I think we really missed Dr. Rajpal's insights into what can be done in heart failure. But anyway, there is always another time. Let's see. But this segment of diabetes about how to improve adherence so that we have a better outcome as far as diabetes complications is concerned. And one of the end of the road concept of heart failure, reduced HRF or whatever it is, what are the treatment options?
I can't hear, this is all breakage. I can't take.
Especially so when it comes to the new concept of guideline directed medical therapy for heart failure, hypertension, diabetics, etc. Do we really look at guideline directed? So we have to look at this. Unfortunately, what has happened in the last few years is to put head on head with two molecules which have a similar action, or two molecules which have similar outcome, and say this is better and that is better. Personally speaking, when we have so many molecules which are good enough, which are safe enough, which are efficacious enough, we need to look at what would be the X factor of A versus B versus C. So I would be in a position to ask this question: what would be the X factor of Vimada or sacubitril valsartan combination when it comes to HREF in general, or in diabetics with HREF, or heart failure as a major issue with the end of the line concept of heart diseases? Dr. Raj?
Sir, I don't think his audio is clear and he's able to take questions as of now. Dr. Raj, can you take that? I don't think he's connected well, sir. So you can conclude the session and we move on to the next.
Okay, I think we'll stop here just to say that you have another new kid in town which has very good outcome. As in heart failure, all you need is to prevent symptoms from progressing, to prevent hospitalization, which will make them so poor financially that they cannot go for the second hospitalization, and to prevent death. Mortality benefits, heart failure, hospitalization prevention, and prevention of progression of symptoms would be there. And guideline directed medical therapy says sacubitril valsartan ticks all the three boxes. This is the final thing. Galvus OD or vildagliptin OD is as good as Galvus BD or vildagliptin BD is my final answer. Thank you for this.
Thank you, sir. Thank you for moderating this session. Then we move on to the next session for today. I ask Pooja to take over.
Good evening, everyone. Good evening, Dr. Praveen. I would like to take this opportunity to introduce Dr. Praveen R, Senior Director, Medical Affairs, Biocon Biological Limited. Welcome, sir. Over to you, sir.
Thank you very much. And I really thank Dr. S.R. Arvind, Dr. Sanjay Reddy, Dr. Prasanna Kumar, and Dr. Kushish Shadri for this wonderful conference, ADORE CME. And we are now moving up to the symposium, which we are having two eminent speakers, Dr. Sanjay Reddy and Dr. Viraj Suvarna. Before I would like to introduce Dr. Sanjay Reddy, but I thought I should put across few critical aspects, because that is actually goes with the topic what Dr. Sanjay Reddy is going to speak about the 100 years of insulin discovery. Have we done justice to insulin therapy? So a couple of points what I thought is that where exactly 100 years before, where Banting and Best successfully treated a dog with the diabetes with insulin, what they actually extracted. And then after that, after a month after that, where James Collip, who actually a biochemist, joined the journey, and then he started purifying the insulins, what they have actually extracted. And then the first patient, who is a type 1 diabetes, Leonard Thompson, though they had given him, but because of the allergic reactions, unfortunately, they could not able to continue the therapy. But what actually the miracle is that in the year 1922, where Elizabeth Uggs were responded to insulin therapy, that is something a miracle, and for that which where Banting and the Best got the Nobel Prize. And then the year 1924, where the mass production of the insulin actually started in its own journey. And then if you see the current situation, like I would like to quote the data points what came out from the recent IDF, where they say that almost the prevalence of diabetes is almost 10.5%, and 536 million people have been having diabetes. And where I could also quote one of the article which I have gone through very recently, written by Dr. Sanjay. He actually said that 33 million people in the year 2018, they cannot afford or they don't have access to insulin. And the number would actually goes up to almost 41 million in the year 2020. That is how the need of insulin has been looked into. So, and I'm very sure where Dr. Sanjay Reddy is going to make that kind of justice, because after the 100 years of insulin discovery, we really done a justice to insulin is something which where Dr. Sanjay Reddy is going to speak about. It's a pleasure to invite Dr. Sanjay Reddy. Is MBBS and MD in General Medicine, consultant diabetologist and a medical director in the Center for Diabetes and Endocrine Care, Bangalore. And then he's also a consultant diabetologist in Fortis Hospital and a vice president at Primer Group. With that, I'll hand it over to Dr. Sanjay Reddy. Over to you, sir.
Thank you, Dr. Praveen, for the introduction and for the kind words. What I'm going to speak for the next 15 minutes, I think we're running a little late on time. Let me share my slides. Hope you can see them.
Yes, sir.
Yes. Give me a minute. Okay. 100 years of insulin therapy, have we done justice? I'm not sure to insulin therapy, but let me enumerate on what I'll just go on to the next. Give me a minute. Yeah. Thank you, Biocon, for inviting me to speak on this topic. Have we done justice to insulin? So, just to say, I think insulin has saved more lives than any other molecule in the world. Before this, just want to share one of the statements from Jocelyn's. Before insulin, diabetes was mostly a fatal disease. We all knew what the diet was for type 1 diabetes. This was starvation treatment, mother and child with type 1 diabetes in the 20s. This was what was recorded, and this I want to show. They had restricted them on carbohydrates, and sometimes people died of starvation. Now, what happened in the research of diabetes? This 1989, we had Oscar Minosquick and Joseph von Mering found out that pancreas gland, when removed from the dog, they developed diabetes, and they found that there's a substance called insulin, which was responsible for it. Later experiment narrowed the search to islet of Langerhans, and then we had certain 19th century Edward Sharpie Schaeffer suggested only one chemical compound was missing from the pancreas in people with diabetes, and they decided called this chemical insulin, and you see what magic it has done over the years. Now, the therapeutic history of insulin from 1906 to 14, we had struggles in animals trying to find out this, that the Zulker struggled with animals trying to find out how this disease caused. Then 13 to 21, it was Scott Kleiner, Polesco at work, just trying to remember whoever was responsible over the centuries for the development of insulin. And then we all know the four of these people who were responsible for producing for discovering insulin, and started that was Banting West, supported by Collip and MacLeod, and later Walden, supported by Clovis, developed large-scale processes using isoelectric precipitation. Insulin is a fragile molecule, difficult to bioengineer, and often bioincompatible. Now, we all know these four gentlemen who were responsible, and they received the Nobel Prize for the discovery of insulin. This is pre-insulin era. Now, what did insulin do in the last 100 years? Now, have we done justice? I don't know, but what it did do. Now, before the discovery of insulin, life expectancy of people with diabetes was this. Imagine after 1945, after insulin was started, they started to use insulin. Look at the life expectancy dramatically changed. In 1945, a child diagnosed with type 1 diabetes at the age of 10 would expect to live more than 30 years longer than a 10-year-old diagnosed with type 1 diabetes before the discovery of insulin. So first thing, what did it do? It improved life expectancy. Now, how many people did insulin save? That itself is the credit which I don't think no other molecule can take it away. Now, this prompted somebody to write, or none other than Professor Elliot Jocelyn, writing 48 with insulin and 4,000 years without. Today, there must be 3 million people with diabetes whose lifespan has increased on an average at least by 10 years each. This makes a total of 30 million years of productive human life in one country alone. This was in America. Now, these are different time frames which led to the event of discovery of insulin. Now, if this is what insulin has done in one country in an observation 40 years ago, what is the observation we have after that? Now, a small history. When did we get insulin into India? I was reading an article from the Times of India, though I don't have that as a presentation. I think somewhere a couple of researchers in 1923, and this article was written by, it was in the Times, and 1923, researchers from India got insulin was used. But the documented use was somewhere 1929, and we all know Leonardo Thompson was the first to receive. But the documented evidence of somebody receiving was Kumudini from Calcutta. I don't know how many of you have known about it. And one of the doctors who have first used it was at Calcutta, Dr. Bose. And I was reading this article, and which suggested that Dr. Mohan, Dr. V. Mohan, and we know Dr. V. Mohan, and there's going to be a book called Bose, Banting, and Beyond in insulin in India, the last 100 years. This information is not there. Now, over the past 100 years, there are 10 different categories of medicines which have been developed. This is after insulin. It was one of the first medications to have ever developed for diabetes. Now we have different types of insulins, insulin analogs, OHAs. Now, where are we in the usage? We know that there's an increasing trend in the prevalence of in diabetes, both type 1 and type 2 in India. And these are the projections by 2045. Don't want to go into it. It's only the millions of numbers. Now, the oral anti-diabetic drugs. Now, look at it. So there was work from 1980 on all the oral diabetes drugs, but this is where the this is oral anti-diabetic drug progress over the years. Now, this progress has been rapid over the last 2 decades, but insulin has been there for 100 years. I think it did serve more lives and more data than anything else. Now, if you want to look at glycemic control, there's no other drug. If you compare glycemic control alone, I don't think any other drug can beat insulin in achieving the type of glycemic control it can do. And that is enough proof for it, for the justice which is done in our country. Now, if these oral drugs put together, now I have a small statement for any patient who comes to my clinic with type 1 or type 1 diabetes. Obviously, we only use insulin. Type 2 diabetes, you have to use insulin at some point of your life. So why not start talking it from the day you can when he comes in? So we know all of us know signs of insulin adequacy, and that is when you use more than 2 ADs in significant insulopenic or glucotoxic patient, whenever the patient is having hyperosmolar symptoms, HbA1c constantly above the individualized glycemic target, and duration of diabetes more than 5 years. Now, when to consider a person with an insulin type 2 diabetes, now when OHAs fail, more than 2 OHAs fail, you can now consider insulin therapy associated with unacceptable, all OHAs are accepted, unacceptable adverse reactions, advanced hepatic or kidney disease, special consideration, especially in patients on steroids, infection, pregnancy, hyperglycemia in hospitalized patients, presence of severe hyperglycemia. Now, what is the need? Need of the hour is, can we initiate early insulinization? Now, we have a lot of data suggesting that we all know that type 2 diabetes is a progressive disease, and there's absolutely insulin deficiency even before, by the start of diabetes or much earlier than that, there is decrease in insulin secretion. So many oral therapies alter the decline in beta. Not many oral therapies alter the decline in beta cell function. And poor glycemic control is an important driver for glycemic complications or diabetes related complications, which we are all aware. So early insulin therapy is physiologically intelligent, will provide long-term health benefits for type 2 patients. Now, early insulin therapy overcomes beta cell exhaustion. We have seen data suggesting that patients with A1C at 10 and above, and even on diagnosis, insulin for short period of time does give them better, there's lesser progression, they respond better, achieving targets later becomes easy. So early initiation of insulin therapy aids in providing long-term efficacy against complications with type 2 diabetes. Now, what does timely insulin initiation do? Deaths due to diabetes are decreased 21%, myocardial infarction by 14%, even if you get A1C down by 1%. Microvascular complications will be down by 37%. This is an old slide which we all know. And now what are the different types of insulin we have? Now, we moved away from animal insulins to regular insulins to the insulins basically are based on the type, the duration of action, short acting, ultra rapid acting insulins, intermediate acting, long acting basal insulin, ultra long acting basal insulin. Now, one of the most commonest and the easiest insulin to start off is a basal insulin. So what happens when you give basal insulin? Basal insulins can be started off very easily. They have significant low rates of hypoglycemia, less weight gain. Basal plus, now once you achieve the fasting glycemia, target is fixed or fix the fasting, adding a bolus dose later becomes easy. And rationally for insulin, for initiating insulin with basal insulins with basal insulin, look at what happens. You fix the fasting first and then go on the prandial levels. So that way we will be able to achieve target. Basal insulins, especially insulin glargine after NPH insulin, which was used, an intermediate acting insulin which was used earlier, glargine did change the way insulin initiation was significantly improved after the invent of insulin glargine, and all societies recommend, ADA or ACE recommends use of basal insulin during the process of during the duration of diabetes. The reason for it is convenience of dosing, safety and efficacy, availability, affordability, education and training on handling of insulin. Now, all these are very easy with basal insulin. Almost all guidelines in the world have started recommending this. Now, you should understand most of the insulin, which if you start a basal insulin, you can start at 0.1 or 0.2. If the A1C is greater than 8, 0.2 or 0.3, we all know the titration regime. Once in 3 days, do an SMB, do a fasting blood glucose. I take an average of 3 fasting blood glucoses. Based on it, we have algorithms explaining if it's more than 180, what to do between 140 and 180, 110, 139. The most important thing is starting insulin. Second, titrating and adjusting to achieve goals. Whether this is the most important aspect of insulin. So ADA Standards of Care 2021 also says consider insulin as first injectable, blood glucose is 300, A1C is more than level, especially on diagnosis too. There is evidence of ongoing catabolism, other symptoms of hyperglycemia present. Basal insulin alone in most convenient insulin in the regime and can be added to metformin and other oral agents. So you can add it along with GLP-1 analog too. So additional of basal insulin, or if you compare it with NPH insulin, which is available, if you compare glargine and NPH, we know NPH has more incidence of hypoglycemia. Now we have premix insulins and we have shorter acting insulin. Premix, if you compare premix with basal, there are more differences. Basal insulin is more convenient, lower insulin doses, less complicated, low risk of hypoglycemia and weight gain. Premix, you have to use it more than once. Higher insulin dose required, need adjustment with meals and exercises. You have associated with more weight gain and hypoglycemia, but both of them are being used. But there are barriers to insulin therapy, which is there, which have been talked about always. It could be physician barrier, it could be language barrier, it could be training, newer insulin devices and experience, concern of the risk of hypoglycemia and weight gains, concern about patient non-compliance and use of insulin in office. Basal insulin, I'm not going into the titration regimes of basal insulin. I just want to conclude and then give a talk what have we done the last 100 years. Conclusion is please use insulin wherever there is indication. And we have seen what it is and how many lives it has saved and what it can do in future. Early insulin initiation, the glucotoxic effects of hypoglycemia. Guidelines recommend initiating basal insulin in symptomatic patients with A1C above individualized glycemic goals. Timely basal insulin dose titration is important to overcome inertia. Now, have we just done justice to insulin therapy? Might take. We have saved millions of patients across the globe. We are going to save many more. I think timely initiation of insulin, more high, and have we caused barriers in initiation of insulin? I think partially. There's been a lot of last 3 decades to 4 decades. When I was in medical school, they used to admit a patient to initiate insulin therapy. I think we've come a long way from there, where it is done in a patient setting. 30 years ago, it used to be that. But now, I think there is a lot of education on that front, probably from the way insulin has improved and the number of newer insulins coming in. But still, we need to start insulin. Education, educating healthcare professionals, patients, I think is still the key. It should go on, and we still have a long way to go. Now, there are questions of availability, accessibility, and affordable insulin. Are we having them to do this? Are we successful in developing insulins other than in injectable forms? I think we have failed the last 100 years. Future of insulin therapy, wait till it's further disrupted. Thank you very much for patiently listening.
Thank you, Dr. Sanjay Reddy. Thank you very much for that wonderful talk. You took a clear-cut journey about starting from insulin, and then you got into the various guidelines, and then you put across how the basal insulin titration, etc. And I think so we are now moving to the very interesting topic. That is next topic. We have Dr. Viraj Suvarna, who is going to speak about the world's first US FDA approved interchangeable biosimilar insulin glargine. So Dr. Viraj Suvarna is a Vice President and Head of Medical Affairs, India and Emerging Markets at Biocon Biologics, Bangalore. Before I would hand it over to Dr. Viraj Suvarna, I have a couple of points which I thought I should put across. So we all know the biosimilar insulins, and I would also like to quote something about the IDF team, what they have actually taken about the access to diabetes care. And then where the biosimilar insulin also plays a very major role. When we actually spoke about yesterday with some of the top physicians in Chennai, where they clearly said that the getting a biosimilar insulins really made an point, and I would not dilute any of the dialogue. They said that it actually brought down the price of the insulin, where a lot of biologics drug have been now. If the biosimilar would have been not in the market, the price would have been really gone much higher. There was a clear-cut biosimilar insulin made a pitch about checking the prices of the insulin. So with that, I shall hand it over to Dr. Viraj Suvarna for his talk. Over to you, Dr. Viraj Suvarna.
Yeah. Share your slides, Dr. Viraj.
Yeah. Can you see the slide?
Yes, Dr. Viraj Suvarna.
Yeah. So first of all, thank you very much, Dr. Sanjay Reddy, Dr. Arvind, and everyone at ADORE for giving me this opportunity of presenting and, more importantly, learning from the questions that I'm sure will come at the end of this presentation. What you're seeing on the slide is the theme of World Diabetes Day by the International Diabetes Federation, which interestingly has come in the insulin centennial. So 100 years of insulin, and still the theme is access to diabetes care, if not now, when? And it's not for 1 year, it's for 3 years. Now, another thing that you're seeing on this slide, which I thought I'll explain, typically one doesn't use the brand name on a slide, but here it's important because when a doctor reports an adverse event on a biosimilar, he needs to report it by brand name. And even the international non-proprietary name is not just biosimilar insulin glargine. There is a 4-letter suffix, like in this case, it's YFGN, to differentiate Basalog from other biosimilar insulin glargines, because every one is different. But the reason why we are still talking about access is exactly what Praveen was saying in the beginning. 33 million people with type 2 diabetes do not have access to insulin, and by 2030, so another 9 years from now, the number will touch 41 million. And the current levels of insulin access are highly inadequate compared to the projected need, particularly in Africa and Asia. Now, these are points which I'm sure everyone in the audience is well aware of, that there is a difference between a generic and a biosimilar. So a small chemical innovator or original product, when it goes off patent, a generic comes in. Similarly, when a biologic goes off patent, a biosimilar comes in. But the regulatory pathway is not the same. So for a generic, it's much easier, and that's why you find a huge difference in price, 80% or more. But if you look at a biologic and a biosimilar, the price differential is not that much, because to introduce a biosimilar, you need to invest quite a bit, and I'll talk about it in my subsequent slides. The second important point is biosimilarity is not the same as interchangeability, and we'll talk about that also later. And of course, in diabetes, it's all about time, because even when a patient is diagnosed with diabetes, he or she has already lost up to 50% or more of beta cell function. So therefore, time can also be an acronym for the importance of being, and purposely I've spelled B as a beta because it's all about beta cell dysfunction, the importance of being metabolically early. And this was an article written by Shashank way back in 2009, so 12 years earlier, where he's asking the question, biosimilar insulins, are they really similar? And why I've put the EMA guidelines is because they were the first regulatory authority to come out with guidelines on biosimilars way back in 2005, 16 years earlier. And thereafter, the US FDA, perhaps Japan, Australia, then of course, India also in 2012. And then we revised our guidelines in 2016. Now, it's interesting to note that, first of all, this term bio better. Now, what may happen sometimes, the biosimilar, when it's being compared to the biologic, the original, may appear to be superior, not just non-inferior. So that is when someone may say that it is a bio better. But that's not how the regulator looks at it. For a regulator, if you claim that you're a bio better, then you have to undergo the same regulatory pathway that, for example, the original or reference biologic underwent. So naturally, no company would want to do that. So I don't think this term bio better should actually be used. The other interesting thing is biomimic or biocopy. Some people also call it intended copy or a non-regulated, non-similar product. Now, this is what happens when, say, in the European Union, the EMA or the US FDA, they find that the biosimilar is not similar to the biologic. And that's important because I wonder why only one Indian biosimilar is actually available even abroad. Why only one Indian biosimilar insulin glargine is approved by the EMA, by the US FDA, by Japan's PMDA, by Australia's TGA. Why not the others? Because Indian companies do export generics made in state-of-the-art US FDA approved manufacturing plants. So why can't they also export biosimilars? I agree, biosimilars are not easy to make as compared to generics, but still, why not? With biosimilars, of course, the process is the product because the starting point, the master cell bank, is obviously proprietary. The innovator is not going to share it. So the biosimilar manufacturer has to have his or her own starting point. In this case, it's Pichia pastoris. But what is interesting to note is in this process of recombinant DNA technology, the whole definition of a drug actually changes. Because a drug is essentially a substance that when administered only alters existing function of a cell. It does not impart new function to that cell. So for example, a muscle cell doesn't become glandular cell or vice versa. But here, if you look at it, Pichia pastoris or E. coli or Saccharomyces cerevisiae or Hansenula polymorpha, these yeasts or bacterial cells, they have never produced insulin or any other such product all their lives. But now, because of recombinant DNA technology, where you identify the gene of interest, put it on a plasmid which acts like a vector or a carrier, insert it into this yeast cell, it gets integrated into the cell, the nucleus, so the genome. And then when this cell divides, obviously the daughter cells also get the information on how to produce that protein of interest. So from DNA to RNA transcription and then translation, from mRNA to tRNA to rRNA on the endoplasmic reticulum, the rough part. And these ribosomes or ribosomal RNA would ultimately produce that particular protein. It's almost like a factory and assembly line, and you have pure forms of that protein produced en masse. But what is interesting to note is that the drug substance for Biocon Biologics is actually made in Namma, Bengaluru. That's interesting, because typically we always depend on other countries, and in particular China, for our active pharmaceutical ingredient. Why? I mean, we know that China is at almost doing a proxy war with India, and yet Indian companies are dependent on China for the API. Why can't we make our own API, our own drug substance, the way Biocon Biologics does? And then, of course, that manufacturing facility is inspected by the US FDA, by the European Medicines Agency, before approval. And this particular slide is important because that fingerprint actually is unique. It identifies the biosimilar and makes it distinct from any other biosimilar or even the original biologic, based on the structure or the sequence, the identity, the form, the size, concentration, activity, purity, and surface charge. So this is important because sometimes people say maybe the biosimilar is bioidentical, but I wouldn't say that, because the basic amino acid sequence is identical, I agree. But otherwise, because of post-translational modifications such as glycosylation, sialylation, phosphorylation, acetylation, amidation, there is some difference. So you can't really say the same. So that's why I'm saying similar is not equal to same. Equivalent is not equal to equal. That is what we must keep in mind. But practically, for all clinicians, as long as clinically in the studies that are conducted, if there is no clinically meaningful or significant difference in efficacy, safety, including immunogenicity, then yes, we have to say that they are similar. Now look at the development for an original biologic. Here, if you look at that inverted pyramid, the biggest part of the pyramid is right on top, which is the clinical development, all those phase 3 studies which are done on the product to establish efficacy, safety, immunogenicity. Then comes the PK/PD, then the animal studies, and finally the in vitro studies. But if you look at the erect pyramid, you realize for a biosimilar, the biggest part is actually the in vitro studies, the analytical characterization. The process quality, the manufacturing specifications, whatever you saw on that slide, which had the fingerprint, that is the most important, because if you don't pass that test, you can't even go on to the next. Next comes the non-clinical, so the animal studies, then of course PK/PD. And in clinical, it looks, yes, definitely the smallest of the four, but the reason why this is done is obviously because the patent for the biologic has expired. So now naturally, more patients should have access, and therefore the regulator tells the biosimilar manufacturer, at least do one study. You don't have to do the entire clinical development that the original or reference biologic had to do. One study, but prove equivalence, clinical or therapeutic equivalence, which you don't have to do if you're a generic and you compare yourself to a small chemical originator product. And this equivalence design is important because, see, typically we know about these superiority studies where the null hypothesis is that there is no difference between drug A and drug B, and then you do the study and you test this hypothesis. And if you find a difference that is significant, then you reject that null hypothesis and conclude that there is a difference. But in an equivalent study, it's just the opposite. The null hypothesis is that there is a difference between drug A and drug B, and then you do the study and test that hypothesis. And if you find no difference, then obviously you reject the null hypothesis and accept that there is no difference, and therefore the two, drug A and drug B, are considered to be equivalent. That means neither superior nor inferior. But for that, for both the kind of studies, you need a calculated sample size. It can't be just 100 patients in each arm, the way the Indian guidelines and biosimilars demand. Because 100 patients in each arm, sometimes you may actually find no difference. That's because the study is not adequately powered. So then you will conclude that there's no difference, but we really don't know whether there is a difference or no, because you've not adequately powered the study. And then, of course, in the Indian guidelines, all you need to do is a PMS study on 200 patients, and that's it. With biosimilars, one needs to be careful. It's not the same as a generic. So unless that biosimilar is thoroughly evaluated and approved by stringent major market regulators like the EMA, the US FDA, Japan's PMDA, and Australia's TGA, I would be a little, scared of using it. From a physician's perspective, obviously, he'll look at the indications, but more importantly, the proof of safety, of bioequivalence, of clinical equivalence, and most importantly, immunogenicity. Why? Because you have anti-drug, in this case, anti-insulin antibodies that could be produced by the patient in response to that biosimilar. Now, imagine if, when you compare yourself to the original or reference biologic, in this case, obviously insulin glargine or Lantus, and if to that biosimilar, the anti-insulin antibodies are much more than to Lantus, then what can happen? Obviously, in that patient, the biosimilar doesn't work. So then you feel like going back to Lantus, but even Lantus won't work because these anti-insulin antibodies can destroy even Lantus. So that's why it's extremely important that on immunogenicity testing, the anti-drug antibody has to be tested against the original or reference biologic, which means you have to have clinical studies. And the pharmacoeconomic impact, of course, is not just that obviously the biosimilar is cheaper than the biologic, but it's also in terms of, because it's cheaper, perhaps the patient is more compliant, more adherent. If he's more adherent, he's likely to be more controlled. If he's more controlled, he's likely to have lesser complications. And ultimately in diabetes, it is the cost of complications that makes the difference. Then, of course, with Biocon Biologics, we all know more than 15 years of manufacturing expertise, the science, the scale, the scope, the technology, and years of patient experience. Be it recombinant human insulin or Insugen, 43 countries, global trials in Europe, in the US, and even with insulin glargine, 68 countries, and one of the largest insulin suppliers. We have a huge plant even in Malaysia. Then, of course, all these global trials, phase 3, InStride 1, I'll talk about it in type 1, InStride 2 in type 2, then InStride 3, which is an extension of InStride 1 in the US, and then a PK/PD study in Germany. We also do euglycemic hyperinsulinemic clamp studies. There's an Indian study, there's a Japanese study, and all pretty long studies, 52 weeks. So 7 trials, 1,915 patients, 20 countries. I don't really think other insulin biosimilar glargines had to do this kind of development because they're only in India. And then, of course, all the approvals, not just from India, but the US FDA, EMA, South Korea, which is again a reimbursed market, Japan's PMDA, Malaysia, and of course, Australia's TGA. And the fact that this particular product has different brand names in different countries only because Biocon Biologics does not really have a presence in all the markets. So what we do is a B2B or a business-to-business model. We have partnerships. For example, in the US, there's a company called Viatris, which is nothing but Mylan plus Upjohn from Pfizer, both generic giants, and they have a presence there. So we are partners with them. We give our Basilog to them. They, of course, it's a co-marketing partnership, so they can change the brand name and they adopt the brand name Semglee. So that's why you'll see Semglee as the world's first and only biosimilar interchangeable insulin glargine. But that doesn't mean that it's with Semglee and not with Basilog, because the two are identical. Please, let's understand that when the US FDA approves, they also come to the manufacturing facility and inspect the processes. So they came to Malaysia, the manufacturing plant of Biocon Biologics. They didn't go to the Mylan plant. So let's understand that it's basically Basilog in Semglee. And this is the entire clinical trial package. So it's not just for regulatory approval, but continuing clinical development of the product and the therapeutic area around the product. This is again important because when a patent expires, The product does not. But for that innovator company, naturally, their incentive for developing the product further will go down. But for the biosimilar, and a biosimilar like what Biocon Biologics brings to market, it's almost like an original biosimilar or the reference biosimilar. So we will continue to further the clinical development of not just insulin glargine, but the therapeutic area around the product, facilitating even in investigator-initiated trials. Now, this is the entire package, so I'll straight away go to INSTRIDE 1. These trials are a bit similar. INSTRIDE 1 is non-inferiority, type 1 diabetes mellitus patients. You compare Basalog with the reference insulin glargine, which is obviously Lantus, and this was in 558 patients, all published. You basically have to compare the two, and it's on all the three parameters: efficacy, safety, and immunogenicity. So this is in terms of the objective, the design, the sample size. It was open label because it was difficult to blind the study in terms of the two different pens, but more importantly, it was a blinded endpoint studies, which means that people who evaluated these patients on efficacy, safety, and immunogenicity, they were blinded as to who was on Basalog and who was on Lantus. And then, of course, the study design, so a screening period, a run-in period, and then they were randomized into the two arms, followed up for 52 weeks and another follow-up of 4 weeks, essentially looking at the change in HbA1c, and importantly, the non-inferiority margin should be no greater than 0.4%, the upper limit of that two-sided 95% confidence interval. And then there were a host of secondary endpoints. FPG was looked at, change in insulin dose, and then, of course, safety endpoints like hypoglycemia at any time, and in particular, nocturnal hypoglycemia, and obviously immunogenicity. And it was found that from the upper bound of the 95% confidence interval for the mean change in HbA1c from baseline to week 24 was within that non-inferiority margin, proving that Basalog was non-inferior to Lantus. The changes in HbA1c and FPG levels, again, were similar. Basal bolus insulin dose levels did not differ, and also the rates of hypoglycemia and other adverse events were comparable. INSTRIDE 2 was very similar, 560 patients, but of course in type 2 diabetes mellitus patients over 24 weeks, but otherwise more or less the same kind of design. And here, of course, a similar kind of conclusion in terms of change in HbA1c, FPG, the insulin glargine dose level. This is also important because apparently people are saying that Lantus is more potent than Basalog, but as you can see in these trials, if the dose level does not change between the two groups, obviously it means that in potency and efficacy, both were similar. And this is the most important because for the first time in the world, an Indian company actually managed to get this interchangeability, which means if you are on Lantus, I can now switch you to Basalog. So now for that, the design had to be, first of all, conceptualized, and it was co-conceptualized between the company and the US FDA, and the same design is now used for others as well. It's a 3-switch design. So essentially what happens is that, in this case, of course, patients with type 1 diabetes mellitus who were in INSTRIDE 1 completed that study. They were on the reference insulin glargine, which is Lantus. Then they were randomized into two arms, Arm A and Arm B. I know you'll say 127, isn't that too small a number? But there is a reason why the number is 127. If you look at this design, it looks like a parallel group design. So one arm is those who were on Lantus plus Lispro, but look at the other arm. So Arm A, initially they were on Lantus, now they are on Basalog plus Lispro for 12 weeks, after which they go back to Lantus plus Lispro, and then after 12 weeks, they come back to Basalog plus Lispro, which means within the same patient, you're reducing variability. It's not like between two arms. There, of course, there's more variability, but within the same patient, you can actually look at all these switches. First, he was on Lantus, then he was on Basalog, again on Lantus, again on Basalog, and in all these different switching sequences, if efficacy, safety, immunogenicity, no clinically significant differences, then obviously you know that one can switch from one to the other. And in a way, this is good for Lantus because it at least tells you that if you are on Basalog and then you have to go back to Lantus, Lantus will still be effective because the anti-insulin antibody that has been produced is not clinically significant. It does not do anything to Lantus. So change in HbA1c, as you can see here, the red line is the non-switching sequence, the blue line is the switching sequence. So this change was equivalent whether you were on Basilog or Lantus. More importantly, the cross-reactive insulin antibody percent binding over time, there again, no statistically significant difference, and that's most important. And this is again telling you the proportion of patients, who had this antibody response, where you're seeing absolutely no differences between Biocon's insulin glargine in blue and the reference insulin glargine in a slightly darker gray. And that is why on July 28, 2021, the US FDA for the first time in the world approved an interchangeable biosimilar insulin glargine for diabetes. Imagine an Indian company being the first. The second is, of course, Boehringer Ingelheim for their adalimumab, Siltezo, which was considered interchangeable with Humira, that's AbbVie's product. And very soon, I'm sure you'll have a third, and we might also come with a biosimilar insulin aspart, which also will be interchangeable. So clearly the US FDA, I mean, the acting FDA commissioner, normally she's not very vocal, but she actually said it. Today's approval furthers FDA's long-standing commitment to support a competitive marketplace for biological products and empowers patients by helping to increase access to safe, effective, and high-quality medications at potentially lower cost. And if you look at the comparison in terms of pricing, also you find that biosimilar insulin glargine vials are 48% more affordable than the reference product, and biosimilar insulin glargine cartridges are 16% more affordable than the reference product. So that actually is my last slide. I would like to again thank the organizers of ADORE for giving me this opportunity. And now in the time that is left, I know we've gone a little beyond time, but please feel free to ask questions so that I learn more from the clinicians in this audience.
Thanks, Dr. Viraj Suvarna, for a very insightful talk about the biosimilars and the interchangeable designation. I have one question to ask. What is the difference between the interchangeable and the switching? Because that's something which is very pertinent to the current discussion, what we can actually take it up.
So interchangeability is actually a regulatory term. And based on that 3-switch design, you get a term or claim or approval of interchangeability. Switching is what a doctor can do in his clinic from one particular, say the original or reference biologic to this particular biosimilar, which has been approved to be interchangeable. And at a pharmacy level, that is where substitution happens. Now, I know in the US, the moment you get interchangeability as an approval, at a pharmacy level itself, people can change without the doctor even knowing about it, without the pharmacist even telling the doctor. But that happens only in the US, and that too only in some states in the US, not all. But in India, clearly, it will not happen. And there is no way Biocon Biologics also is going to chemists. We just go to doctors and we leave the decision to the doctor.
Sure. Thank you, Dr. Viraj Suvarna. And I shall hand it over to the ADORE team. Thank you, Dr. Sanjay Reddy. Thank you, Dr. Aravind, for this wonderful time and the discussions. Over to you.
Thank you. Thank you so very much, Praveen. Thank you, Sanjay. Thank you, Viraj. I think that was a very, very great talk. And now we'll be actually combining the two halls, which will be going live, and probably there'll be a minute's delay. I would like to take this opportunity to request the IT team to now take over from there. And as soon as they give us the go-ahead, then I will be requesting Dr. Krishna Sheshadri to take over soon after that. Just be patient for a minute, because the hall A and the hall B will get now interconnected, because whatever feed is going live will have to be connected to both the rooms. There can be just a minute's delay at this particular point. Good evening, everybody. Thank you so very much for that patience. Both the halls have been combined, and at this point of time, I'll be requesting Dr. Krishna Sheshadri to take over. And of course, Krishna Sheshadri has been a part of the ADORE team, and he's been one of the directors of this particular conference. And actually, he requires no introduction, but then I will, however, still do it. He graduated from the Madras Medical College, went on to do his MD in the American Board of Endocrinology. At present, he is a consultant endocrinologist at the Chennai Diabetes and Endocrine Clinic at Chennai, and he's the clinical and research lead at Apollo Sugar, Chennai. Dr. Krishna Sheshadri, the stage is all yours, and you can go on to introduce Dr. Rohit Kulkarni, who will be one of our star speakers. And Rohit has always stood by us for the last 12 to 13 years. And he's been a permanent member of all our meetings, both during the ADA primer, PAMS, and of course the ADORE. Over to you, Krishna.
Thank you. Arvind, sort of is quite strange to not be physically in Bangalore for ADORE. It's been part of my calendar for so many years. And I can claim a little that I helped coin ADORE. Rohit is a friend for many, many years. And the best tribute that I can give him is to say that, I wish he were here, that I had met him during the residency, and I would have just begged and pleaded my way to work in his lab. Rohit is an inspiration, bringing translational medicine back to India, helping people understand how the bench relates to the bedside. And as always, one of the people who inspires youngsters like me to do more. Interestingly, he's chosen Modi 8. For those of you who want a recap of Modi 8, this is a single base pair division in the 11th exon of the cell gene. Interestingly, an insertion in the same gene actually causes polymorphism. So let's hear what Rohit has to say. Rohit, welcome, all yours.
Great. Thank you very much, Krishna, and I hope you guys can hear me.
We can hear you.
Great. Let me share my slides. Can you see the slides?
Yes, we can see the slides.
Great. Thank you so much again, Krishna and Arvind. It's a pleasure to be involved with this forum. As you mentioned, it goes a long way back, and I'm really delighted to be part of this forum for several reasons. And one of the reasons has been that you guys agreed to include research as a component of this forum, because it gives the younger faculty an opportunity to learn and to also realize that research is an integral part of medicine. So I'm grateful to that. So as Krishna mentioned, I wanted to focus on a Modi 8 because of the unique features of the disease, and also because it gives us another example of how research translates into clinical medicine. So I think my time starts now. So I hope you guys will make sure that the clock starts ticking from now. Before I start, I just want to thank the people in the lab, but just specifically mention Sevim, who did a fantastic job over the last 6 or 7 years, focusing on the efforts for this particular talk, and give her all the credit for what she's done. I won't go into detail again here, but just to emphasize the point that Modi is a monogenic form of diabetes as opposed to type 1 and type 2, which are polygenic. Usually it first occurs during adolescence or early adulthood, and accounts for up to 2% of all cases of diabetes, at least in the US. So again, coming to Modi, as was alluded to by Krishna earlier, Modi is also called a defect in the CEL gene, as shown in the red box here. CEL stands for carboxyester lipase. It accounts for less than 1% of all Modis. Distinctly, it's got two components to it. Not only does it have all features of Modi, where you have beta cell dysfunction over a period of time, but the defect actually is in the exocrine tissue. So if you look at all the different types of genes which are affecting these individuals are termed as MODY, this is unique in that the defect is outside the beta cell. And that is what gave us an opportunity as a challenge to figure out what exactly is going on. So it goes back to physiology, in fact, in that the islets constitute only 2% of the entire pancreas, and the islets are surrounded on all sides by acinar cells. And so teleologically, one can argue that there is a crosstalk between exocrine and endocrine cells, and therefore a defect in one of the cell types will cause a abnormality in the other. So, for example, one can argue that alterations in pancreatic exocrine function is evident in patients with diabetes, and this has been reported. But we also know that there is an increased risk for diabetes in the sense that endocrine function in individuals with exocrine pancreatic disease, for example, individuals with acute or chronic pancreatitis, people with cystic fibrosis, pancreatic cancer, each one of them would also manifest diabetes. So it really, we've always sort of shied away from understanding what's happening in the exocrine tissue. And part of that is because it's been a challenge to model exocrine cells, work with them comfortably as like what we do with the islets. And therefore, the studies focused on exocrine tissues has lagged behind in some ways. And so I think the field is now catching up quickly to figure out what exactly is the crosstalk between these two cell types, which is important for us to understand in the overall physiology of the pancreas. So, and therefore the interest in MODY8, which is a mutation in the carboxyester lipase. This is the variable tandem repeats, which leads to a syndrome of diabetes and pancreatic exocrine dysfunction. So CEL is a bile salt dependent lipase, is secreted mainly from the pancreatic acinar cells, hydrolyzes a wide variety of lipids, and is characterized by childhood onset exocrine pancreas dysfunction. So I'm emphasizing is exocrine pancreas dysfunction. But then these guys go on to develop diabetes. And so the cause has not been very well understood. And the reason as to how you want to treat these individuals is still lagging behind. A little bit of biochemistry and details here. So on the top, you find that you have, I hope you can see the pointer. This is the wild type CEL. And below that is the mutant CEL, and the red box here is the region of the tandem repeats, and this is the region which is altered in patients with CEL MODY. And what has been shown is that these the proteins which are formed from the mutant CEL form intracellular aggregates, but this has been shown in acinar cells. And it's also been shown that this secretion of this mutant protein is reduced compared to the normal or the wild type protein. And that overexpression of this mutant protein leads to a number of disorders of the cells. For example, it leads to stress, also called endoplasmic reticulum stress. It also it leads to what is called as the unfolded protein response, and leads to cell death by apoptosis. But most of these data has been focused on acinar cells. And so the question still remains, how do they get diabetes if the defects are in the acinar cells? So we undertook this challenge many years ago to begin to model this. And we developed, you can see this published in 2010. We knocked out the carboxyester lipase in the mouse, and we found absolutely no phenotype. We then went on to do another experiment where we inserted this transgenic CEL as a knock-in in the mouse. And again, we found absolutely no phenotype. So these efforts, just to give you an idea, it takes about 2-3 years each. And so it was very disappointing that we didn't find any phenotype. So we went back to figuring out what might be happening. And again, this was a challenge for us. So we thought that perhaps we could derive stem cells from patients with MODY and ask whether there is a developmental defect. So I'll discuss that very briefly in part 1. And part 2, spend most of the talk in the crosstalk between these two cell types, which we think is the defect. So generation of MODY8 specific stem cells, again, was a huge effort by Sevim, who started this like 6-7 years ago. And just as being transparent, these data have been accepted in Nature Metabolism, so this will come out pretty soon. So I won't go into detail here, but just to mention that we undertook these studies to take samples from these individuals, skin biopsies, and specifically from these individuals with MODY8. And from these skin biopsies, we engineered them to develop into adult stem cells. And from the adult stem cells, we developed beta-like cells and SNR cells, and asked whether these MODY8 derived cells are showing any defective beta-like cells or SNR cells. And again, disappointingly, we didn't find any difference. So shown here is these beta-like cells from healthy individuals and those with the mutations. And you can see that overall, they're still, if you look at the stimulation index, they're still responding to glucose, whether it's a healthy individual or individual with MODY8. So this told us that the beta-like cells are not any dysfunctional if they're derived from these individuals. And we also observed that the insulin content was not very different. And there's a difference between these two panels here. One is an ESC-derived beta-like cell, and one is an iPSC-derived beta-like cells. And in both of these cases, you can see that the ESC-derived beta-like cells was created from inserting a mutation in the embryonic stem cell, as opposed to the iPSC-derived beta-like cells directly from the patient. So in both these instances, we did not see a defect in the beta-like cells in terms of its function. And so that was, again, a little bit disappointing, but it ruled out that developmentally these beta-like cells are pretty normal. So there must be something else going on in the adult situation. So we went back to the drawing board, and after agreeing that there's no defect in the development, we begin to look at the actual crosstalk between pancreatic SNR and beta cells. And so here's where I should give kudos to Sevim, who really pioneered these efforts and persisted until we found the defect. So let me give you one example of the crosstalk between these two cell types. So what Sevim did was she took SNR cells, both human and mouse SNR cells. In this case, it's mouse. And then you transfect them with different vectors, either an empty vector, which is a control, or you express it with a normal CEL protein or a mutant CEL protein from the patient MODY8. And then you culture these cells and you take the conditioned media and the cell lysates and look at the expression of this protein. And you can see that clearly in the wild type, in the lysate on the culture media, you have the overexpression of this wild type protein. In the mutant, because of the truncation, the mutation of the stop codon, it's a smaller protein, but you can still see that it's present in the lysate and the conditioned media. So this gave us confidence that this system is working. And she went on to show that you can look at the levels using Western blotting, and this can be quantified, pretty much equal amounts of protein being expressed. So what can we do with this system? She went on then to ask whether she can take the media from these SNR cells, which are from the normal or the mutant proteins, and then add it to the beta cells in a separate dish shown here. And then she could show that using this approach, that the number of CL positive beta cells, which are taking up this protein, is much higher when you look at the amount of mutant protein that's being taken up. So the beta cells appear to be more able to take up the mutant protein as opposed to the wild type. Or conversely, they take up equal numbers of protein, but perhaps they might be degrading wild type faster, but not degrading the mutant protein. But this was very evident that the CEL protein is being taken up by the neighboring beta cells from the SNR cells. So what happens to these cells? So shown here is an image where you can see that these are the controls on the first upper two panels. Here's the empty vector, which is again another control. And this is the wild type protein. You can see that the red, which is the agrosome, which is the CEL protein in the case of the wild type is not so distinctly observed as opposed to the mutant. So it tells us that there is some accumulation of this protein only in the case of the mutant. All these are beta cells. So they're taking up the mutant protein, but only in the case of the mutant, they're forming these aggregates. And that can be quantified, shown here. So I've shown you that the beta cells, when you keep them next to the acinar cells, when you have the mutant protein, it's taking up the mutant protein and it's accumulating inside the beta cell. And what happens to the degradation? So I told you that in the wild type, we don't see too much of the protein, either because it's getting degraded or because it's not taking up enough amounts. But we think it's the former, that in the case of the wild type, so shown here as an example and plotted on the graph here, that the wild type is able to solubilize this protein over a period of 24 hours. But look at the mutant, it always lags behind. And you can see that over a period of time, there is a large amount of the insoluble mutant protein compared to the wild type. So this is telling us that there's something happening in the cells which is preventing the degradation of the mutant protein. And that leads to accumulation of the protein in these beta-like cells. And so does that lead to any dysfunction of the beta cells? So just to remind you that there are other diseases where you have protein accumulation. One is Alzheimer's disease, shown on the top here. And so Parkinson's disease, these diseases are because of accumulation of these proteins within these cells, which are important for optimal function. So it's possible that the MODY8 could also be a defect of this accumulated protein. So can we show what happens to beta cell biology when this mutant protein is getting accumulated? There are 2 points to make here. One is that we can demonstrate that if you take these, in this case, we use HEC cells because they can secrete the protein much, much higher. And so you take the culture media, put them onto the beta cells, and we can show that there is a growth arrest shown by Ki67. This is a fact sorted Ki67. You can see that in the wild type, it's slightly higher compared to the mutant. So it's not dramatically that different, but significantly different. But the amount of apoptosis is also significantly altered in the case of the mutant versus the wild type, shown on the right. So you can see that the proteins which are important, which are P16 and P21, which are important in maintaining the cells, are elevated. The P16 is elevated in the mutant, whereas P21 is lower in the mutant, and both of these would lead to enhanced apoptosis. So you're pushing the cell to grow less and to become much more prone to cell death when you have more of this mutant protein. What about the function? It also leads to impaired beta cell secretion. So shown here on the top is what happens to a number of these genes which are important for identity and the secretion and synthesis of insulin. And you always see that if you just eyeball this, the ones with the red dots are always lower compared to the one with the blue dots, suggesting that all these genes are expressed to a certain lower level in the mutants. But what about the secretion? You can also see that the secretion, there is a defect shown on the left panel, glucose-stimulated secretion. Comparing, you can see that the red bars here, the basal secretion is higher, in fact, which is also a defect in these patients with diabetes. And you add glucose, and that does not lead to even further increase compared to the empty vector, which is a control, and the wild type control. And one can do a stimulation index, and can see that significantly lower. So I've shown you that if you take these culture media, which are containing the mutant protein, first of all, the beta cells take it up at a higher level compared to the wild type protein, and it leads to a defect in growth arrest, growth of the beta cells and beta cell apoptosis, and also leads to beta cell secretory dysfunction. So just summarize this part of the talk, we realize that the defect actually is the release of the mutant protein and being taken up from the beta cell is potentially what is happening in these patients with MODY. And normally it leads to, in the normal situation, the endosomes are very active, and these cells are able to endocytose and discard the protein. But in this case, there is aggregation, leads to growth arrest, altered gene expression, and ER stress. So how do we move this forward in the context of the humanized approach? And so everyone always criticizes that everything is in vitro. So we took two approaches for that. One is to begin to look at a humanized mouse model. So what did we do here? We decided to go back to the stem cell approach. So we took ES cells and we generated pancreatic progenitors. And just to remind you that the pancreatic progenitors are able to generate beta cells and SNR cells. So we argued that perhaps we need to look very carefully as to what may be happening in the mutant SNR and beta cells at the same time. So if I remind you, the earlier study that I mentioned to you was we focused only on the beta-like cells or only on the SNR-like cells. But here we wanted both of them to be together so that you see when the mutant SNR cells are being present in the same environment as the beta cells, then the beta cells must be taking up this protein. So we generated this model where you have both SNR and beta-like cells being generated, and then you transplant these ESCs into the mouse model, and then study what happens to SNR-like cells and beta-like cells over a period of time. And here was a very, very interesting finding. So when you look at the graphs over a period of time, like 8, 12, or 16 weeks, you can see that when you look at the wild type beta-like cells, when you expose them to glucose stimulation, there is a significant increase from 8 weeks to 12 weeks of age. In contrast, the mutant, you still see an effect, but this is somewhat blunted. When you take out these graphs and do an actual stimulation experiment, it's even more evident. So these beta-like cells, which have been exposed to the mutant SNR cells in vivo, when you take them out and do an experiment in vitro, you can see that the wild type is responding to the glucose over a period of 30 minutes, whereas in contrast in the mutants, the response is blunted. So this is actually still in vivo. Apologize for that. So the response in the wild type versus the mutant, you see that in vivo there is a response, but this is absent in the mutant. And this is just an example of the graphs that we see, which have been stained for insulin in green, trypsin and CK19, to show that both the wild type and the mutant, you have increased amount of the CK19. One can quantify that in the mutant graphs. So what about the total number of beta-like cells? Can we quantify that over this period of graph analysis and see whether there is an alteration in the total number of beta-like cells? And we can do that, again shown as immunostaining for CEL in green, insulin in red, and DAPI is the nuclear stain. Left is the control, and then here is the mutant, and the fetal pancreas, the human fetal pancreas is again a control. And you can see that clearly you have expression of SNR cells and beta-like cells, and one can quantify this. And you can see the proportion of SNR cells is much higher in the mutant compared to the wild type. But importantly, the number of beta-like cells are much lower. And so this is significantly different between the two, and just want to emphasize that we start off with the same number of cells between these two groups. For some reason, when the beta-like cells are exposed to mutant SNR cells, the number of beta-like cells decreases over a period of time. So this would argue that perhaps this is one of the defects which might be happening in these individuals. Can we also show that there is a defect in proliferation in these beta-like cells, which have been, again, exposed to mutant SNR cells over a period of time? So shown here is an example of immunostaining for beta-like cells. You can see this is Ki67, which is shown here, a large number of beta-like cells in the wild type. And the mutants, again, you can see that the number of beta-like cells are not so high. And the number of insulin Ki67 positive cells are significantly lower, as quantified on the right. So I've shown you that you can develop a humanized model where you can take humanized SNR-like cells, which express the mutation, and co-culture them with the beta-like cells, very similar to what may be happening in vivo in these individuals. And over a period of time, the beta-like cells begin to grow less, the total number of beta cells are lower, and they have a dysfunction in their secretion. So many of these things we think may be happening in MODY8 patients. So finally, I think that I just want to show a couple of points here. One is that when you transplant these beta-like cells in the islets with the mutant SNR cells, the amount of protein that is taken up in the mutant beta-like cells is much higher. So again, if you go back to the first few slides presented in the in vitro model, we can show the same thing in the in vivo humanized model, where you see that the insulin cell positive cells are similar between the wild type and the mutant, but in the case of the mutant, the amount of protein is significantly higher. So this would again argue that the mutant protein is being taken up by the beta-like cells and potentially not being degraded. So all that is fine. Can we tie this back to the patient's pancreas in terms of what we have seen so far? And as you can imagine, getting these pancreas from these patients has been very challenging. There are only 5 families in the entire world. But we were lucky to get 2 samples of these individuals, unfortunately, who passed on for several reasons. So we could collect pancreas from patients with MODY, and then we looked at specifically the points that we are trying to emphasize what may be happening. So shown here is a control individual, a person who is non-diabetic, the same age. Here's an individual with MODY8. You can see that the number of beta cells with stain for red are significantly reduced in this individual with MODY8. Here is another H&E stain, hematoxylin eosin stain of the pancreas from a patient MODY8. Here are the islets, and you can see there's a lot of fibrous tissue of these. The islets are embedded in an amount of fibrous tissue and adipose tissue. So there's something going on with the SNR cells, obviously abnormal. But one can then, immunostain for all these different cell types and quantify this. And you can see that the total number of insulin positive area in the islets is significantly lower in MODY8. And we have tried to match this as much as possible in terms of BMI, gender, and age, and so on. The number of glucagon positive cell numbers is significantly higher. So suggesting that this could be one reason in these individuals that the total number of beta-like cells is low because, as I mentioned to you, they could be dying. And we can also look at markers of the beta cells, and I'm not going to go into detail. It's all in the manuscript, which we can show. But just to point out that there's also markers of ER stress on the top right panel. BIP is a marker of ER stress, and so comparing the control versus the MODY8 islet, you do see some amount of ER stress. Again, this is just one section and needs much more quantification, but we were really excited to see that we could identify that. We can also look at the presence of the cell protein in these beta cells. So again, here is the control individual who's been stained for CEL, insulin, and DAPI. You can see that insulin is in green. In MODY8, again, you can see that the distribution of the beta-like cells is much lower. But when you quantify this, you can see that the wild-type beta cells don't contain the CEL protein at all, likely because they're degrading it. But the mutant beta cells in the patient with MODY8 contain a large number of mutant protein. So again, this argues that the mutant protein is being taken up by the beta cells, it's forming aggresomes, and leading to defects in beta-like in the ER stress in the beta cell, and leading to death and dysfunction. So I hope that I've argued from an in vitro model where we show that in healthy conditions, the wild-type carboxyester lipase, which is present in the SNR cells, because of the close proximity of the SNR cells to beta cells, is being taken up by the beta cells. And I've not gone into much detail as to what are the interactions in terms of desmosomes or pores or other communication channels between SNR cells and beta cells. And we discuss this in the manuscript. But this is an area of a large interest. It's a very hot topic right now in terms of crosstalk. And so this does not lead to any aggregate accumulation, as we showed you. It leads to regulated uptake by the endosomes and degraded by the lysosome. Whereas in MORI-8, I think that I've shown you by 2 or 3 different approaches, especially including the humanized model, where we transplant acinar cells with the mutant protein and the beta cells by 2 different approaches, and show that the mutant, the CEL protein, is taken up by endocytosis. And we also argue why exactly it's endocytosis. We've done multiple experiments to pin down that it's endocytotic process taken up by the beta cell. And this does not lead to this late endosome lysosome, but in fact, maybe part of it could be going through the lysosome, but most of it leads to these agrosomes. That leads to growth arrest, altered gene expression, ER stress, and impaired function. So we have finally nailed down the defect in MORI-8. It's taken a while, but I thought I'd just give you an example of how you go from bench to bedside. And now we're ready to begin to look at, we know the defect, and now we can begin to think how exactly we can handle the treatment of these individuals with MORI-8. But this gives you one example which could be applicable to other diseases as well. So I think I'm running out of time, but I'm glad I planned my talk with a fewer slides. And so I think I'll stop there and just say that it's looking like this now, but in a few hours we're expecting a snowstorm, so it won't be like this anymore. But thank you again for your attention.
Thank you, Rohit. Wonderful as usual with the way you made it so simple, thinking about how to take bench from bedside. While you wait for a couple of questions, can I just ask you, what is the function of the physiology? What is the function of the aggregate that goes into the beta cell? So clearly, the beta cell is not taking it just like that because it's available there, right? Do you think that the acinar cells are sending a message to the beta cell in physiology generally?
Yeah, that's a great question. And I think that's going to be the topic for many of us to understand in more detail. There are a number of studies which are going on right now to address this. It's a very, very hot topic. But there are areas in the normal acinar beta cell interface to argue that the products from the beta cell can go into the acinar cell, and products from the acinar cell can come into the beta cell. And so whether this gets dysregulated over a period of time is something that we have shown for MORI-8, for example. But there's more incentive now to argue whether this actually is happening in both type 2 diabetes and type 1 diabetes. And also to mention that CEL is a risk gene for type 1 diabetes. So we are inclined to think that some of these things could be happening in type 1. And in fact, some of us are doing some similar experiments to see what could be happening. But going back to your question, yes, it's very likely. I mean, isn't it amazing that only 2% of these islet cells exist with so many acinar cells around, and there's no communication going on between these 2 cell types? Theologically, I think it does make sense. And the question is, how can we nail it down and how can we prove it?
Can I just extend this to ask you, there is an aggregate that is seen in pancreatic beta cells, and we know that for years, and that's amyloid, right? Are there parallels?
Yeah, so amyloid is clearly seen in the beta cells, and so there are some other examples too. But I think that the question is, are they initiated in the context of diabetes? And so specifically focusing on type 1 or type 2 diabetes, what type of protein is accumulating and how exactly it's functioning over a period of time, or whether the normal beta cell is so efficient that it's able to degrade this quickly and move on. So we still haven't got a handle on how we can look at this very carefully. So, for example, one can do single cell RNA sequencing and also single cell proteomics, perhaps, and look for proteins which are of acinar cell origin at different time points. So, those type of experiments, I think, need to be done and potentially are feasible.
My last question, and I'm putting out on a limb here. What are the implications of this for example, understanding the physiology of type 2 diabetes? So you said that there is a reactive oxygen species. So clearly the electron transport chain at some point of time is getting hit, or there is an ROS generation. So do you think that the efficiency of the cell itself is affected?
Yeah, it's all of the above. I mean, it's possible, right? Because I think the type 2 is like a large bag, which each one of us have our own favorite defects, glucotoxicity, lipotoxicity, ER stress, mitochondrial stress, you name it, insulin resistance, amyloid deposits. So I think there are a number of things which are probably functioning in type 2, but some of us think that perhaps we're missing a very early signal because it's very unlikely that the cell is so inefficient that it allows so many defects for it to occur before it starts reacting. So there could be a defect very early during the transcript generation rather than the protein generation. Because if you look at how the dogma is that you have the DNA, transcript, and protein. So why wait until the protein is formed by the beta cell and then start correcting itself? So we have been looking at M6A methylation as a very early defect, right? The transcripts could be regulated by M6A methylation. Number of transcripts. Transcripts are important for ER stress, and a number of other processes. So maybe the defect is very early, and then we need to correct that at that early stage to overcome the defect in type 2. But that's a topic for another talk.
So the last question is very personal, right? How do you make this so simple? I can think of the step now. Your entire talk, I can summarize it in 6 steps and go away. But it took a lot of time, didn't it?
I have to concede that Dr. Arvind had something to do with it, because every time I gave a talk, he always said, I really didn't follow this. And so I thought that maybe I'm just not communicating well enough. So that allowed me to hone my skills on talking and giving a much simpler, so the lesser the better, right? So I think in that way, Dr. Arvind allowed me to improve my talks. So thanks.
Yeah, that makes the two of us, because he's doing this for many, many years to me.
Before we leave you, Rohit, I still have a question which has been sent to me by one of the delegates who is watching this. He appreciates your talk and then says it's a great effort, congratulates you on all your efforts. He is very happy that you passed out of Bangalore Medical College. But now he wants to know, what are the implications for treatment? Will this finding change any of our treatment in the future?
Yeah, that's a great talk, and that's what we are beginning to. So with our colleagues who are working on MODI, I mean, I'm in touch with also Lou and others who are experts in MODI. But here is an example of where I think that approaches to dissolve that protein in the beta-like cells would be relevant. And so we are trying to see whether we can undertake those types of experiments, first of all, in a mouse model, and see whether we can, but at least we know what the defect is, right? We never knew what the defect was for so long. So now that we know what it is, we can undertake translational approaches to see whether we can find small molecules which can improve beta cell survival and dysfunction, and whether that can be tagged on. Right now, I think it's oral hypoglycemics and insulin therapy for these individuals, which is the standard. But clearly, it's not solving the problems. It needs to be much more personalized for this. So I think the personalized precision medicine approach would be what we want to.
While we wait for that, though, thanks for this.
Thank you, Rohit.
Amazing class on physiology. This is amazing.
Thank you, Rohit, and thank you, Krishna, for taking this session. I think with that, we'll end that session of Dr. Rohit, and I would like to now call upon Dr. Shrikanta. Shrikanta, thanks for being there for us. And you have spent a lot of time with Dr. John Buse and so many others in the US. And I don't really have to introduce Dr. Shrikanta to the Indian audience, but then he's been like a mentor, he's been like a guru to many of us. And then he runs this medical center called the Samatvam with Science and Research for Human Welfare Trust. He has spent a lot of time in India and in the US. He's been a part of the Jocelyn's team for many years. And I would like to now call upon Dr. Shrikanta to actually introduce Dr. John Buse. But before that, I have a small announcement just to avoid the internet difficulties in the last minute. Dr. John Buse and Clara have sent their recorded lectures. So after you introduce Dr. John Buse, we will run the recorded lectures, and I can see that Dr. John Buse is already there live. So he'll be there to take the questions live. Over to you, Dr. Shrikanta.
Shri Hari Om, Shri Hari Om, Shri Chidananda Rupa Shivom Shivom, Shri Chidananda Rupa Shivom Shivom. Dr. Arvind, Krishna and team, it is a good fortune to be with you all in the noble mission you are doing, and particularly thankful for the opportunity to introduce John Buse. I will divide this into two quick parts. First, what has been summarized by the organizers. John Buse, MD, PhD, is the Verne S. Cabanis Distinguished Professor, Director of North Carolina Translational and Clinical Sciences Institute, and Senior Associate Dean for Clinical Research at the University of North Carolina, UNC. He has served as signatory PI of the University of North Carolina Clinical Translational Science Award since 2005, as a member of the CTSA program, steering committee member since 2019, and as a co-chair for 2021. So rightly, John Buse is based in North Carolina, in the University of North Carolina. Buse completed service as a president of the American Diabetes Association in 2008, and in 2019 received the American Diabetes Association Outstanding Award in Clinical Diabetes Research. He has authored more than 400 publications. In a more personal way, it was in the year 1981, July, that I met John Buse when I was a first-year fellow at the Duke. He was an MD, PhD student with Dr. Harold Leibowitz. And from that time, he moved with Professor Eisenbach's team to Joslin and Harvard in 1982. And to summarize our association, for me, John represents everything I learned from United States of America, a great nation, a great culture. First, science. He was very passionate and driven with science. So he was though he was younger to me, he was a role model in science, role model in medicine, and everything about United States professionalism, culture, mannerisms, the gregarious nature, the most friendly person in the lab. And after his marriage, he visited India. I helped him, and we had the pleasure. He met even my parents in Bangalore, and we hosted him in the Century Club. He still reminds me, Sir M. Vishweshwaraya's going of learned living. He met my 95-year grandma. Again, we met 30 years later when he came and spent time with us. And most fortunately, he sent his daughter, Carolyn, who was a music graduate, a violinist from University of Michigan. We had the pleasure of having with her at our home. She did a rotation in medicine with us and learned violin and medicine in the Mysore. So it's a more than a professional relationship. Over to you. But one more thing I want to tell you, John Buse's parents, Maria Gordon Buse and John Buse Jr. are in front of me. And we used to meet them. They're very illustrious meeting. If Arvind permits, I would like all of you to just Google Maria Gordon Buse, Maria Buse Diabetes Care. The article in Diabetes Care is called A Family Affair Through 6 Decades of Diabetes Discovery. It's a beautiful story of a young person migrating from Hungary, science, working with Nobel laureate. So Maria Gordon Buse, A Family Affair Through 6 Decades diabetes discovery in diabetes. Please go through. It will give a real picture of the illustrious medical scientific family he hails from. Over to Arvind. Thanks a lot.
Would you like to take the lecture live, or can we play the recorded lecture?
I think because I'm at home, it's better to give a recorded lecture, but Shrikanta, thank you so much for that wonderful introduction. And I would just update you that Caroline, based on, in part on her experience with you, is now a second-year medical student who finished her required coursework yesterday.
Oh, she graduated.
Yes.
Thanks a lot.
Thank you. With that, I think I will request the IT team to start the lecture of Dr. John Buse. Of course, he's there live with us, and he will be taking all the questions after this and Dr. Clara's talk.
Good day. It's a pleasure to be able to talk to you about patient-centered care, particularly in the context of type 1 diabetes. My name is John Buse. I'm a professor of medicine at the University of North Carolina in Chapel Hill. Here are my disclosures. So just as a reminder, I think as clinicians, we generally think a lot about prevention of the chronic complications of diabetes, but often forget about the acute complications of diabetes because they're more common. So hypoglycemia, almost an everyday occurrence for many patients with type 1 diabetes, sometimes severe, even disabling or fatal. And diabetic ketoacidosis, though not as common as hypoglycemia, is a near-term complication for many patients with diabetes, with national data, at least in the United States, of incidence of about 5 to 10% overall. And again, though this is not as frequent as hypoglycemia, it can be fatal. So the need to balance acute and chronic complications in our thinking is really important, and I just provide this as a reminder up front because I do think it's important in the patient-centeredness of the care that we delivered. So it is important to recognize that type 1 diabetes is a very high burden disease. And what I mean by that is that people with type 1 diabetes never get a day off from managing it. It requires 24-hour-a-day attention, 7 days a week, 365 days a year for the rest of a patient's life. And that attention includes glucose monitoring, either by frequent finger pricks or continuous glucose monitoring, attention to the details of meals, not only the quantity, but the distribution of nutrients, particularly carbohydrates, and the impact of physical activity, stress, and unrecognized intercurrent events. The essential element of management is that insulin needs to be administered continuously, which requires either multiple daily injections or the use of an insulin pump. And both CGM and pump, these technologies, are associated with very helpful alarms that disrupt patients' lives. The net result of all of this is often exhaustion on the part of patients. Some people have frankly reach the place of almost terminal exhaustion and require fairly aggressive intervention to turn things around. Other people, their enthusiasm for managing their disease waxes and wanes, and we just need to be aware of that. And I think the most burdensome aspect of all of this is weighing the sort of very scary long-term complications of diabetes, blindness, amputation, kidney failure, heart attack, strokes, with the near-term and almost everyday occurrence of hypoglycemia, which is uncomfortable and is recognized to have potentially fatal or disabling consequences. So there's this just constant overhang of potential bad outcomes in patients with diabetes that really is a burden in addition to all the behaviors that are required. And despite our many clinical advances, the outcomes in patients with type 1 diabetes are not very good and haven't gotten better over the last few years. in the left panel, you see hemoglobin A1C is a function of age. The orange line is data from 2010 to 2012, and the blue line from 2016 to 2018. These are from some of the best diabetes centers in the country. The first thing that's obvious is we're not doing better with regards to the A1C levels attained recently. And the second is we're particularly doing poorly in patients that are relatively young, under the age of 30, with average A1Cs generally above 8%. In the middle, the one piece of good news is the dashed line is the case fatality rate for diabetic ketoacidosis. That's going down, but the actual incidence of DKA hospitalizations is increasing. And on the right, the incidence of hypoglycemia hospitalizations is also increasing. And at least in the United States, hypoglycemia hospitalizations have now exceeded DKA hospitalizations in patients with type 1 diabetes. What's the path forward? I think the critical element to getting to a better place in diabetes management is the consistent and absolute recognition that it's really the patient that's managing their diabetes. They're the ones that are making multiple decisions every day about insulin doses and activity and diet choices and the timing of behaviors. All the critical decision making is being done by patients, and it's being done all day long. We as providers at best are coaches, and we just need to make sure that in our coaching that we are respectful of the role of the patient, recognize their right to autonomy, and engage them in such a way that is effective in improving outcomes and with a shorter time scale and improving behaviors over time. What's the path forward in that regard? I think the first thing is to make sure there's alignment on the part of the patient and provider with regards to goals. So from a patient-centered perspective, almost always the first line interest of the patient is to resolve symptoms and prevent acute complications. This is obviously very important in the beginning, where patients generally feel terrible when they're first diagnosed with diabetes, and they just want to feel better. And as we get to the second phase, it's really a focus on sustaining quality of life that's most important to patients. They want to balance the complexity of their treatment regimen, the glucose monitoring, the insulin, the diet changes, the amount of time and education is required to become proficient in their diabetes self-management. This complexity is often a burden that's very hard for them to incorporate into their lives. For many patients, avoiding weight gain is really important. For many patients, it's the side effects of the ancillary treatments in diabetes that occupies a lot of their thoughts. And one thing that we don't pay enough attention to is the financial aspects of diabetes care. Specifically, patients with diabetes, just like everybody else, have a budget. They need a certain amount of resources to be able to care for their family, to maintain their quality of life, and we can't expect them to just have a blank check for diabetes care funding and care. So these issues around sustaining quality of life are really important. They're complicated. They require time and focus for the provider to understand with the patient. And then the prevention of the chronic complications is almost always the focus of the provider. This, I think, is derived from the DCCT trial and the really sort of seminal information that improving glycemic control over decades results in lower risk of chronic complications. But for many patients, this 20-year horizon to potential blindness or amputations or kidney failure is just not really their focus day to day and week to week. And so as providers, we need to make sure that our focus is shared by the patient, or that we share their focus. And the one way to bridge chronic complications to the sort of more short-term focus of many patients is to help people understand how sustaining quality of life does include a need to prevent chronic complications, at least for their quality of life in the future. But doing this in a realistic way and honest way is essential to achieving a good partnership with patients in their diabetes care. And then it is important to recognize that this focus on goals changes over the lifespan. So later in life, when the life expectancy is shorter, we don't need to focus as much on the 10 and 20-year horizon of many of the chronic complications. We need to have more short-term focus. And in patients whose motivation and adherence is flagging, we need to refocus on the goals and help people understand how it is possible for them to perform certain behaviors to achieve the goals that they want to achieve. So what is the path forward for actually achieving these ends? And I think the critical element is so-called empathic patient-centered care. And this comes from an understanding that people with diabetes live with multiple chronic conditions, not just medical conditions, but social and behavioral conditions. We as providers, but also our clinic staff and the entire healthcare system need to prioritize the delivery of empathic, individualized, patient-centered care. We have to help people understand, each patient, what their best management option is to achieve their short-term and sometimes intermediate or even long-term goals. And to be able to do that, we need to understand their personal, social, and biomedical context. The patient understands this viscerally, but the provider needs to understand that as well, and his or her values. And of the treatment options, which are many, from food choices, insulin choices and how it's administered, monitoring choices, screening for comorbidities and complications, behaviors that are repeated day after day after day. Of all those available options, we need to help the patient understand the relative contribution of each of them with regards to benefits, harms, costs, and inconveniences. And this, if you really think about it, is an overwhelming set of sort of understandings to develop with the patient. But I would posit that if you focus on understanding the personal, social, and biomedical context and really embrace that, the empathy will be derivative of that understanding and really help channel your advice and counsel with regards to the available options and helping patients understand how they would fit into a totality of a diabetes self-management plan. I think it's really important that that providers remember the everything else of medical care. And this came from a blog in the New York Times many years ago in thinking about the placebo effect, that it's not really the pill that drives the placebo effect, but the everything else. And it's so beautifully put, how caregivers describe their medication, how they administer it, the expectations they have for the medicine, their tone of voice, the strength of their eye contact. In short, everything that doctors and nurses do in an interaction with patients. Now that we have these incredibly powerful interventions, many providers give short shrift to the relationship with patients, the trust, the need to help people retain motivation for caring for their diabetes. Everything else is really critical to get from a sort of opportunity that we might achieve the treatment goals to the reality of achieving the treatment goals through diabetes management and support. And there are data to support this contention. So this is a survey of patients where they were asked about the nature of their relationship with providers, and those that characterized their relationship as good in the pink bars had better diabetes control, better adherence to intervention, and less diabetes distress. The path to successful management is, again, this empathic shared decision-making on an individualized basis, making sure if the patient is going to be the main provider of their diabetes care, they need extensive diabetes self-management education. They need to understand pharmacokinetics of insulin. They need to understand the nature of foods and how the quantity and quality and distribution of nutrients is important with regards to the glucose profiles, et cetera, et cetera, et cetera. This is a very complex set of trainings that we need to provide to patients, and it has to be done in a comprehensive way, whether by a diabetes educator or through another technique. We need to continuously reassess patients with a focus on preserving adherence and persistence, and we need to avoid clinical inertia, the sort of trap that patients and providers often fall into, where we just sort of accept the current clinical state as not being modifiable. That's almost never the case, and I think patients really appreciate the sort of constant exploration of, could we do this better? Could we do that better? Is this new option something that you want to consider? And moving on from a sort of positive and forward-looking way, as opposed to just maintaining the status quo. There's been a lot of development of new products and technology in diabetes, and we often get seduced into the sort of essential nature of all of these advances. So we now have ultra rapid insulin analogs all the way to very long acting insulin analogs, and under development once weekly formulations. And in general, many patients benefit from one particular agent more so than another, and exploring these is important. But remember, for many patients, the critical issue is the cost of insulin, and therefore we need to be proficient in using human insulin, regular short-acting insulin, NPHs, and intermediate-acting insulin in managing type 1 diabetes. 20 years ago, that was a skill that every diabetes care provider had. We can do very, very well with this, so when it is important that for budgetary reasons we use short and intermediate acting insulin, we need to be able to embrace that. Continuous glucose monitoring has been a tremendous advance for many patients. It allows them to quickly develop new understanding of how diet and physical activity and the timing of insulin and the quantity of insulin, all those things affect the glucose profile. Many patients find it transformational. In fact, I would say that at least the people that I have asked about it, if they had to give up one or the other, most patients would give up their insulin pump before their continuous glucose monitor. It also, in the context of insulin pump therapy, as sensor augmented pump therapy allow many patients to achieve better control with less hypoglycemia in a way that wouldn't be possible before. So this is an important advance. But there remain unmet needs. As we spoke earlier, A1C should be lower, particularly early in the course of the disease. Weight is a concern for many patients and their providers. Severe hypoglycemia is really an important and immediate complication, a barrier to advancing better glycemic control, and frankly, a potential cause of disability or death. which may be as common or more common than the chronic complications we usually think about. Diabetic ketoacidosis remains an issue, and we can address it. And whereas we have largely eliminated blindness and amputations in type 1 diabetes populations with good access to care in the United States, based on the great interventions of ophthalmologists, podiatrists, and vascular surgeons, in the best practices, chronic kidney disease and cardiovascular disease are still quite prevalent and an important cause of morbidity and mortality. Will these be eliminated by these emerging technologies? Probably not. I think the emerging technologies will help, but we need more and better treatments. Some of the stuff that's coming is based on understanding of the pathophysiology and natural history of the disease. So patients are born with a genetic susceptibility. The notion is that an environmental trigger starts an autoimmune process that results in the selective destruction of beta cells until insulin is required to prevent hyperglycemia and ketoacidosis. There are studies working at prevention strategies using things like immunization. There are many studies using immune therapies to block the autoimmune process, either trying to preserve beta cell function at the end, or more exciting, trying to prevent the progression to the requirement for insulin during the natural history of the disease. And lastly, lots of efforts at reversing diabetes through applications of various sources of beta cells. And I just point out that the Food and Drug Administration in the United States is evaluating teplizumab, an anti-CD3 antibody, to prevent the progression to phase 3 type 1 diabetes requiring insulin therapy. If this moves forward, this will set the world on its head with regards to type 1 diabetes, which has exclusively been a focus on managing the disease once it presents, to one of screening to recognize people early in the natural history of the disease to intervene to prevent the development of type 1 diabetes. And then just last month, there were a report of the first stem cell derived islet transplant to a patient with type 1 diabetes whose diabetes has been touted as cured. In fact, the patient requires immunotherapy to prevent the recurrence of autoimmunity. So I don't think it's quite a cure, but certainly a major advance for people whose lives are very disrupted by the management needs for type 1 diabetes. And a lot of work is being done about using type 2 diabetes drugs in the setting of type 1 diabetes. I think each of these interventions have little tiny things to perhaps consider in selected patients. The GLP-1 receptor agonists definitely have substantive benefits with regards to weight. I'll talk about the SGLT2 inhibitors over the next couple of slides, and my colleague Clara Klein will talk to you about glucokinase activators in the next presentation. So to summarize the findings of SGLT inhibitors in type 1 diabetes, on average across the programs, there's meaningful reduction in hemoglobin A1C, about 0.4% on average. More impressive with blinded CGM, a 3-hour increase versus placebo. And kind of amazing that despite the mean glucose going down, either no change or some reduction in the time in hypoglycemia, reductions in insulin dose, weight, systolic blood pressure, and improvements in patient-reported outcomes. People generally feel better on SGLT inhibitors in the setting of type 1 diabetes. The problem is diabetic ketoacidosis, and the scope of that problem is about a 4 per 100 patient years increase in relatively severe cases of diabetic ketoacidosis. This has nevertheless been approved in the European Union as an oral adjunctive treatment to insulin in patients with type 1 diabetes and a BMI greater than 27. I understand that dapagliflozin has recently withdrawn their marketing for patients with type 1 diabetes. This absolute risk increase of DKA on the order of about 4 per 100 patients per year is an important consideration, and there are patients who have died of DKA in the setting of type 1 diabetes. It is potentially manageable. There are many papers that review these issues. I think the critical issues are patient selection, and then ensuring that patients understand the need for monitoring blood ketones and for managing early ketoacidosis with carbohydrates and insulin. And I would suggest that you read these kinds of papers very carefully and develop very robust training programs for your patients with type 1 diabetes if you're going to think about doing this in your practice. So to summarize, the early diagnosis and treatment of type 1 diabetes emerging and a really unique opportunity with potential lifelong impact on outcomes and an exciting area of emerging science. Therapeutic inertia and medication persistence and adherence are critical barriers to optimal outcomes. This empathic, patient-centered, shared decision-making and support is essential to achieving optimal outcomes and does involve continued focus on improving lifestyle in an ongoing basis with empathic support. And how do I characterize what this means, this empathic, patient-centered, shared decision-making? It fundamentally boils down to teaching our patients and not preaching to them, and motivating them and trying to avoid castigating them, and remembering that the everything else of medicine is essential. The relationship that we establish with patients, their trust, their partnership. This is really the essence of personalized diabetes care. Thank you.
Thank you, Dr. John Buse, for that wonderful lecture. Now, Shrikanta, there is another recorded lecture of Clara Klein, and Dr. John Buse will be around to take the questions from that talk also. Would you like to ask him some questions now, and then again we come back? You are muted, Dr. Shrikanta.
Thank you. To introduce Dr. Clara Klein. Clara Klein is MD, PhD, fellow at University of North Carolina, Chapel Hill, in the Department of Endocrinology Metabolism, where John heads. Throughout her training, she's been working at the juncture of molecular biology, biochemistry, and endocrinology in both animal models of disease and clinical trial. Dr. Clara Klein has a number of honors to her credit and is the recipient of the Physician Scientist Training Program Grand Fellow Awardee at the University of North Carolina School of Medicine. She has a number of publications to her credit and is actively participating in a number of ongoing research projects. One point about John is his initial project was on the autoimmunity in the BB Vister rat, and we saw him blossom into a total clinician, physician, scientist. The central theme is translational science and translational medicine. And you might be happy to know that the government of India has taken translational medicine and science in a very big way. And that is what John and his science epitomizes. I think we will need John's support for the Prime Minister to guide translational science and medicine in India and develop a lot of collaborations. We'll be in touch with John. Take care. Over to the lecture.
IT team, you can start the lecture, please.
Good afternoon, everyone. Thank you so much for inviting me to talk to you about improving the care of type 1 diabetes through glucokinase activation. Today, I will tell you about some of the work that I've done with a pharmaceutical company called BTV Therapeutics on a small molecule glucokinase activator called TTP-399. Some of the data I'll present here was published in April of 2021 in Diabetes Care, and so I will spend a little bit of time talking about how the drug works and what we previously showed in the Simplicity-1 study. I will also present some exciting unpublished data from a phase 1 mechanistics trial that we conducted in the summer of 2021. In the end, I hope this talk will convey to you how excited we are about glucokinase activation and TTP-399 in particular for the treatment of type 1 diabetes. As a young endocrinologist and clinician scientist, I found it somewhat stunning that despite ever-expanding knowledge and technology, there is so much more to do and learn to improve the care of our patients, and particularly our patients with type 1 diabetes. Despite truly revolutionary therapies for the treatment of type 2 diabetes, treatment for type 1 diabetes remains almost universally insulin alone. In the United States, there are no FDA-approved oral adjunctive therapies for the treatment of type 1 diabetes, and despite more physiologic and faster-acting insulins, very few patients are achieving the American Diabetes Association recommended hemoglobin A1c target of less than 7%. And this is particularly true for our youngest patients, who will live with diabetes the longest and are therefore at risk for the most severe complications. But maybe even more interestingly, despite all of these advances, two of the more devastating complications are occurring at a higher rate. As you can see in this graph in the middle, the incidence of diabetic ketoacidosis hospitalizations has seen a sharp increase in the last decade, and this is also true for hypoglycemia hospitalizations. This is perhaps a little more obvious in this figure here, where you can see that there's been a substantial increase in the prevalence of hypoglycemia in the last decade. So much so that the Endocrine Society, as well as other agencies, are prioritizing addressing hypoglycemia. Interestingly, there are no therapies available that protect against these events. To date, most if not all of the adjunctive therapies tested in type 1 diabetes may improve glycemic control, but do it at the expense of increased risks of hypoglycemia and ketosis. There remains a very clear unmet need to identify therapies adjunctive to insulin that improve glycemic control without increasing ketosis or hypoglycemia. But if we move a step further, identifying an adjunctive therapy that protects against these complications would mark a very significant advance. What I hope to convey to you today is that we see real potential for glucokinase activation for the treatment of type 1 diabetes, not only to improve blood sugar control, but also to provide some protection against both ketosis and hypoglycemia. So how does TTP-399 work? TTP-399 works on glucokinase, which is the enzyme that catalyzes the first step of glucose metabolism or glycolysis, both within the pancreas and the liver. Glucokinase has unique properties that allow it to act as a molecular glucose sensor. Specifically, the kinetics of glucose binding is different than for other hexokinases, such that it binds at a much higher glucose concentration. And that glucose binds at a high glucose concentration is really important because in the pancreas, glucokinase activity leads to insulin secretion. And so you really only want glucokinase activity during periods of hyperglycemia. A second key property is that glucokinase is not inhibited by downstream products like glucose 6-phosphate, so that it continues to be active as long as glucose concentrations are high enough. Again, insulin should be secreted during periods of hyperglycemia and should only stop when hyperglycemia has resolved. There is strong genetic evidence that supports glucokinase's role in glucose homeostasis, as both activating and inactivating mutations have been described in humans that lead to dysglycemia. Particularly relevant to our discussion, inactivating mutations in glucokinase lead to heritable forms of diabetes like MODY2. And so you can imagine that glucokinase has long been a therapeutic target of interest for the treatment of diabetes. And yet development of glucokinase activators have been stymied due to unfettered activation of glucokinase within the pancreas, which leads to insulin hypersecretion and hypoglycemia. And as we've discussed, this is one of the major issues that have plagued other adjunctive therapies. Hepatic glucokinase, however, has several properties that differentiate it from pancreatic glucokinase. First, hepatic glucokinase has a unique interaction with a protein called glucokinase regulatory protein, or GKRP. During periods of euglycemia, GKRP binds glucokinase and sequesters it within the nucleus. During periods of hyperglycemia, glucokinase undergoes a conformational change, which releases glucokinase regulatory protein, and glucokinase is able to move into the cytosol, allowing glucose metabolism through glycolysis. Secondly, whereas pancreatic glucokinase is constitutively expressed, liver glucokinase or hepatic glucokinase is insulin dependent. In type 1 diabetes, where portal vein concentrations or the portohepatic insulin gradient is low, it is expected that glucokinase expression and glucokinase activity is also low. And therefore, if we could selectively restore hepatic glucokinase in individuals with insulin deficiency, it may provide a unique opportunity to improve glucose homeostasis without leading to insulin hypersecretion and hypoglycemia. TTP-399 is a small molecule glucokinase activator that activates glucokinase within the liver, but has no activity within the beta cell of the pancreas. Importantly, TTP-399 does not disrupt the GK-GKRP interaction. Thus, it maintains physiologic control of glucokinase and only promotes activation during periods of hyperglycemia. TTB-399 has been tested in patients with type 2 diabetes and demonstrated a favorable safety profile without hypoglycemia and a significant improvement in glycemic control over a period of 6 months. Prior to the Simplicity-1 study, no glucokinase activator had been tested in humans with type 1 diabetes. The Simplicity-1 study confirmed the ability of glucokinase activation to improve glycemic control, but it also gave us distinct hope that it could protect against hypoglycemia and maybe even ketoacidosis. The Simplicity-1 study was an adaptive phase 1b/2a randomized controlled trial to test TTB-399 in type 1 diabetes. Phase 1, or the Sentinel phase, was a 7-day dose escalation study to confirm safety and determine dosing of TTB-399 in subjects with type 1 diabetes. After safety was confirmed, Phase 2, or the learning phase, tested TTB-399 in 19 adult subjects with type 1 diabetes on insulin pump therapy and CGM. The primary endpoint was change in hemoglobin A1c, and when efficacy was confirmed, we expanded the study to Part 2, or the confirming phase, which tested TTB-399 in 85 adult subjects with type 1 diabetes and did not require CGM or insulin pump therapy. We don't need to spend too much time discussing the study outline, but I do think it's important to understand that Simplicity-1 followed an aggressive treat-to-target design, such that participants had to achieve a fasting plasma glucose of 80 to 130 prior to randomization to placebo or TTB-399. Once randomized, insulin was adjusted frequently to target a fasting plasma glucose of 80 to 130 and a postprandial or post-meal blood glucose of less than 180 with a peak of less than 200 mg per deciliter. This is very aggressive treat-to-target design, and so any improvement in glycemia was above placebo was seen on top of this aggressive treat-to-target adjustment in insulin. In Part 1 of the study, we saw significant improvements in glycemia, and this was again on top of this intensive treat-to-target design and in participants with already very good glycemic control with an average baseline hemoglobin A1c of 7.3%. As you can see, the treatment effect was a reduction in hemoglobin A1c of 0.7% compared to placebo. In Part 2, in a broader patient population, we observed hemoglobin A1c reductions of 0.3% compared to placebo. Again, this was on top of intensive treat-to-target design in participants with very good glycemic control, with an average baseline hemoglobin A1c of 7.6%. The reduction was more modest than that in Part 1, but the observed reduction is similar to that of other adjunctive therapies tested in type 1 diabetes, and so we were excited to see consistent and significant improvements in glycemia. But more excitingly, we saw a favorable safety profile. Treatment-emergent adverse events were similar between the groups. However, we found a trend in reduction of hypoglycemia and ketosis events. Post-hoc analysis of hypoglycemia events demonstrated a significant difference with a p-value less than 0.05. Ketosis events, defined as a beta-hydroxybutyrate of greater than 0.4 millimoles per liter at any study visit, were overall few. The study was not powered to assess statistical changes in ketosis events, and so while I think you can appreciate that there was a difference in the incidence of ketosis, post-hoc statistical analysis was not conducted, but we were encouraged by these results. You may be wondering, well, you highlighted that there was a very intensive treat-to-target design. Maybe participants who experienced less ketosis were just on more insulin, and those who were on less insulin were experiencing less hypoglycemia. Maybe changing the insulin really impacted the safety results. But that data really didn't bear out. In these unpublished data, you can see that the participants on TTB-399 experienced less ketosis and less hypoglycemia regardless of their insulin change status. The one patient here who had a symptomatic hypoglycemic event that was randomized to TTB-399 had no detectable TTB-399 in their blood. Perhaps most impressively, in the column on the far left, 67% of participants randomized to TTB-399 who had reductions in insulin doses also improved their hemoglobin A1c. And even with less insulin on board, these patients were experiencing numerically less ketosis events. When analyzed based upon their ability to make endogenous insulin, in patients who have undetectable C-peptide, which was about half of the Simplicity-1 participants, these patients experienced reductions in their hemoglobin A1c that were significant, but also had only a quarter of the ketosis events. phase 1 animal studies support this finding and may provide some hints at the mechanism of how glucokinase protects against ketosis. Prior studies presented previously at the EASD, but not yet published, demonstrate that animal models of type 1 diabetes treated with a hepatoselective glucokinase activator are also resistant to ketosis. In this experiment, streptozotocin treated mini pigs who have chemically induced destruction of beta cells and become insulin dependent underwent a 4-day insulin withdrawal test. As you can see in this figure on the left, during a period of 4 days of insulin withdrawal, treatment with TTP355, a glucokinase activator analogous to TTP399, delayed ketone onset. While we do not fully understand the mechanism of how it protects against ketosis, we suspect that the increased glucokinase activity allows for increased glucose metabolism in the setting of insulin deficiency and increased glycogen stores. These increased energy stores may be utilized during periods of insulin deficiency, which results in less ketone production. As you can see in this graph, there was numerically more glycogen in the TTP355 treated animals. This is also important for hypoglycemia, as improved glycogen stores may also protect against hypoglycemia. Again, here the mechanism of the adjunctive therapy matters, and the hepatic glucokinase activity has unique potential to improve glycemia and provide some protection against ketosis and hypoglycemia. To test this hypothesis in humans, we conducted a phase 1 mechanistic study to determine the impact of TTP399 on ketone levels during insulin withdrawal. Unfortunately, due to confidentiality, I cannot share all of the data with you, but I will share some of the data that was released by BTV in a press release in October of 2021. The study is outlined here. Briefly, we randomized 23 participants with no detectable C-peptide to either placebo or TTP399 1-to-1 blinded for 7 to 10 days, and then we brought them in, fasted, and disconnected their pump for up to 10 hours. Ketones were measured every hour for the first 6 hours and then every half an hour until 10 hours were completed or insulin withdrawal test cessation criteria were met. Stopping criteria included ketones greater than 3 millimoles per liter, glucose greater than 399 mg per deciliter, or bothersome symptoms according to the patient. Again, 23 individuals with type 1 diabetes with no detectable C-peptide on insulin pump therapy were randomized either to TTP399 or placebo. 12 were randomized to TTP399 and 11 to placebo. Demographics were well balanced with a hemoglobin A1C of 6.8% and 7.1% in the placebo and TTP399 arms respectively. The study achieved the primary endpoint, and that was to demonstrate non-inferiority relative to placebo. Again, that TTP399 does not increase the risk of diabetic ketoacidosis. And this meant that it met the proportion of subjects reaching pre-specified concentration limits of beta-hydroxybutyrate during acute insulin withdrawal was not different. There was no significant difference between active and placebo arms in the beta-hydroxybutyrate profiles or mean duration of the insulin withdrawal test. Most interestingly, though, the bicarbonate was numerically higher in the TTP399 group, suggesting a lower risk of ketoacidosis in those randomized to TTP399. We're also extraordinarily encouraged by the data from the 7 to 10 day treatment period. In those 7 to 10 days, individuals randomized to TTP399 experienced reductions in their fasting plasma glucose, such that the TTP399 group experienced a almost 30 mg per deciliter decrease in their fasting plasma glucose compared to 4 mg per deciliter in the placebo group, and this was significant with a p-value of 0.03. Treatment emergent adverse events were also fewer in the individuals treated with TTP399, and this was really encouraging from a safety standpoint. And then, even more excitingly, patients taking TTP399 reported no events of hypoglycemia, while 4 events of hypoglycemia were reported in the placebo group. This is particularly exciting because some of the biggest issues in type 1 diabetes is that push and pull between tight glycemic control, which improves long-term outcomes, and increasing insulin to achieve that tight control, causing acute, terrifying hypoglycemia. If TTP399 is able to provide some protection against hypoglycemia while improving glycemia, it may allow for improved outcomes across the board. Finally, that hypoglycemia was also reassuring, and that it was suggestive that TTP399 might protect against hypoglycemia was really encouraging because a phase 3 pivotal trial is coming. In the spring, the FDA gave TTP399 a breakthrough therapy designation, largely based on its impact on hypoglycemia. For that reason, hypoglycemia will play a more central role in the trial than it has in prior trials of adjunctive therapies for the treatment of type 1 diabetes. Details are being worked out, but I think this will be a very interesting trial, both from a design standpoint and also because we're so encouraged and excited about the glucokinase activator itself. I think this drug shows real promise, and I'm really looking forward to seeing the results of the phase 3 trial and hopefully getting this drug, if it continues to show exciting potential for improvement of glycemic control in hypoglycemia and potentially even prevention of acidosis, hopefully getting this drug out to our patients. So I'll stop here with a summary. Overall, the Simplicity-1 study confirmed the efficacy and safety of TTP-399 in participants with type 1 diabetes. Data from the Simplicity-1 study suggested that TTP-399 may have a role in protection of patients with type 1 diabetes from diabetic ketoacidosis and hypoglycemia. Our phase 1 study certainly confirmed safety and gave continued hope for prevention of hypoglycemia and potentially even acidosis. Larger and longer clinical trials are needed and are planned, and we're really encouraged about the future of glucokinase activation in type 1 diabetes with the hope of improving the care of our patients with type 1 diabetes. Thank you again so much for inviting me to talk.
Dr. Srikanta, if you're there, I think the floor is open for you to moderate and take the questions.
Any questions from the audience? Arvind is allowed?
Audience is absolutely allowed. I haven't received any on my chat box yet.
John, you'll take the question to Clara also?
Yes.
Yes.
2 questions. You know, several years ago, the Merck had the MK0941, the glucokinase activator acting on the beta cells. We were part of the phase 2 trials. That got abandoned because they developed high triglycerides and high blood pressure. What is the story of the beta cell glucokinase?
Yeah, this glucokinase activator, the TTP-399, is different in that it is hepatoselective in its action. So it doesn't have any effect on the beta cell, reducing the risk of hypoglycemia. But it's really the preservation of the interaction with the glucokinase regulatory protein that we think contributes to the lack of hypertriglyceridemia. The other thing that was noted in the prior compounds, there was often tachyphylaxis where the effect of the drug waned after the first few weeks. And we haven't seen that with this compound either. And the studies in type 2 diabetes have been completed. Some of them continued to 6 months. So, you know, I think it is a potentially exciting advance. There's another compound that has completed a phase 3 trial in China that is also advancing, you know, with this sort of glucokinase, hepatoselective characteristic.
You don't see a future for beta cell selective glucokinase activators? Beta cell selective.
You know, I often joke that my role in this whole process, I don't make the drugs, I make the drugs better. So it's not that I don't see a path forward potentially, but what I have read in the literature is that the non-beta cell selective ones, you know, have been vexed with hypoglycemia, which I think now is almost an unacceptable side effect profile for new drug development. You know, we just won't accept a drug that has hypoglycemia as a risk moving forward, I don't think.
1 or 2 minor questions. With the oral semaglutide being in the market, do you see any hope for oral insulin? The Bangalore did it, Biocon, it didn't read the people, the Israelis did it. Any hope for oral insulin like oral semaglutide Do you see anything in the horizon?
I do. I don't know anything specific. There's a very interesting technology out of MIT, which is a capsule that has like a little hook on it that you eat. You eat the capsule, and the little hook functionally is a needle. It delivers insulin into the lining of the intestine. And then there's a variety of formulation efforts that companies are pursuing. So I do think there's a possibility. I think the one problem we can get away with semaglutide, which is a very long half-life drug, is the variability in absorption. So with semaglutide, it doesn't matter because if you dose it every day and it has a half-life of a week, then you end up or a half-life of 2 days, and then you end up with an accumulating area under the curve. With insulin, perhaps these once-weekly formulations like insulin icodec, if you could deliver it orally, would similarly provide for basal insulin. And then another, sort of more consistent formulation for rapid-acting oral insulin might be possible as well.
Two last questions. The Vertex Pharmaceutical, the first person, do the new islets have to be protected from recurrent autoimmunity? Is it being immunosuppressed, or it doesn't need?
It did. I mean, and it took a little bit of time for me to sort that out fully. But yes, the Vertex technology requires immunotherapy. And what I understand, frankly, from the New York Times, is that the patient is on a relatively low dose of some immunotherapy, but has had a long remission of their diabetes with these stem cells.
The last question to John is, what is your experience and comment on the DIY, do-it-yourself artificial pancreas?
Yeah, my experience actually is excellent. We, for medical legal reasons, we don't tend to perform the patient education around how to do it yourself because it's not an FDA-approved product. We do support patients who are using this technology, and there are individuals within our community, pharmacists, diabetes educators who have type 1 diabetes, who have used these do-it-yourself products with great control. I mean, at least as long as it's working, it works really, really well.
Okay. Over to Arvind. Arvind, please take over, Arvind.
Thank you. Thank you so very much, Shrikanta. Thanks. And my heartfelt thanks to Dr. John Buse, who has made time. Even though he's on a holiday, he said that I will record my talk and send it so that I don't have to face any internet issues. Thank you so very much, John. It's been a long time we were able to catch you now, and thank you so very much for actually connecting us with Clara Klein, who gave a brilliant lecture on glucokinase.
John Lost, welcome back home. Both tell Caroline, everybody.
We're an Indian family is marrying into our family, so I'll be in India soon.
Take care. No virus in India. We are doing well. No, very little virus. Okay, God bless you. Thank you, John.
Thank you, John. And I think we'll move to the next session of two great scientific lectures that's going to come. And then I will invite Dr. Vijay Sarthi, a pediatric endocrinologist, and to introduce him, well, he's well known in the Bangalore circle. He's the professor and head of the Department of Endocrinology at the Vaidehi Institute of Medical Sciences and Research Center, Bangalore. Thanks for being there for us, Vijay Sarthi, and it's over to you. You can introduce the speakers and take it from there. And then my heartfelt, sincere thanks to both Camilla Evans and Maureen Gannon, who accepted to be the speakers for today's lecture. Thank you so very much. Over to you.
Yeah, thank you, sir. Good evening, everyone. So it's a time to have a wonderful discussion on a very challenging topic, how to modify the course of type 1 diabetes mellitus. To discuss the topic, we have an elegant speaker, Dr. Kamala Evans Molina. She is the Eli Lilly Professor of Pediatric Diabetes at Indiana University School of Medicine in Indianapolis. There she serves as Director of the IU Center for Diabetes and Metabolic Diseases and also as a staff physician at the Rodebush VA Medical Center. She's a co-executive director of the Network for Pancreatic Organ Donors with Diabetes, that is NPOD, and is a co-PI of the NIH Integrated Islet Distribution Program. Dr. Evans Molina's basic science research is focused on understanding how impaired calcium handling in the secretory pathway contributes to beta cell dysfunction in diabetes. She is also an investigator in the NIH-funded Type 1 Diabetes TrialNet, RADIANT, as well as TIDAPC networks. The podium is yours, Dr. Kamala. Please take over.
Great, thank you so much. Can you hear me okay? I'm going to go ahead and share.
Yes, we can hear you.
Okay. And are you seeing the right slide?
Yes, we can see your slides.
Okay, thank you. And you're seeing not the speaker view, but the regular view of the slides?
It's the regular view.
Okay, great. All right. Thank you so much for that very kind introduction and for the invitation to talk here this morning. Hopefully no internet problems. So I wanted to just start with my disclosures and give you a second to read those, but to highlight one, the one at the top, I'm going to talk about some compounds that were given to us in kind by BMS as part of this discussion. And as alluded to in the introduction, one of the things I'm going to talk about today is disease-modifying therapy in type 1 diabetes and what we've learned from past experiences and where do we go in the future. And actually, John sort of introduced this very nicely. We're at somewhat of an inflection point in the treatment of type 1 diabetes with the possibility that we might have the first disease modifying therapy approved in the US. So this is the drug is teplizumab, which is an anti-CD3 based therapy, and these results really come on the background of over 30 years of trial experience with this particular class of drugs. And the first studies that tested the efficacy of teplizumab in type 1 diabetes began in the early 1990s in animal models. And then this was followed by a series of studies performed primarily at type 1 diabetes onset, what we call now stage 3 type 1 diabetes. And then really what has pushed this, this potential decision by the FDA to approve teplizumab as a disease-modifying therapy is based on this study called the TN10 or TrialNet 10 study. And I want to show a few key pieces of data from that. And this study was reported out in 2019 with an update to the trial results in 2020. And this trial was somewhat unique from our other past trial efforts in type 1 diabetes. For many years, we pursued disease-modifying therapy at what we call stage 3 onset. So it's very typical in our TrialNet network to target individuals who develop diabetes within 100 days and then try to add an immune modulating therapy after stage 3 onset to see if we can reverse C-peptide loss. And I think largely the field would agree that we've had somewhat modest benefits with that approach. So in the around 2008 or so, there was this really big push to try to redefine the stages of type 1 diabetes so that we might target people earlier in the disease process with the hopes that we'd have a better response to immune modulating therapy. And so these efforts were based on results from birth cohort studies that showed that once you develop multiple autoantibodies, your risk of developing type 1 diabetes is very high. So in the particular birth cohort studies that were analyzed, your risk over about 10 to 15 years exceeds 80% if you have 2 or more autoantibodies. So this led to a redefinition of stage 1 type 1 diabetes as having 2 or more autoantibodies, but still having normal glucose tolerance. Stage 2 is defined as having dysglycemia on an oral glucose tolerance test and continuing to have 2 or more autoantibodies. And then obviously stage 3 is what we say is clinical onset of type 1 diabetes. And the teplizumab study that's led to its consideration as an FDA-approved agent was performed in very high-risk individuals in that stage 2. So they had 2 or more autoantibodies and already evidence of dysglycemia on an oral glucose tolerance test. And this was a very difficult study to recruit for because individuals were asked to come to our clinical centers and receive a daily infusion of the drug for 14 consecutive days. And it was a small study, 44 individuals in the teplizumab group and 32 in the placebo group. But there was really, I think, a remarkable response, especially if you compared it to our earlier trial efforts at the onset or stage 3. So we looked for progression from stage 2 to stage 3, and we observed a median delay in the diagnosis of stage 3 by about 2 years. And that was the original trial results that were published in the New England Journal of Medicine. There was an updated analysis in 2020 by Emily Sims and Kevin Harold, and this illustrated a continued benefit, and the extended median delay of stage 3 onset was about 32.5 months. So again, this was really heralded as quite a success in type 1 diabetes immunomodulatory therapy, but I want to point out some things, lessons learned from this study, and how that's really shaped how we're considering moving forward with immune modulating therapy in type 1 diabetes. The first is that we saw that teplizumab, when administered to these very high-risk individuals, really stopped this decline in C-peptide. And this is C-peptide, area under the curve graphed. And you can see that these individuals are extremely high risk. They're losing C-peptide in a very rapid fashion. And when you administer the drug, as you can see from the red line, there is this improvement in this decline in C-peptide. This is the drug-treated group, and this is a placebo-treated group. So take-home messages from this is a very high-risk group of individuals. They're losing C-peptide rapidly, and this drug is able to reverse that decline in C-peptide. Despite this reversal in the decline in C-peptide, though, what we largely observed is that they maintained dysglycemia. We were not able to reverse the large majority of these individuals back to normal glucose tolerance, suggesting that we're not completely reversing the defect in the beta cell. The other very interesting observation from this trial has to deal with the concept of heterogeneity. And this has been one of our most challenging concepts to deal with in type 1 diabetes disease-modifying therapy interventions, because there's quite a bit of heterogeneity across our populations. We know age really dictates your disease course, but there are a number of other factors, including your complement of autoantibodies as well as your HLA background. One of the most interesting to me as a beta cell biologist findings from this study is that when we performed what were pre-specified subgroup analyses, we saw that there was an improvement or a marked benefit in individuals who had the worst C-peptide. So we divided the population based on C-peptide AUC above or below the median of the group, and those in the lower median or the lower group had the best response, suggesting that those with worse beta cell function were really primed to respond. So this was importantly independent of age. We didn't see a dramatic effect of age in this particular study, which is a little bit unique compared to some of the other studies. But essentially this raises two questions which kind of form the foundation of the objectives that I wanted to talk about this morning. And these are really, are we best able to reverse type 1 diabetes if we target individuals in what we call this accelerated active disease of type 1 diabetes. So we know that these individuals in stage 2 are at very high risk. They're losing C-peptide at a very high rate. Are they uniquely primed to respond to a disease modulating therapy? And then as a beta cell biologist, I've been very struck by the findings related to the metabolic outcomes of this study, suggesting that we can do better at the level of the beta cell, which raises, I think, the important question of whether we might have better efficacy by combining immune modulating therapies with agents that directly target the beta cell. The important question here is what type of agent might we employ for this purpose? So this really, I think, is this concept is not new. It's something that we've talked about in the field for a number of years, and it's based on a number of really important basic science studies and studies using tissues from InPod, studies from another NIH group called the HERN, the Human Islet Research Network, and in particular the HPAP program there, where we've been able to analyze tissues from individuals who've passed away, who've had type 1 diabetes, and try to understand what are the molecular mechanisms that are happening within the beta cell that might contribute to disease pathogenesis. And these studies have largely developed this theme that the beta cell is not really just a passive participant, not a victim of the autoimmune assault, but rather there are pathways that are activated in the beta cell that directly contribute to disease pathogenesis that might, in fact, increase the immunogenicity of the beta cell. And a number of these pathways have been studied by many in the field, including some of the speakers in the lineup today, but they include pathways such as ER stress, mitochondrial dysfunction. We know there's marked MHC class 1 upregulation in the diabetic beta cell. There's release of chemokines that might serve as chemoattractants to immune cells. There's potential generation of neoantigens, and that's been linked with ER stress. And then we know also there's intriguing data suggesting that extracellular vesicles with autoantigens are released from the beta cell, and that these might pattern interactions with the immune system. And then finally, there's something called a senescence-associated secretory phenotype that's been more recently described by Peter Thompson and Anil Bashan. So in aggregate, this literature suggests that there are pathways that might be targeted in the beta cell that could potentially improve our responses that we see in these trials of disease-modifying therapies. So I wanted to spend a little time talking about one of these pathways, which is type 1 interferon signaling in the beta cell. And this has interestingly been linked with several of these deleterious responses in the beta cell, including signaling through the type 1 interferon receptor, and in particular interferon alpha, which is a very important cytokine at multiple stages in type 1 diabetes. And this has been linked to the production of chemokines and the upregulation of inflammatory genes in the beta cell, as well as the upregulation of MHC class 1, and then also endoplasmic reticulum stress. So these three hallmarks really of the beta cell response in type 1 diabetes. And I think what's also very important to think about is that these evidence of activation of this pathway or gene signatures associated with this type 1 interferon response are really evident at multiple stages of type 1 diabetes. I'm going to just show a couple pieces of data supporting this. So this is this first piece of data is a really elegant study by Annette Ziegler and colleagues in Germany. She looked at children who are at high genetic risk of developing type 1 diabetes and assayed their blood for interferon responses, and found that there was evidence of this type 1 interferon signature that preceded even the development of seroconversion. And it was also associated with viral infection and upper respiratory infection, which I think is really important to note as well. The second panel here is really just gene expression analysis from actually pancreatic biopsies of individuals in Scandinavia who had recently developed type 1 diabetes. So in this study, a small group of adults agreed to have a pancreatic biopsy after type 1 diabetes onset. And when gene expression analysis was done, there was a really strong evidence of a type 1 interferon signature in these biopsies. This study was stopped because, as you might expect, there were some adverse outcomes, but it's been the tissues that were collected have been really informative to the field to understand what's happening in the human pancreas. And then finally, this is data from our own group. We're able to collect blood from individuals who are admitted to our pediatric hospital within 48 hours of type 1 diabetes. And when we do whole blood gene expression analysis, we see that there's still remaining a strong response to type 1 interferons even at the time of type 1 diabetes onset in the blood. So this really paints the picture that this is an important pathway at multiple stages of type 1 diabetes, and that there might be some benefit to modulating this pathway. And so there are a couple of different ways that you can modulate this pathway. So again, we're really thinking about targeting interferon alpha, which is one of the most important of the type 1 cytokines. And interferon alpha binds this heterodimeric transmembrane receptor termed the interferon alpha receptor, IFNAR. And in a number of different animal models, if you block the IFNAR receptor, you can reverse type 1 diabetes or prevent type 1 diabetes in mouse models. Very intriguingly, there was a small study of oral interferon alpha that was performed in individuals who had newly diagnosed type 1 diabetes or stage 3. And this treatment with oral interferon alpha actually preserved C-peptide in this very small clinical study. But I think what's more important is that this has been an area of a lot of active drug discovery and investigation to target the downstream kinases, the tyrosine kinases downstream of the IFNAR receptor. And these are, of course, the JAK1 tyrosine kinase and TYK2. And these phosphorylate the latent cytoplasmic transcription factors, STAT1 and STAT2, and it's really the STAT transcription factors that upregulate a number of gene programs involved in inflammation and chemokine production. And there's been a lot of work on targeting the JAK side of this signaling cascade. And there are drugs that are approved for use in rheumatoid arthritis, alopecia, lupus, and psoriasis that are JAK inhibitors. Now, I'm going to show a couple pieces of data from other groups, including some data from Decio Zurich, who's a close collaborator. Decio is an investigator in Brussels, and he's been studying interferon alpha signaling in the beta cell for a number of years. And he has performed a lot of in vitro studies and ex vivo studies using isolated islets and human islets. And this is a study that he performed using baricitinib, which is a JAK1/2 inhibitor. And he showed that when you treated human islets and endo-C, which is a human beta cell line, with baricitinib at increasing doses, you could really block HLA class 1 upregulation, as well as inflammatory gene expression in these islets. And then MX1 is a gene associated with an antiviral response. And then you could also block ER stress responses with JAK inhibitor treatment. Helen Thomas, an investigator in Australia, tested this repurposed JAK1/2 inhibitor in NOD mice and showed that when you treated with this compound AZD1480, that you could both prevent the onset of type 1 diabetes in the NOD mouse model. You could improve insulitis, so there was less immune cell infiltration into the islet. And she also showed that you could reverse type 1 diabetes in this model. So when the mice became diabetic and then were treated with the drug, you could reverse hyperglycemia successfully with a JAK inhibitor. A number of other findings of importance included a reduction in beta cell MHC class 1 upregulation. Helen's group also showed that islets that were treated with the JAK inhibitor secreted less CXCL10, again, this chemoattractant substance, and there was reduced cytotoxic T cell activation and beta cell killing, and then again, reduced T cell accumulation in the islet. So I think based on these very impressive findings and really encouraging findings of targeting this side of the pathway, there is a trial ongoing in Australia that's led by Thomas Kay and Helen Thomas, and they're taking baricitinib, this JAK1/2 inhibitor that is approved in the US for the treatment of rheumatoid arthritis, and they're enrolling individuals aged 10 to 30 years of age who've been diagnosed again with type 1 diabetes within the last 100 days. So this is a stage 3 trial. It's a multi-site study in Australia, and individuals in the trial will be treated with baricitinib or placebo for 12 months and then have their C-peptide assessed at 12 and 24 months. So this is really the first study that will address specifically whether targeting this pathway has efficacy in humans with type 1 diabetes. So I want to switch gears and talk about the other side of the signaling cascade, TYK2, which is something that we've been interested in for several years now. So TYK2 is involved in both signaling through type 1 interferon receptors as well as IL-12 and IL-23 signaling. And there's actually some really interesting genetic correlates of TYK2 deficiency and polymorphism in TYK2 that have been informative to the role of this tyrosine kinase in autoimmune diseases. So there are some individuals who have been described that have autosomal recessive deficiency of TYK2, and they exhibit increased susceptibility to mycobacterial and viral infections. But what's, I think, most relevant to type 1 diabetes is the study of some polymorphisms in the TYK2 region. And most of the polymorphisms that have been linked with type 1 diabetes are in non-coding regions. Some of the SNPs in TYK2 happen to be in coding regions of the gene. And one of the most studied is this 2304256, which has been associated with protection against type 1 diabetes. And this causes a missense mutation in the protein, and there's actually decreased association with the receptor, the interferon alpha receptor, and then decreased signaling through this complex. And that's actually associated with a protection against type 1 diabetes. Now, all SNPs in TYK2 have not been protective in all autoimmune conditions, and this appears to be somewhat very specific to the condition that you're looking at. This is an analysis that was published looking at 3 different polymorphisms in the gene, and then looking across a number of different autoimmune diseases. And what you can see is that blue indicates protection, red indicates risk, that some of them are associated with increased risk in conditions like Crohn's disease and ulcerative colitis, but those same polymorphisms are associated with protection in type 1 diabetes, lupus, rheumatoid arthritis, and psoriasis. Now, drug discovery targeting TYK2 has lagged those efforts that have been focused on targeting the JAK1 tyrosine kinase, and they've taken a different approach. The JAK1, 2 drug discovery efforts have really focused on targeting the kinase domain, whereas efforts to modulate TYK2 activity have focused on stabilizing the pseudokinase domain of the molecule, and that leads to an autoinhibition of TYK2. And this is a study that was published not too long ago, really looking at efficacy of the first in the class, this BMS 986165, in psoriasis. And the drug did have beneficial effects in psoriasis, and showing really for the first time that this approach of targeting the pseudokinase domain had efficacy in an autoimmune condition. Now, BMS has led the way in this particular class of agents, and they've been working on developing drugs with improved PK and permeability. And I'm going to show some data from this drug 986202, which has an improvement in these chemical properties as compared to the one tested in psoriasis, and has shown some preclinical efficacy in conditions like acanthosis, lupus, and colitis. And we were able to obtain this drug from BMS and test it both in some in vitro studies, collaborating with Decio Zerik's group at the IBRI, and then in some in vivo studies using a couple different mouse models of type 1 diabetes. And so essentially in studies with Decio's group, we showed that if you treated, these are experiments done in endo-C cells, treated the endo-C cells, which is the human beta cell line, with interferon alpha, and then increasing doses of this TYK2 inhibitor, you could reduce inflammatory gene expression, and our main output here is CXCL10, reduce expression of MX1, and reduce class 1 upregulation in the endo-C cells. So based on this, these promising in vitro results, we wanted to test this drug in a couple different mouse models of type 1 diabetes. And the first model that we chose is a model called the RIP-LCMV transgenic mouse model. And so this is essentially a transgenic and virally induced model of type 1 diabetes, where the beta cells have been engineered to produce these immunodominant epitopes of the LCMV virus. And when you then challenge the mice with LCMV, you get expansion of these CD8 positive cytotoxic T cells that are specific for the beta cells. And so this leads to obviously beta cell destruction and pretty significant hyperglycemia and type 1 diabetes. We were particularly interested in this model because the investigators who created it, Oldstone and von Herath, had studied a number of different interventions using this model and had shown that not only do LCMV infected mice have these very strong responses to type 1 interferons when you look at their gene expression signatures in their islets, but you could also prevent disease by blocking interferon alpha in this particular model. So these are results, blood glucose results if you used an antibody against interferon alpha, and these are blood glucose results in the model if you used an antibody against the IFNAR receptor. And either intervention was able to prevent diabetes in this particular model, which made us feel with some confidence that it would be a particularly good model to test our TYK2 inhibitor. So how we treated these mice is to administer the TYK2 inhibitor 2 days before the viral injection with LCMV, and then we performed a number of different immune profiling assays looking at blood, spleen, the pancreatic lymph nodes, and then we have also focused on some pancreas-specific analyses, including looking at gene expression patterns in the pancreas. And so what we found in our hands is that this is a really good model of type 1 diabetes and hyperglycemia, in that when we give the LCMV, we see a rapid progression to hyperglycemia within about 14 days. And when we administered the drug, the TYK2 inhibitor, about 90% of the treated mice remained diabetes-free. And so this is just a survival curve here for diabetes, showing that when we treat with the inhibitor, we have a really marked response in preventing hyperglycemia. And then these are just the blood glucose results on the right. Now, we don't have time to go through all the mechanistic analyses, so I just wanted to pull out a couple of the results from our flow cytometry analysis, looking at the blood, the spleen, and the pancreatic lymph node, to just really kind of highlight two major points. The first is that very early in this model, and I think this agrees with the signatures that were seen in the study by Oldstone's group that I highlighted, is that very early in the treatment, we see that there's modulation of innate immune signatures. So we see some changes in the macrophages and the NK cell populations in the mice that were treated with the inhibitor. And then at later time points, we start to see some modulation of adaptive immune signatures. And one in particular that we've been very interested in is that we see an increase in CD8 positive T cells that are highly expressing this molecule PD-1, which has been linked with T cell exhaustion. So this makes us think that there may be some T cell exhaustion that we're observing with this particular treatment. We also see some increase in PD-1 expressing T regulatory cells as well. And then finally, when we look at the level of the pancreas, we see that we are modulating gene expression signatures that we know are downstream of that interferon alpha receptor. We can see reduction in CXCL10, some reduction in STAT1 when we look at the pancreas of the treated mice with RNA fish. And then finally, we wanted to test this in a second model of type 1 diabetes. So we used the very traditional NOD model. This is a spontaneous model where female mice develop diabetes with time. So in our colony, we see about 80% of the mice develop diabetes within 30 weeks of age. So in this particular model, we treated with the inhibitor starting at 6 weeks of age and continued treatment through 12 weeks of age. And then we observed the mice for their incidence of diabetes. We chose this time point, let me go back, because many other groups have shown that this is a period where you start to see immune cell infiltration into the islets, but then you also see evidence of ER stress in the beta cell as well at these very early time points. And when we treat the NOD mice, we saw a similar response as observed with the RIP LCMV model, that we could effectively prevent diabetes in this mouse model. So in red, you see the TYK2 inhibitor treated mice, and in gray, the mice that received vehicle. And then finally, when we look at the immune cell infiltration into the islets, we saw that there is less immune cell infiltration in the NOD mice that were treated with the TYK2 inhibitor. So just to conclude, I think there are multiple lines of evidence that really implicate this important role for type 1 interference signaling in type 1 diabetes pathogenesis. And sort of focusing on the beta cell, we know that this pathway has important effects in the immune cell, but really there's been a lot of foundational work showing effects in the beta cell, linking this pathway with ER stress, MHC class 1 upregulation, and chemokine production. If you block interferon alpha or the receptor, or you treat with a JAK inhibitor, that has efficacy in preclinical models of type 1 diabetes. And then we've shown some data that suggests that if you block TYK2, that you might also be able to modulate hyperglycemia. We see these very early innate immune changes, followed by later adaptive immune changes, and then we're seeing some direct effects in the beta cell as well. Now, there are lots of questions. The most important is obviously translating findings from preclinical models to humans. Many interventions have been successful in the NOD mouse. Only a small minority have been able to be translated. But I think another important question is to still consider whether we are directly impacting beta cell immunogenicity. What's the optimal timing of an intervention that might target this pathway, and how do we combine it with other traditional immunomodulatory drugs? And then a whole other host of questions about how do we identify these high-risk individuals. And there's a number of efforts that are ongoing in Europe, and some of those are starting in the US to do general population screening so that we can identify those at risk who should be targeted for disease modification. And with that, I just wanted to acknowledge the partners in this particular program, including the team at the Indiana Biosciences Research Institute led by Decio, and then the people in my lab. And I would just highlight the efforts of Farouk Syed, who did his undergraduate training in Chennai, who's really led the project from our point of view. So with that, I will stop, and I thank you for your attention. I'd be happy to take any questions if there are time.
Thank you so much, Dr. Evans Molina, for the wonderful talk. So we do have some questions. Let me start with my own. Okay. So you talked about a bet on teplizumab. So we know that it's delaying the onset of type 1 diabetes mellitus. But what happens to the future course of a patient who receives teplizumab? What happens to the honeymoon phase? Is it curtailed or prolonged or remains unaltered? Any idea about that?
That's a great question, and we don't know that in particular because we're still studying those individuals. And we have a protocol in our TrialNet network where we ask people to enroll in a long-term follow-up study. So we're trying to answer those particular questions. They don't seem to have a difference in when they develop type 1 diabetes. They look very similar to anybody else who develops type 1 diabetes at that time of disease onset. But we don't know if they may have a prolonged honeymoon, for example. But we're very interested in answering those questions.
Right. So another interesting point I noted from one of the slides is that those who had a GAT positivity but negative for other autoimmune antibodies had a better response to teplizumab. So does it prompt us to select patients based on the antibody profile for the teplizumab use, or it doesn't make a big difference?
I think that's a great question. Really, one of probably the most important kinds of questions that we're trying to answer in type 1 diabetes clinical trials right now. This idea of particular endotypes who might be most responsive to a different drug. So, at first, I would say I think the study was a very small study. So we're making a lot of assumptions if we start to say, there's a particular population that's going to benefit, like those who are DR4 positive or DR3 positive, et cetera. But I think that this is really important because one of the things that has delayed our progress in the field is the marked heterogeneity that we see in clinical trial responses. So if we can start to understand these different endotypes that we should target with a particular agent, I think that will advance our efforts in this area. But I will say, I believe we're probably many, many years away from understanding those things. There has been some really interesting work in, GAD immunotherapy has had somewhat disappointing results, but people have gone back into those studies and looked at particular HLA subtypes and have found that the particular HLA subtypes respond better to GAD immunotherapies. So I think that there's a lot of work to be done in this area, and I hope that we'll get to a point where we can link an endotype with a particular drug therapy. We're just not quite there yet.
Thank you. So the other important thing is, in fact, like I'm very excited that you're coming with TYK2 inhibitor, especially baricitinib. Being in India, problem for us is that like, even though the teplizumab is approved in US now, so but its availability in India would be greatly delayed. But if at all, if baricitinib works, though we already have the molecule in India, probably definitely we can go ahead with its utility even for type 1 diabetes. But in the current situation where we are actually having questions about whether this drug works or not in India is actually a BCG vaccine. So I have two questions for you here. So does BCG vaccine really help for type 1 diabetic patients? Second thing is, the strain what we have in India is slightly different from what they typically used in the studies for BCG vaccine. So whether this difference in the strain makes any difference in the efficacy for type 1 diabetes?
So those are great questions. So I think there's been some intriguing data about BCG vaccine and whether there might be a preservation of C-peptide. I think that the studies that have been published have largely been very small and probably underpowered to be able to answer that question specifically. I don't know the particulars of the subtype of the BCG vaccine, so I'd have to do a little reading and get back to you on that. I think that we still need a lot of studies to really understand if BCG might have an effect to preserve C-peptide.
Thank you so much. Arvind sir, any questions from audience?
I have no questions. Dr. Prasanna Kumar, you have any questions?
Thank you, Dr. Carmela Evans, for an excellent talk. We have been seeing last 4 decades immunotherapy from cyclosporine to TYK2 inhibitors. And now the question is, in the natural history of type 1, what is the predictability? Whether you have 1 antibody, 2 antibody, 3 antibody. There have been many studies from German diet baby studies and other things. Where is the window of opportunity where we can interfere? Look at the normal islet cells. Then you have got an immune mechanism. Then you have insulitis. Then you have a stage where it's a point of no return. Whether you deal at the stage of macrophages, whether your NY killer cells, or now CD8 apoptosis. So you are now looking at CD8 apoptosis. Is it too late or too little? You see, we should go backwards for it. Even taking TYK2 inhibitors compared to placebo, what did your data show? Only 50% were offensive. That means any immunotherapy will never achieve 100%, because we have seen this, whether it is infertility, FSH vaccine, and antibodies against this, to get an antibody, whatever stage, whether it causes an apoptosis, anything, the immunosuppression, any of these mechanisms will never be 100%. Just like a safety of a vaccine against COVID or whatever it is, 80, 90, 70%. So this one is, okay, it is fine, you have excellent drugs, but whether in a patient, whether I should do 5 antibodies and 3 are present, they are going to respond. Tomorrow you may have a precision medicine and say, okay, you have got an immunosuppression, where it works, wait. It's still a hit and run trial where it's something like a trial and error method where we don't have that sort of precision medicine like what we have genetic analysis of MOD. And people have been doing it for the last 4 decades. It's not true. We have looked at various stages of this type 1 diabetes immunomodulators. Unfortunately, nothing has come 40 years. It works in some, doesn't work. I have my own skepticism that an immunomodulation very early, what stage of it, where you can prevent, do we have a salvageable beta cells, or it's a point of no return. So this is what I feel, though from mouse to human being, there's a huge stage. 30 years back, we used to see patients with ketosis. Today, I hardly see 2% with ketosis. We had a meeting last week, not only India, 8 countries across the world, starting from Cameroon or Kenya to Indonesia, they said, we are seeing less of the type 1 diabetics present with ketosis. Maybe we are recognizing early. And even after 20 years, studies have shown highly sensitive C-peptide, there is still a reservoir C-peptide even after 3 decades of type 1 diabetes. What are those patients where it is slowly progressive type 1, very fast progressive one? I'm not talking of malignant one. So what is your take on the predictability, intervention, ultimately drug being useful?
So you sort of summed up the field beautifully and all the challenges. So I completely agree with you. We've been at this for quite some time. I think one of the most important things that we did is recognize that it was very hard to modulate the course of the disease at stage 3. one of the sort of things that we're very much stuck in right now is that it's so hard to identify these autoantibody positive people in stage 2 and even to some extent stage 1 and enroll a trial that we're still testing any new therapy in stage 3. That's probably not the right approach, because if we don't see efficacy, we tend to discard that class of drugs. And then we don't really know if that might have worked in earlier disease stages. I would like to think that we'll get better at screening, but that's a very expensive and a very challenging thing, is to screen people for autoantibodies. Do we screen every year? Do we screen all children, et cetera, et cetera? So I think that's really challenging. You know, we in the field are very excited about teplizumab being potentially approved, but you know, you still have to go back. It's going to be a very difficult drug to give. It's a 14-day infusion in potentially very small children. So it's not going to be very completely easy to administer that drug either. So I think that where we are in our thinking is that we've probably been a little timid in type 1 diabetes in combination approaches. We could likely take a lot of lessons from our colleagues in oncology and rheumatology to understand how we combine therapies. And in particular, I'd like to think that we could find something that would be good for the beta cell in addition to modulating the immune system. And then I think really trying to identify this window of opportunity where people are most primed to respond is very important. That's challenging though, because even if we have a metabolic definition for that, we have to perform metabolic tests to identify those people in that particular stage of disease. So there are a number of challenges. And then I think the other point that you're alluding to is that the challenges of chronic immunosuppression balanced against, we are seeing less complications of DKA, et cetera. We have great insulins, technology, et cetera. Where does that balance meet of putting someone at risk with immunotherapy, but then also knowing that we have good treatments for type 1 diabetes? I might go back to Dr. Buse's lecture, which highlighted the challenges still of having type 1 diabetes, even with the most advanced technology and the most resources. It's still very challenging to have this disease. So I like to think that we'll be able to find that sweet spot and modulate the disease course.
Thank you. Thank you so very much for being there. I know it's early in the day for all of you in the United States, and thank you so very much for being there for us. My personal thanks from all of us at Bangalore and the Cure Trust and Icon Hospital. Vijay Sarthi, I think we can move on with the next lecture. I'd like you to introduce the next speaker, please.
Yes, sir. The speaker for the next session is Dr. Maureen Gannon. She is a Bachelor of Science in Biology and Master of Science in Eye Biology and Doctorate in Cell Biology and Anatomy. Dr. Gannon is currently the Professor in Department of Medicine, and she's also the Associate Dean of Faculty Development at Vanderbilt University Medical Center. Dr. Gannon has secondary appointments in the Departments of Molecular Physiology and Biophysics and Cell and Developmental Biology. Her laboratory focuses on the regulation of pancreatic beta cell mass and during development and postnatally in response to physiological and pathological stimuli. Her research has been funded by JDRF, NIH, ADA, as well as VA. So she's going to discuss on the role of prostaglandin E2 receptor and the enhancing the beta cell mass, as also the cardiac cells. Over to you, Dr. Gannon.
Thank you. Actually, it looks like I can't share my screen.
When you come down, you will see, if you just move the mouse, you can see the share screen, green.
Yeah, I clicked on that, but it's telling me there's some security or privacy thing that I can't share. Gosh.
Can you try once more? Is it possible to try? May I request?
I'm so sorry. Yeah, it says I have to open my system preferences. I'm not really sure.
May I request the IT team to help out? Dr.
Yes,
Gannon?
that would be great.
You had to allow open the system preferences, and you have to allow the system recording.
Okay. I'm not really sure how to do that. Maybe I could email you the presentation and you could show it. Can I do that?
Ravi,
Yes, we can. Yes,
we can do that. Yes.
Okay, I'm so sorry. We guess we should have tested this beforehand, but
Ravi, Ravi, can you please share the email?
so I'm going to try and email you the presentation. Hopefully you'll get it.
Yeah, Dr. Gannon has the email ID of Mr. Ravi, so I think she should be able to do it.
Yes. Okay, I just sent it.
I know the ID. Can you just look at the email ID to which you have sent, Dr. Monik?
Sure. So I sent it to the one that was in the chat.
Yes, yes. So let me check it out.
Okay. My apologies. I don't know.
No, absolutely no problem. I think it's absolutely fine.
I just got a new computer from Vanderbilt and it's got all this like extra security stuff on it. So it says it went through.
Ravi, just tell us if you have received the email.
Yes, sir, received. I'm just opening.
You're opening the email. Okay, so there we go now.
Great. I am so sorry. So while we're waiting for that to open, I just want to thank Dr. Aravind and Dr. Kulkarni for inviting me, and for all of the ADORE symposium team for giving me the opportunity to meet with you all today. And also thank Dr. Sarathi for the kind introduction. Yay.
Yes, finally we are on.
Okay, great. So can you go to the next slide? Thank you. So I'm coming to you today from Nashville, Tennessee. So this is our beautiful skyline. So I thought I would just show you what Nashville looks like in case you've never been. And if you go to the next slide, please. So I've circled the state of Tennessee, which is where Nashville is located. And so you can see that based on the darker colors here, that the incidence of obesity in the part of the United States where Tennessee and Nashville are located is some of the highest in the country. And if you go to the next slide, please. That, unsurprisingly, correlates with very high incidences of diabetes in the United States. So the same regions that are where we see prevalent obesity, we also have high incidence of diabetes. And then if you go to the next slide, go to the next slide, please. Thanks. This is also correlates with high incidence of heart disease. So this is not really surprising. You know, cardiovascular disease is one of the most common complications of diabetes. And so today what I'm going to talk to you about is the potential for some drug targets that can potentially benefit both diabetes and its major complication, heart disease. So if you go to the next slide, please. So prostaglandin E2 is a lipid signaling molecule that's derived from the membrane lipid arachidonic acid. And so you can see in this diagram the pathway for metabolism of arachidonic acid by cyclooxygenases or COX enzymes that leads to the production of multiple different prostaglandins, including prostaglandin E2, which if you click again, I think I have a little red box that comes, there we go. So prostaglandin E2 is elevated in the setting of obesity. So it's known that there's chronic inflammation in obesity, and it's also highly elevated in both humans and mouse models of type 2 diabetes. So if you go to the next slide, please. There are 4 receptors for prostaglandin E2. They're all G protein coupled receptors. Today, I'm going to talk to you about 2 of those receptors, EP3 and EP4. And those are the main receptors that are expressed in the pancreatic beta cell. And what's really interesting about these 2 receptors is that they bind prostaglandin E2 ligand with equal affinity. So prostaglandin E2 doesn't have a higher affinity for one or the other. So it's really the outcome of that signaling pathway is really going to depend on which of these 2 receptors is there in more abundance, not really the ligand. So we know that from many different biochemical studies that the EP3 receptor is coupled to GI, so inhibitory G proteins, and this is going to inhibit adenyl cyclase activity and decrease cyclic AMP production. Whereas the EP4 receptor is coupled to activating G proteins or G alpha S, and this is going to lead to increased adenyl cyclase activity and increased cyclic AMP production. So these 2 receptors oppose each other when they're expressed in the same cell type. So again, the activity of the PGE2 ligand is going to depend on which receptor is there in more abundance. So while we think of chronic inflammation as a problem and something that we want to inhibit and avoid in the setting of obesity and type 2 diabetes, the ligand in and of itself is not really the issue. It's which receptor is it going to interact with. And so if you click advance to the next, please. So what we know from several different groups who have looked at the expression and the function of EP3 in the islet and in the beta cell is that expression of the EP3 receptor, so this inhibitory receptor, is increased in islets in both humans and mouse models of type 2 diabetes. We also know from our group and others that expression of EP3 increases in islets with age, and the incidence of type 2 diabetes, as you all know, increases with age. Michelle Kimple's group at the University of Wisconsin has shown that if you knock out a GI protein that is known to couple to EP3, you actually get increased beta cell proliferation and increased functional beta cell mass. So again, EP3 would have an inhibitory tone on beta cell function, beta cell proliferation, and would potentially lead to increased susceptibility to type 2 diabetes. Now, if you advance to the next slide, we'll talk a little bit about EP4. Advance one more. Thank you. So it hasn't really been studied in terms of knocking out EP4, or there's been some studies looking at knockout of the G alpha S's that can couple with EP4, and that's been shown to be deleterious. There have been some whole animal studies showing that EP4 agonists can improve overall survival in the streptozotocin mouse model, which mimics type 1 diabetes. The mechanism of that was not elucidated. There's also been some systemic treatment with EP4 agonists in the type 2 diabetes mouse model, the DB-DB mouse. And again, that improved glucose homeostasis, but the mechanism for that was not elucidated. So overall, we can conclude from all of these studies that EP3 activation by prostaglandin E2 would have negative effects on beta cell mass and function, whereas PGE2 interaction with the EP4 receptor would have beneficial effects. Can you go to the next slide, please? Thank you. So my group a few years ago published some studies that we did with isolated human islets from cadaver donors, where we treated these islets ex vivo with either an antagonist of the EP3 receptor called DG041, and you can see in the upper left-hand corner what the nomenclature is for these different chemicals that we're using. So we treated them with either an EP3 antagonist or an EP4 agonist, which is that K compound. And what we wanted to know was whether this would, how this would affect beta cell proliferation. And so what you can see is if you look on the DGO41 treated islets, you can see that there's an increase in beta cell proliferation when we inhibit or block the activity of EP3. When we treated with the K compound alone, we didn't really see any significant effect on beta cell proliferation in these human islets. But when we combine treatment with inhibiting EP3 and activating EP4, you can see that there was an additive effect and that we saw a further enhancement in beta cell proliferation in these human islets over EP3 antagonism alone. Can you go to the next slide, please? Importantly, oh, I'm sorry, can you just go back? Thanks. I want to make this point. I think it's really important. We evaluated the effects of either of these compounds alone or in combination on alpha cell proliferation. And in no circumstance did we ever see any change in alpha cell proliferation. So treatment of whole islets with these compounds had a beta cell specific effect, even though the receptors are also expressed in the alpha cell. And that's really different from a lot of other stimuli that have been shown to promote human beta cell proliferation. Most of them also have effects on alpha cell proliferation, and we do not see that with these compounds. And so I think that's really important. Can you go to the next slide, please? Thanks. So we also looked at effects on beta cell survival. And so again, these are isolated human islets from cadaver donors treated ex vivo with either agonists or antagonists of EP3 and EP4. And on the left-hand side, you can see the little schematic that shows you what the compounds' names are and whether they activate or inhibit the two receptors. And so what we did in this case was to either have islets that were not treated with cytokine, and that's on the left-hand side of the graph, or we had islets that were cultured in the presence of cytokines with none of the compounds, and that's the vehicle under the cytokine treated row. And you can see that there's an increase in beta cell death when we treat with cytokines. When we treat with sulprostone, which is an EP3 receptor agonist, that actually exacerbated the effect of the cytokines. We saw increased beta cell death. When we treat with DGO41, which is our EP3 antagonist, you can see that it decreased beta cell death or enhanced beta cell survival. Likewise, when we treat with the EP4 agonist, the K compound, that also promoted beta cell survival. And when we treat with the EP4 antagonist, it had no effect. So what we found is that EP3 inhibition or EP4 activation enhances beta cell survival and protects against cytokine-mediated beta cell death. So you can go to the next slide, please. So more recently, we've started to look and see how these compounds might affect the progression to diabetes using in vivo mouse models. And so what I'm going to show you today is some data that was very recently published by our group using the DB-DB mouse model of type 2 diabetes. And so what we did was to inject daily with the EP3 antagonist for a period of 2 weeks. And we started either at 4 weeks of age or at 6 weeks of age. And this is still a window in the DB-DB mouse where they're not really overtly hyperglycemic. And there's still some attempts at beta cell compensation, which ultimately fails in this mouse model. But we were trying to see if we could extend the period of beta cell compensation and prevent the onset of type 2 diabetes. So if you go to the next slide, please. So what you're looking at here on the left-hand side are sections from either the control animals, which are the DB heterozygotes on the top, or DB-DB mouse on the bottom, that were treated either with vehicle on the left or the EP3 antagonist DGO41 on the right. And if you look at the quantification in panel B on the right-hand side of the slide, you can see that when we treat from 4 to 6 weeks of age, there's a trend toward an increase in beta cell mass in the DB-DB animals, but it wasn't significant. But when we treated from 6 to 8 weeks, you can see that there was a significant improvement in beta cell mass when we inhibit EP3 activity. If you go to the next slide. This is most likely due to an increase in beta cell proliferation, which you can see with the 4 to 6 week old animals. We have a nice significant increase in beta cell proliferation. We looked at beta cell death using tunnel and we didn't see any effect. So we don't think that it's working through inhibiting beta cell apoptosis, but most likely through enhancing beta cell proliferation. If you go to the next slide, please. We also did some gene expression analyses. And so first we compared whole islet gene expression using RNA-seq from the DB heterozygous controls with the DB-DB animals. And what we saw is that there was an increase in the DB-DB islets or an upregulation of genes that are associated with beta cell immaturity, such so-called disallowed genes. And this includes lactate dehydrogenase, MAFB, and OC1. We also saw in the DB-DB animals an increase in expression of the gene PTGER3, which is the gene name for the EP3 receptor. So that goes along with what has been shown in humans, that there's an increase in EP3 in the setting of type 2 diabetes. We also saw downregulation of beta cell identity genes, which are listed there. I won't go through all of those, and that's not too surprising in this model. And this was early in the disease stage. This was at 8 weeks of age before really overt hyperglycemia. So you go to the next slide, please. So what we wanted to know then was, did treatment with DG041, the EP3 antagonist, reverse any of these gene expression changes that we see in DB-DB islets compared to non-diabetic control animals? And one of the things that we found was that the GLP-1 receptor was dramatically decreased in DB-DB islets compared with controls. And so you can see this in the second lane from going from left to right. In red is the GLP-1 receptor protein expression. And you can see in DB-DB animals, whether they're treated with vehicle or the EP3 antagonist, there's the same level of GLP-1 receptor. And in the DB-DB mice, you can see there's a dramatic reduction in GLP-1 receptor protein and insulin in green. You can see the insulin is practically gone and undetectable. But in the last row on the bottom, you can see when we treat with the EP3 antagonist, we have a beautiful recovery of insulin expression, and we have some recovery of the GLP-1 receptor as well. If you go to the next slide. We also noticed in our RNA-seq analysis that expression of the transcription factor NRF2 was enhanced when we treated with the EP3 antagonist. And NRF2 is a master regulator of antioxidant genes and has been shown to be really important for beta cell proliferation by Don Scott's group at Mount Sinai in New York. And so he helped us look at protein expression of NRF2. And what you can see is, again, you can see that beautiful rescue of insulin here in the middle row, in the middle column, in gray, but you can also see in red is the NRF2, and we see both in the DB heterozygotes and in the DB-DB animals that when we treat with the EP3 antagonist, we have a dramatic increase of NRF2 in the nuclei of the beta cells, and that's quantified for you on the right-hand side of the slide. So inhibition of EP3 enhances expression of this NRF2 antioxidant pathway. So if you go to the next slide. We also looked at a marker of oxidative stress, 8-hydroxy-DG, and you can see similarly to what we saw with the NRF2, we see a decrease when we treat with DG041 in both the DB heterozygous animals and the DB-DB animals, suggesting that this increase in NRF2 is actually relieving oxidative stress in the beta cells. So you go to the next slide. So now I'm going to move to some of our more recent studies where we've been starting to look and see whether or not inhibition of EP3 or activation of EP4 can have beneficial effects in the heart. And so, as I mentioned at the beginning, cardiovascular disease and heart failure are two major complications of individuals who have type 2 diabetes. And there's been some publications showing that EP3 has negative effects on cardiac function, and EP4 has beneficial effects. So if you could advance to the next, just click one more. Okay, so there's evidence in vivo and in vitro studies that PGE2 can work through EP3 to reduce contractility of cardiomyocytes. Then if you click again, from transgenic mouse studies, if we move one more, please. Thanks. Overexpression of EP4 in vivo in a mouse model, specifically in cardiomyocytes, improves cardiac function in a mouse model of myocardial infarction. So again, just like in the beta cell, EP3 and EP4 seem to play opposing roles in the heart. And so inhibiting PGE2 production by using NSAIDs, for example, that blocks COX activity and would block PGE2 production, would have effects both on the EP3 and the EP4 pathway, because you're getting rid of the ligand. So you would lose the beneficial effects of PGE2 and as well as the negative effects. And so what we think is that maybe targeting the receptors individually rather than the ligand would be a more beneficial approach. So if you could go to the next slide, please. We've been doing some things with DB/DB mice in vivo, and we've been treating systemically with the EP3 inhibitor, the DG041, to see whether or not that can also improve cardiac function, as it also improved, beta cell proliferation and mass. And so if you look in panel A, you can see that the DB/DB animals have reduced heart rate, and that compared to the DB heterozygotes on the left. Treatment with DG041 had no effect on heart rate, but it did improve parameters such as cardiac output and volume and stroke volume. And so you can see that there were significant or almost significant effects of inhibiting EP3 in the DB/DB animals specifically, and really no effect in the heterozygous controls. If you go to the next slide. We've been trying to figure out the mechanism of action of how EP3 inhibition or EP4 activation could enhance cardiac function. And so we've been doing some things with isolated cardiomyocytes from mice ex vivo and treating them either in culture conditions of normal glucose or high glucose, and treating them with vehicle or the EP3 inhibitor, which is shown on the left, or the EP4 activator, which is shown on the right. And you can see that if we look at peak amplitude, so calcium peak amplitude, which is going to influence contractility. And if we look at fractional shortening, which is also another measure of contraction strength, you can see that both under normal glucose and high glucose culture conditions, treatment with either the EP3 antagonist or the EP4 agonist enhances cardiomyocyte function in culture. So if you go to the next slide. More recently, we've been trying to see how this could potentially correlate with human phenotypes. And so we've been working with Dr. Quinn Wells at Vanderbilt, who has works with a team that developed this tool called PredictScan. And what we're using here is whole genome sequencing results from approximately 25,000 patients at Vanderbilt University Medical Center, de-identified patient data. We have this blood bank database where they've done whole genome sequencing on, as I said, about 25,000 individuals. And we can correlate gene expression data or predicted gene expression data with phenotypes in the electronic health record. And so what we found is that expression of the EP3 receptor, which is that PTGER3 on the top row, is correlated with type 1 diabetes and chronic kidney disease, and it's correlated with negative outcomes. Whereas expression of EP4, the PTGER4 gene, is actually shown to be cardioprotective in this cohort. And so we're really excited about being able to translate these findings in our mouse models potentially in the human population. So if you go to the next slide, please. So I'm just going to summarize and leave you with this cartoon about how we're thinking about things. Again, we think both in the beta cell and in cardiomyocytes, EP3 and EP4 play opposing roles on activity of adenyl cyclase, and this is influencing downstream cell function, including proliferation. And we know that with age, EP3 expression increases. And so the presence of the PGE2 ligand is going to preferentially work through that negative pathway. So if we could block that, or if we could enhance activity of EP4, we could reverse those negative effects. We know from some proteomic analysis in the lab that the EP3 inhibition is working through phospholipase C gamma, and the EP4 activation is working through PKA. And we now know some downstream target genes, including NRF2, that's involved in antioxidation and maybe beta cell protection and cardioprotection. And so we're really excited to move forward with this project and to get more detail into the mechanism of action of these different drugs, and also to figure out potentially drugs that are maybe more bioaccessible. So those are ongoing projects that we have in the lab. So I'd like to leave with the last slide and just thank all of the members of my lab. If you can go to the next slide, please. So I have listed here the current members of my lab, and here's a recent photo of my group, former members of the lab who really were instrumental in getting this project going, my funding, which I'm very grateful for, from the VA and from the NIDDK, our fantastic islet procurement and analysis core, and of course the donors and their families for the human islets. And I'd be happy to take any questions. Thank you so much, and thank you for running the slides. I appreciate it.
Thank you so much, Dr. Gannon. That was a wonderful lecture. In fact, let me just convey you the compliments given by Dr. Shekhar from Mysore. He has appreciated your phenomenal research and the singular focus where you're particularly working on prostaglandin E2 receptor.
Oh, great. Thank you.
Yeah. So the questions for you are the evidence is building that addressing the EP3 and EP4 are actually improving the beta cell mass. But is it just an increase in the mass, or it's a functional mass? So do we have any evidence to say it also increases the C-peptide levels in your mice and also the insulin levels? And if so, how much percentage the improvement is seen? And also the second question is that what is the durability of this improvement in the functional mass as well as the functional capacity to secrete insulin? Does it persist over long run?
Yeah, those are great questions. Those are things that we're looking into now. We only did a 2-week treatment. And with the 2-week treatment, we did not see any changes in glucose homeostasis. We did static incubations for insulin secretion. We didn't see any improvement in insulin secretion either. So what we're trying to do now is to do a longer treatment. So we're going to be using, because we were doing daily injections, so we're going to be moving to a pump system that can do a more chronic and longer term release of the compound. We're also working with our high throughput screening facility to come up with some more compounds that are more water soluble. So this compound can't be given orally. And so we would like to be able to put things in the drinking water so we could treat for longer and see if we could have a more beneficial effect. So I can't really tell you the longer term outcomes, but that's something that we're working on now with a new grant that we just got funded.
Right. Thank you. And there's another question from Dr. Shekhar. For example, someone who has a very minimal beta cell mass, right? For example, we tackle a patient or a mice which has almost lost its beta cell function, where the residual function is only around 10%. So does these drugs will still work? So even at that level, or we want any particular amount of residual beta cell mass for these drugs to work with?
Yeah, that's an interesting question. So we have plans. We just started recently some experiments in the NOD mouse that was mentioned by Dr. Evans Molina in her talk. So we're looking to see if we have lost some beta cell mass, can we reverse that? So those are ongoing studies. Right now, I can tell you that treatment with the EP3 antagonist reduces insulitis. So we have no evidence yet as for beta cell mass. We're doing those analyses, but by H&E, it does reduce the insulitis. So that's encouraging. We also plan on looking in the streptozotocin mouse model where we have a dramatic reduction in beta cell mass to see if it can reverse that. So those are ongoing studies, and I wish I could tell you right now, but hopefully it will work.
Thank you so much. So any other questions? Prasanna Kumar, sir?
Thank you, Dr. Gannon, for an excellent talk. And a lot of things that you said is new to us. My question is simple. PGE2 is distributed all over the body. It's not restricted to beta cell or heart. In fact, it is there in the kidney, it is there in the brain, and many of the tumors also they have. The question is, when we are trying to see that effect of this, that whether we are looking at the two things where it is a suppression of EP3 or a stimulation of EP4. What is the effect? Because I know that PGE2 is the one which is responsible for angiogenesis and also is a modulator in the inflammation process. And that's how it is going to improve, whether it is beta cell mass, where it suppresses the inflammation or increases the activity. So when you use these modulators, the PGE2 as such, and then try to inhibit the EP3 and stimulate EP4, what is the effect on the kidney? What happens to the brain? So we should also see a total effect, because even in the tumor genesis in the uterus also it is seen, where it is very important role. So looking at rather than one cell, when you see the human being in total, what are the effects? Maybe good, effect on the heart, as you showed, but what is the effect on the kidney and brain, other organs? What does it do generally in a patient, whether it's a mouse model or later on we go to human beings?
Mm-hmm. Yeah, fantastic question. I mean, when you're treating systemically, obviously looking at things in isolation is not okay. We really have to look at everything else. I completely agree. I can tell you that, so this particular compound that we're using, this EP3 antagonist, doesn't really seem to cross the blood-brain barrier. So we don't think there will be any effects on the brain. However, the EP3 knockout mice do have an overeating phenotype because of the loss of EP3 in the brain. So if one were to design a drug targeting EP3, you would want to make sure that it didn't cross the blood-brain barrier. It's really important. In terms of the kidney, it's been shown to have beneficial effects on the renin-angiotensin system and hypertension. So inhibiting EP3 is beneficial in that regard. There is one negative effect that we and others have noticed, and that's in the adipose tissue. So EP3 activity is required to retain fat in the adipose tissue. So what ends up happening is that some of the fat ends up going to the liver. And so there's an increase in liver steatosis. And so that is the only negative effect that we have observed so far, but obviously that could be a problem. We have a talk coming up soon about NAFLD. And so, I think that's something that we have to think about. But so to date, that's the only negative effect that we've seen.
Thank you.
Sure. Thank you for your question.
Thank you, Dr. Gannon. I think we have more short time by about 30 minutes, and we can take more questions later on. And now I request Dr. Sarthi to end this sessions, and I'll also request Dr. Wagesh to come on, because the US speakers are waiting in the wings and they all have other engagements. So I know Dr. Samuel Klein is already there and he's waiting to start his lecture. And Dr. Wagesh, well, you need no introduction from any one of us, but then you're the professor and the former head of Department of Endocrinology at St. John's Medical College Hospital in Bangalore. You have been a passionate researcher and a clinician yourself. And I would request you now to take over the stage and then introduce our next speaker, Dr. Samuel Klein.
Good evening. Thank you, Dr. Arvind, Dr. Prasanna Kumar, Dr. Krishna Sheshadri, and the team for giving me this opportunity to be a part of ADORE program. We are lined up with two important and interconnected talks. The first one being, everyone knows that obesity causes diabetes, but how it causes is a great question. To dwell on this, we have got Dr. Klein, MD. He is the William H. Danforth Professor of Medicine, Director of Center for Human Nutrition, Director of Center of Applied Research Sciences, Chief of Division of Geriatrics and Nutritional Sciences, and Director of Weight Management Program at Washington University of School of Medicine at St. Louis, Missouri. He has received numerous awards for his research in nutrition and obesity. Dr. Klein's research activities are focused on understanding the mechanism responsible for metabolic dysfunction associated with obesity, in particular NAFLD, and the therapeutic effect of weight loss on it. I think we have got a very interesting talk ahead. I request Dr. Klein to begin his lecture. Dr. Klein? Yeah, I think it's there.
Doctor, you have to unmute yourself.
Okay. Can you hear me okay?
There is some echo coming from your side.
Let me try. Let me see if this works.
Yes, that should work. Ravi, can you help out?
Is this any better?
No, I think there's a lot of echo there and we can hardly hear you. There's a jarring sound coming.
Doctor, can you check your mic settings? Microphone settings?
Let's see. You still hear the sound?
No, there's enough echo.
No, I think there's a very jarring noise which is coming from your end. It's not clear.
Okay.
Yeah,
now
let me.
Now it's
now
clear.
it's okay.
Now it's okay?
Yeah, it's okay.
Good. I did nothing. Perfect. Okay. That's the problem in St. Louis. A lot of electrical ions floating around here. But thank you very much for inviting me to participate, Dr. Vagish and the other organizers, in this really remarkable symposium you put together. I'm going to talk, as you mentioned, is to try to review why obesity might be responsible for causing type 2 diabetes. I know we're a little behind schedule, so we'll go through this in rapid fashion. And so, as we all know, as we gain weight, going from a lean person to obese person, cardiometabolic complications develop. And these are very serious, of course, because they lead to developing type 2 diabetes and heart disease and stroke. And so these include atherogenic dyslipidemia, which is an increase in triglyceride concentrations, a decrease in HDL cholesterol concentrations, and also in non-alcoholic fatty liver disease, which is an increase, triglycerides in the liver. But potentially most important is insulin resistance and beta cell dysfunction, which leads to type 2 diabetes. And this, of course, is a very important risk factor for heart disease and stroke. Now, we know most people who become obese from being lean develop these abnormalities. In India and South Asians, it's even worse because you don't have to become obese by the definition of Caucasian standards. If you simply become overweight, you will develop these complications. Now, the accelerated process of why people from South Asia and people from India are so prone to developing insulin resistance and beta cell dysfunction with a little bit of weight gain is not clear, but it seems to be similar to the mechanisms that might be responsible for these abnormalities in Caucasians, except they happen at an earlier increase in body weight gain. And so the data I'm going to review with you is really done mostly in Caucasians, not in South Asians, but probably the observations will apply to both populations. Now, if you look at people who are lean and obese and measure their insulin sensitivity by using the hyperinsulinemic euglycemic clamp procedure shown here, this is where you infuse insulin at a physiological dose, and then you infuse glucose to maintain euglycemia, normal blood glucose concentrations. So if you're very insulin sensitive, you require very high glucose infusion rate to maintain a normal blood sugar because glucose is being avidly taken up by muscle tissue. But if you're very insulin resistant, you require very little glucose infusion to maintain euglycemia, and you have insulin resistance as shown here at the lower part of this figure. And as you become heavier and heavier with increasing body mass index, there's this curvilinear negative relationship between body mass index and glucose infusion rate required to maintain euglycemia, or in other words, insulin sensitivity. And so people who are very obese are insulin resistant. People who are lean tend to be insulin sensitive. And within this obese group, there's a range, a heterogeneity, as you can see here, in insulin sensitivity, where some people who are obese are insulin sensitive and other people who are obese are insulin resistant. And then there's, of course, the people in between. So there's a huge scatter, a range of insulin sensitivity at any given body mass index value. Now, these two boxes here I put here because these are typical for people who are from India, from South Asians. And we had no South Asians in this study, so I have no diamonds here. But people in South Asia who are even normal weight, there are a subgroup who are insulin resistant, and then people who are overweight, a BMI from 25 to 30, are also insulin resistant. So this curve is shifted to the left if you have the genetic background of being Indian, of being South Asian. So what I'm going to review now, if we can understand the mechanisms that are responsible for why this group at the bottom are insulin resistant and how that differs from the group at the top who are insulin sensitive, we'll understand more about the pathogenesis and pathophysiology of why excess body fat causes metabolic dysfunction and type 2 diabetes. And so in all the studies I'm going to show you now, there are subjects that are similar to the ones that are listed here. And these are people who we define as being metabolically healthy lean, metabolically healthy obese, and metabolically unhealthy obese. And you can see the obese group are pretty well matched on body mass index and percent body fat. They're obviously larger than the people who are metabolically healthy lean. The people who are metabolic and healthy obese have a lot more liver fat content than those who are healthy obese and lean, and they're matched. Fasting blood glucose is higher in the unhealthy obese. 2-hour glucose tolerance test is also higher in the unhealthy obese. Fasting insulin is also higher. And if you look at the glucose disposal rate during insulin infusion, which is a measure, again, of insulin sensitivity, expresses micromoles of glucose per kilogram of fat-free mass per minute, you see that, as by design, the metabolic and healthy obese people are much more insulin resistant, very low glucose disposal rate compared to the healthy obese, compared to the lean. Now, it's important to know here that even though we try to match the healthy obese with the healthy lean people on all metabolic outcomes, it's very difficult to do that with respect to glucose disposal rate for whole body insulin sensitivity. And so even though this group is much more insulin sensitive than the unhealthy obese group, they are still insulin resistant compared to the healthy lean group as shown here. Now, if you look at rodent data, there's a dogma that's been developed as to why gaining body fat causes insulin resistance and why in some people it may not cause insulin resistance and metabolic dysfunction. And here's a figure from Phil Shear's review article years ago, where the hypothesis is, or the dogma is that if you gain body fat and body fat mass, you have an increased number of fat cells, an increased size in those fat cells. And if you're and with that becomes an increased capillarization of adipose tissue to provide oxygen and nutrients to adipose tissue. But if you're unable to expand your vasculature to increase delivery of oxygen to adipose tissue, this adipose tissue becomes hypoxic. And hypoxia stimulates HIF-1 alpha, and HIF-1 alpha causes a whole range of adverse metabolic events in adipose tissue, which lead to inflammation and fibrosis. And somehow this inflammation and fibrosis then causes systemic insulin resistance, which again is one of the important features of developing type 2 diabetes. Now, the mechanism by which this develops systemic insulin resistance is not quite so clear-cut, because you have to have a signal from adipose tissue being delivered to other organs. But the dogma here again is that it's adipokines and cytokines produced by adipose tissue go into the bloodstream, go to other organs, and cause those other organs to become insulin resistant. So this is the kind of the dogma that's been developed from animal models, that's been also applied to people, but it's not really been quite carefully evaluated in humans. And so we did a series of studies that I'm going to share with you right now to look at these different features to see if there's a difference in the metabolically healthy lean group, the metabolically healthy obese group, and the metabolically unhealthy obese group in various outcome measures that I'll show you in a few minutes. Now, these are groups that are very well characterized and separated distinctly. So this is not just, this is really groups that have been defined by rigorous assessments to put them in this category. So these are the extremes of unhealthy obese, the extremes of healthy obese, and also healthy lean people, but no one with type 2 diabetes. This is before anyone develops type 2 diabetes. And if you measure adipose tissue oxygenation by using a probe that measures interstitial, not intracellular oxygen tension, you see a progressive decline from healthy lean to obese to unhealthy obese, shown here. And this is associated with a progressive increase in HIF-1 alpha gene expression, consistent with the rodent hypothesis that there is a decrease in oxygen tension in adipose tissue that's associated with an increase in HIF-1 alpha. Now, again, we never measured intracellular, intradipocyte oxygen tension, which is really what you need to measure, which is not possible to do in either rodents or in humans. But this is supportive of this hypoxia kind of hypothesis. And if you measure adipose tissue oxygen tension in adipose tissue, you see that it correlates directly with insulin sensitivity. So the more oxygen you have, the greater is your insulin-stimulated glucose uptake, as shown here in the clamp procedure. The next thing that we look at is fibrosis and fibrogenesis. Now, we measured fibrosis by using a deuterated water technique where you ingest heavy water for several weeks and you measure the incorporation of deuterium in collagen in adipose tissue. And here it's a fractional synthetic rate of collagen 1 alpha 1 in adipose tissue. And you can see that there's a progressive increase in collagen synthesis going from lean to healthy obese to unhealthy obese, shown here. And if you look at gene expression of all the different collagens combined together, because there's about 20 or so different collagens in adipose tissue, you see, again, a progressive increase in gene expression of collagen in adipose tissue, going from lean to healthy obese to unhealthy obese, shown here as well. And if you do histological staining for collagen adipose tissue, you can see very clearly that the unhealthy obese have a more dense fibrous network of collagen around adipocytes than the lean subjects shown here. So here you can see the adipocytes are larger. There's a thick collagen architecture around it, which is very different than what you see in the lean group. And in fact, if you look at the relationship between the composite collagen gene expression adipose tissue, shown here in the upper right, in relationship to glucose disposal rate during the clamp procedure, which is a measure of insulin sensitivity, you see this negative inverse relationship. The more collagen gene expression adipose tissue, the worse is your insulin sensitivity. So without question, increased collagen, increased fibrogenesis in adipose tissue is associated, doesn't mean it's causal, but is associated with insulin resistance in people. The other important feature are really the inflammatory aspects of adipose tissue. And then there's two components of inflammation in adipose tissue. One are the immune cells themselves, primarily macrophages, because they're the most abundant cell in adipose tissue. In fact, they're much more abundant than adipocytes. There's 4 times as many macrophages than are adipocytes, per gram of adipose tissue in people who are obese. But these are the most predominant immune cells in adipose tissue. And also the gene expression of pro-inflammatory proteins, of pro-inflammatory cytokines and proteins, which I'll show you next. Now, if you take these distinct groups of subjects and measure their M1-like, which are the more aggressive pro-inflammatory macrophages, and measure their M2-like, which is the more anti-inflammatory macrophage in adipose tissue, you see again this progressive trend as you go from healthy lean to unhealthy obese, a progressive increase in the bad macrophages and a progressive decrease in the good macrophages. But even though these are statistically significant differences, where the metabolic and healthy obese group have more macrophages than the healthy obese and the lean group, there's considerable overlap. These are the individual subject values shown here. There's considerable overlap between a healthy obese, unhealthy obese, and even the lean and the obese subjects here. So we see statistically significant averages between the groups with considerable overlap between groups. If the same observation is seen when you look at the gene expression of markers of inflammation. I won't go through really all of these, but SERPINE1 may be the most important because that encodes for PI1 that I'm going to show you in a minute. And PI1 is a protein that's been associated with, that's involved in coagulation. So associated with heart disease, presumably because of its coagulation properties. But now it's being appreciated as actually very much involved with metabolic function and metabolic health as well. And you can see here, PI1 gene expression is the most predominant difference between healthy lean, healthy obese, and unhealthy obese, shown here, gene expression. Here are the other various cytokines and also markers of macrophages shown here, where you can see this progressive sort of increase, but it's not very impressive. There's a lot of overlap between TNF alpha. You can see here between CCL5, CCL2, between the groups. So even though you see this general trend of progressively increasing inflammatory markers, you see overlap between these groups that are more insulin resistant and metabolically dysfunctional obese versus the healthy obese shown here. But both obese groups seem to be consistently increased from the metabolically healthy lean group shown here. And so now the question is, does this increase in inflammation and immune cells in adipose tissue lead to an increase in pro-inflammatory proteins in the bloodstream that can then go to other organs and cause insulin resistance. And this has really been something that has not been very well defined in people. It's been shown in rodents, but not very well shown in humans, even though it's been accepted that these inflammatory proteins in the circulation are causing insulin resistance that come from adipose tissue. So here we take these groups, the lean group in dark blue, the healthy obese in green, and the unhealthy obese in orange. And we measured plasma cytokines all day long, every hour for 24 hours, except we gave them a little break in the middle of the night, so we shouldn't disturb them to let them sleep. And what's remarkable is that for all of these cytokines, they pretty much stay constant all day long. Despite eating 3 meals a day in our clinical research unit, they really stay pretty constant, except for pi1. There's a known diurnal variation in pi1, as you can see here, high in the morning, lower during the day, and then high again at night in pi1. The other thing you notice that pi1 concentration is much higher, 100,000 picograms per ml, than the concentration of all these other cytokines as shown here. What's also interesting, despite having these very low concentrations in all of these cytokines, and probably lower than the ability to cause physiological effects in vivo, because these are below the levels shown to cause physiological effects in vivo in cell culture systems, not only are these concentrations very low, some of them here 0.4 picograms per ml, 2 to 4 picograms ml, but we see an inconsistent pattern. People who are unhealthy obese and may have no differences in their cytokine concentrations than the healthy obese group, for example, shown here in IL-6, but higher than the lean people shown here. Here, the unhealthy obese have a lower IL-1 beta concentration than the healthy obese and lean people shown here. Here again, the unhealthy obese are in between the healthy obese and the lean subject shown here, et cetera, et cetera. So we see no difference, really, no pattern of differences between the groups, and also very low concentrations, except for pi1. This is remarkably different. pi1 is markedly elevated in the people who have unhealthy obesity, and much higher than the healthy obese group, which is about the same as the metabolically healthy lean group shown here. And so we looked at the relationship between 24-hour plasma pi1 concentrations, area under the curve. This is the composition of the pi1 exposure to organs in the body over 24 hours in relationship to insulin sensitivity measured as glucose rate of disappearance divided by insulin concentration during the hyperinsulinic euglycemic clamp procedure. And you see here this very nice curvilinear relationship where people with high pi1 concentrations, which are the metabolically unhealthy group in orange, have much worse insulin sensitivity than the lean group who have very low pi1 concentrations, and in between are the metabolically healthy obese group. So this now shows a very close correlation between pi1 and insulin resistance. Doesn't tell you cause and effect, but really is suggested that pi1 may be involved in the pathogenesis of insulin resistance when you gain weight in people who are lean and then become obese. And then if you look at the 24-hour concentrations of the important substrates, glucose and fatty acids and insulin, in the metabolic and healthy and metabolically healthy obese group shown here, unhealthy in dark blue, healthy in light blue, over 24 hours. The pink bars are meals given during the day while they're in the clinical research unit. You see that all day long, people who are metabolic and healthy obese have much higher glucose concentrations and much higher insulin concentrations than the healthy obese group. Now, these are not people with diabetes. These are people who have pre-diabetes compared to people who are healthy obese people. But there's very little difference in free fatty acids. These are very similar in the two groups, a little bit higher in the unhealthy obese group than the healthy obese group, which again contradicts the dogma that fatty acids are an important mechanism for generating insulin resistance in people who are obese. Now, these are not diabetic patients where the fatty acids are higher. These are people who are unhealthy obese. And the reason for this is that when you eat a meal and you increase your insulin concentrations, as shown here all day long, you suppress lipolysis and fatty acid concentrations with these high levels of insulin that are circulating in blood. And so this does not support the dogma that plasma fatty acids are an important mechanism for causing systemic insulin resistance in people who are obese, who don't have diabetes. This might be different for visceral fat. And this is a study done by Michael Jensen's group that we simply summarized in this figure shown here, where he actually measured the contributions of fatty acid from the portal circulation coming from visceral fat and the contributions coming from systemic fat, upper body and lower body fat, into the portal circulation being delivered to the liver. And the summary of this is that if you're a lean person, 95% of the fatty acids being delivered to the liver through the portal vein come from lipolysis of peripheral adipose tissue going through the systemic circulation into the portal vein, being delivered to the liver. If you're obese, about 80% of the fatty acids going to the liver are derived from the systemic peripheral adipose tissue depots. So that means that your visceral fat contribution is 5% if you're lean and 20% if you're obese on average. But this is an average. And there's some people where the delivery of fatty acids from visceral fat may be 50% or 60%, where others who are obese, actually, it could be only 5 or 6%. And this was not measured in our metabolically healthy obese and metabolically unhealthy obese populations. And we know that people from South Asia and Indians have increased visceral fat. And this might be a reason why they might develop liver insulin resistance by having increased visceral fat and release of fatty acids to the liver, even though they're only overweight and not obese. But it does not explain the systemic insulin resistance that occurs in that population, because these fatty acids contribute a very small percentage of total fatty acids in the systemic circulation. Only about 6% in lean and 14% in obese people of the systemic circulations are coming from visceral fat. Now, the final thing I want to review with you is the new kid on the block, which is exosomes. These are small extracellular vesicles, where some remarkable studies have been done in rodents showing the importance of these extra vesicles in regulating metabolic health. And actually, it's a second, I have one more thing after the exosomes. And so these exosomes are vesicles that are made inside of the cell and released into the bloodstream. Every cell in the body makes exosomes and releases them to the bloodstream, particularly adipose tissue. And there's data from Phil Shearer's group that maybe 50% of the exosomes in plasma are derived from adipose tissue exosomes that release these exosomes into the bloodstream. Now, these exosomes carry a cargo. They have microRNA, they have protein, they have lipids that are delivered to other tissues, and they can deliver signals from one organ to another by unloading that cargo in other tissues. And it's microRNA that might be the most important messenger from exosomes to regulate systemic metabolic function in other tissues, because studies from Jerry Olewski's lab have shown that if you take exosomes from obese rodents made from their adipose tissue macrophages and inject them into lean rodents, you can make them insulin resistant both in muscle and liver tissue. And the mechanism for that are certain microRNAs that are carried by those specific exosomes. And so we did this study in humans, which has just recently published, and one more I'll show you that's not published, that the plasma exosome concentration in metabolic and healthy obese subjects is much higher than the healthy obese and healthy lean people. So people who are unhealthy obese have a lot more exosomes in their bloodstream than the lean and obese people who are metabolically healthy. And if you take those exosomes and incubate them with myotubes, muscle cells as shown here, and these are plasma exosomes on the left and subcutaneous abdominal adipose tissue exosomes shown here on the right. If you incubate them with these myotubes, you see that the healthy obese exosomes don't have any effect in terms of increasing or decreasing AKT phosphorylation, which is a measure of insulin signaling in these myotubes. But the obese exosomes cause a marked downregulation of insulin signaling. They cause insulin resistance in these myotubes, both exosomes from plasma and exosomes from subcutaneous abdominal adipose tissue. And remarkably, if you look at the serine 473 phosphorylation of AKT, insulin signaling in the myotubes from plasma exosomes and adipose tissue exosomes, those correlate with insulin sensitivity measured in vivo in these subjects as glucose rate of disappearance divided by insulin concentration. So this really does support the notion that exosomes from adipose tissue and exosomes in plasma cause insulin resistance in humans as well as they do in rodents. And here's a study we've just, or data we just got really a couple days ago, that if you take exosomes from people before they lose weight who are obese, and then after they lose 17% of their body weight, so they're much more insulin sensitive after this 17% weight loss. These are 10 obese subjects. And you incubate those exosomes again with insulin in cell culture systems with these myotubes. You can see that before losing weight in gray, these exosomes cause insulin resistance. There's decreased insulin signaling. And after they lose weight, exosomes from the same subjects, plasma exosomes, normalize insulin sensitivity back to the as control group shown here of just giving insulin with these insulin alone in the cell culture system. And here's the individual subjects. Nearly everyone gets, after weight loss, improves insulin sensitivity. A couple people, or one person only, had a decrease in insulin sensitivity. And now the final thing I want to review with you then is beta cell function. The talk so far was really focusing purely on insulin sensitivity. And there's some very interesting observations in beta cell function between people who are lean, obese, normal fasting glucose. Something got blocked here. Uh-oh. Back up. Go back. Not sure if I can go back. Previous. Okay, sorry. So if you look at lean subjects in diamonds, obese subjects with normal fasting glucose and normal glucose tolerance in diamonds that are black, obese normal fasting glucose, impaired glucose tolerance, open blue circles, obese with impaired fasting glucose and impaired glucose tolerance, solid blue circles, and then obese with type 2 diabetes with in black purple squares, in purple squares, which are really off the chart. You see some very interesting observations regarding beta cell function. The first thing in this, and this is measured by doing a 3-hour oral glucose tolerance test with frequent samples done in the first 30 minutes to get the beta cell response during this first 30 minutes when there's the greatest challenge to the beta cell because glucose concentrations are rising very, very rapidly in the first 30 minutes after ingestion of glucose. But you see here what you would expect. Obese people with diabetes have high glucose concentrations. Lean people are shown here as being normal. And the obese, normal fasting glucose, normal glucose tolerance, these are metabolically healthy obese. They're identical here to the lean subjects. And then the people with impaired glucose tolerance are shown here. And you can see here that the obese people with normal fasting glucose and normal glucose tolerance have a normal glucose excursion because they have an increase in insulin secretion shown here. And this is a much higher plasma insulin concentration than the lean people, much higher than the type 2 diabetes. And the type 2 diabetics have a similar insulin concentration than the lean subjects. So they have serious insulin resistance and beta cell dysfunction to give them type 2 diabetes. And the other subjects you can see here have massive increase in insulin concentration to prevent them from getting even higher glucose concentration shown here. And now this is the important part of the figures here in the bottom left. This measures the insulin secretion rate through mathematical modeling, which I won't go through now, in relationship to the plasma glucose concentration during the first 30 minutes of the oral glucose tolerance test shown here, when glucose concentrations are rising rapidly. And what you see is that people who are obese with normal fasting glucose, either with normal glucose tolerance or impaired glucose tolerance, have an increased response in terms of secreting insulin to any given plasma glucose concentration. So in relationship to the lean subject shown here in the diamonds. And so if you're obese with normal fasting glucose, your beta cells are hyper responsive. They're hypersensitive to glucose, where they have an increased glucose secretion rate at any given glucose concentration. These are not impaired beta cells in terms of decreased insulin secretion. these are hyperinsulin secretion in response to the same glucose challenge as shown here to a lean person and shown here to obese with impaired fasting glucose. And of course, very different than the type 2 diabetics shown here that's really off the curve. So people who are obese and have normal fasting glucose, we know they have twice as many beta cells as lean people from autopsy studies. And those beta cells are probably more responsive to insulin, to glucose, than a lean person. So they don't have, obese people don't have an impaired ability to secrete insulin. They have an increased ability to secrete insulin. But over time, presumably, this increased ability deteriorates. And when that happens, then their glucose concentrations, as shown here in the upper left, gets worse. And in fact, you can show this very carefully with my last data slide, which is showing you that if you take people who are lean and obese and they're matched on insulin sensitivity by the insulin clamp procedure, this is now a subset of the healthy obese people matched for lean people. You can see that their plasma glucose concentrations in the obese are actually lower during glucose tolerance tests compared to a lean person. And their insulin secretion rate, insulin concentration is actually higher, and their insulin secretion rate is higher as well. And so people who are lean, insulin sensitive, even though they're insulin sensitive, have a hypersecretion of insulin in response to glucose that gives us, if anything, a lower glucose concentration during a glucose tolerance test. So finally, let me just end here to underscore that obesity is a multi-organ disease. As was mentioned by one of the last questions before, we have to look at the whole body. We can't just look at individual organs. All these organs are affected abnormally because of these features shown here in the middle circle that causes these abnormalities on the right circles that cause heart disease and heart failure. And then finally, requires a group of people to do these kinds of studies. I want to particularly point out Gordon Smith, who has involved in a lot of these studies, Bruce Patterson did the mathematical modeling, Jun Yoshino, who did the gene expression analyses, and Bettina Mittendorfer, who did the final beta cell studies that I just showed you, but it requires technicians, dietitians, et cetera, to do these kinds of studies. So thank you very much, and I'll stop there.
Thank you, Dr. Samuel Kang. I think it was a wonderful disposition of obesity, how it causes type 2 diabetes. So, but I have one basic question. When 20% more of a weight we call obese, but when 5% loss happens, how the benefit comes?
Yeah, so very interesting, a very important question, and a question that we're still trying to answer. The overall question is, why does weight loss make things better? And why does just a little bit of weight loss, 5%, make things better? And if you lose 15, 20%, you can have remission of type 2 diabetes. You can revert diabetes. That is the Nobel laureate question, the billion-dollar question. What we do know, and we've studied, we're putting this data together now. It is not from inflammation, adipose tissue. Inflammation stays high. The immune cells, adipose tissue, macrophages, and inflammatory proteins are the same at 5% weight loss as they are before weight loss. But there is a decrease in PI1 in the bloodstream. There's a decrease in SERPINE1 gene expression adipose tissue. There's a decrease in collagen gene expression adipose tissue as well. And somehow those might be involved in this. The mechanism for it, we just don't know. But we are checking now. Could it be the exosomes, as I alluded to? It might be that the exosomes, I should mention, are different. But what is in those exosomes that make them different, we don't know. And we're studying the cargo of those exosomes right now.
Can these exosomes can be targeted with monoclonal antibodies?
Can we treat type 2 diabetes with monoclonal antibodies? No, we cannot. Leave that for COVID.
Fine, I think it's excellent. Dr. Arvind, do you have any question to ask?
I have only one question. I always, whenever I see Samuel clean, I admire his fitness. How does he remain so fit even now? Day in and day out, he exercises. How does he get the motivation to exercise?
Yes, so I do exercise every day, and that's because of psychological illness. If I don't exercise, I become depressed. I can't sleep. So I'm forced to exercise. I eat a lot of food, but I try not to absorb so much of it. And so that's another key. But I think what we should show, the final slide should show, is Arvind has a beautiful granddaughter. She's absolutely beautiful. Looks like his daughter is also very attractive. And you can see the daughter and granddaughter, luckily, look like his wife and not like him. So they're very, very handsome, handsome children.
I knew that was coming from Samuel Klein, and always expected that. Thank you very much, Sam, for that lovely lecture. Thank you so very much. And I know it's almost about 9 o'clock or 9:30 at your place. You have a great Saturday, and then we have a great conversational talk that's starting, and we don't have the next speaker, Dr. Celesta Thomas. I was told by Dr. Louis Phillipson that she's busy with inpatient at this point of time. There is an emergency.
Oh, okay.
I think we will accept that. It's absolutely okay. So I think, Vagesh, what we can do is we can actually close this session, and then I will request Dr. Prasanna Kumar to take over from here. Both Dr. Des Shorts and Dr. Lou Phillipson, who is the mentor for this particular ADORE, are going to be there. Dr. Prasanna Kumar will introduce the other two speakers of this particular session. It's just going to be a chat session. It's a chai pe charcha kind of a thing that we have, what we call as mentor grilling the masters. I mean, that's what we have now said. All are mentors as far as I'm concerned. All are my gurus, but each mentor will grill another mentor, and each guru will grill another guru. I think I'll request Dr. Prasanna Kumar to take over from here.
Thank you, Dr. Arvind. Good evening, everybody in India, and good morning to those in USA. It's my pleasure to invite you all for this session. And my good friend, Professor Des Shorts, is one of the participant panelists here. He is an MD, professor, and interim chair of pediatrics, medical director of Diabetes Institute, and director of Clinical Research Center within the CTS at the University of Florida. He has been involved in type 1 diabetes for the last 4 decades, and he has more than 360 manuscripts, and all of them are type 1 diabetes. Unlike us, we have 150 publications in 35 topics. He was awarded Mary Taylor Moore and Robert Levin JDRF Excellence in Clinical Research Award and 2009 Cure Award from the American Diabetic Association, the 2010 Public Policy Leadership Award, and many other achievements and awards that he has got, and ISPAD Prize for Achievement. Recently has received 2020 years Allen Garber Lectureship Award and was 2020 recipient of University College of Medicine Lifetime Achievement. He was also the president of American Diabetic Association. Next, please. Dr. Lou Phillipson is the James Tyree Professor for Diabetes Research Care in the Department of Medicine and Pediatrics at University of Chicago. He is the founding director of the Covier Diabetes Center and served as 2019 President for Science and Medicine for the ADA. He has received the Banting Medal for Service as a part of 79th Annual Scientific Conference 2019 for his term as President for Medicine and Science. He has various publications, and he was inducted as laureate of the Lincoln Academy of Illinois. Today's program is, I will present 2 or 3 cases depending on the time, and I want the expert to give their opinion, and we'll discuss the case. This is exactly what has happened. These are not hypothetical cases. These are the cases that I have seen, and I had problems, and we'll ask our esteemed faculty to tell us and what we have done, what we are likely to see in this case, what are the problems and prospects, and how does management of, can you see this slide?
Okay. We can't see the slide. I think you have to share screen.
Now I will, yeah, just a minute. Now?
Now we can see.
Good, thank you. So the heading for this is reasoning challenges. What are the challenges in management, and how hope to reality of type 1 diabetes management? So instead of talking hypothetical case, let me present a case, and I want both Des Shorts as well as Lou Phillipson to interact. They can stop at any time and ask me questions or what they think about the case. A 7-year-old young boy presented with polyuria polydipsia for the last 2 months on 25th September 2020. The child had RBS 530 and was admitted to a hospital, in a pediatric hospital under care of pediatric endocrinologist. He had lost 2.5 kg in 2 months. The child has vomiting, tiredness, hurried breathing. Birth history full term and cesarean section. Birth weight 3.2 kg. Cried immediately after birth. No perinatal complication. Developmental milestones appropriate for age. Child studying 3rd standard with good academic and social performance. Family history, non-consanguineous child. Both parents non-diabetic. Paternal grandfather, maternal grandmother had diabetes. Child was allergic to bronchitis requiring nebulization. Diagnosed at hospital was new onset diabetes, probably type 1, ketosis, no obesity, no acanthosis nigricans. And this child is actually an American citizen, Indian American. They were in New York and New Jersey. They came here 2019, and that time the child developed these symptoms. And this is the paternal family tree. As you can see, the child and the parents and the grandmother, grandfather, you can see. And this is what you see. This is the maternal family tree, as you can see here, the child as well as the parents as well as the grandfather, grandmother. Now, at the time of admission to hospital, heart rate was 140, oxygen 100, respiratory rate, systemic exam normal, conscious oriented pupil 2 mm. Child was 138 centimeters tall and weight 32 kg, BMI 17.2. There were no signs of acanthosis nigricans, nor the child was obese. Now, these are the investigation done in that hospital. Thyroid function tests were normal, anti-TP was 13, then ultrasound abdomen normal, A1C 9.72. Anti-tissue plasminogen activity was less than 0.1, so negative. Celiac disease was ruled out. Immunoglobulin IgA 139 and less than 12 years, it was 29 to 270. GAD antibody was negative. Diagnosis, type 1B diabetes, because the GAD antibody was negative, the child has ketosis. Insulin antibodies was normal 9.03. They thought it is type 1, but negative. B12 was normal, D3 was normal. Child was referred to endocrinologist after discharge. Now, this is the management of the child in the hospital, admitted in pediatric ICU. Ketoacidosis was managed by IV fluids, insulin drip, antibiotic, blood gas analysis done. Sodium potassium chlorides were normal, discharge and basal bolus. Child needed 12 to 14 units of this one. Now, she was referred to me. Mind you, that was in September. I had seen the child in January 21. Fasting was 145, postprandial 260, A1C 9.7. Even after discharge, renal function test, everything normal. Child was getting hypoglycemia with 2 to 3 units of insulin per day. Insulin was stopped. I checked C-peptide, it was 2.43, and diagnosis was type 2 diabetes. And previously also GAD negative. I confirmed in my lab GAD negative, C-peptide 2.43. 3 months later, April 2021, that's the time they had gone to USA back because they were on a holiday for some time. And diabetes was well controlled. All blood glucose before and after food were normal range. I hope you can see this. This is how you see from April 8th, and you have got the AGP till 22nd April. 14 days, as you can see, the curve is absolutely flat without insulin. This is the stage. I would like my co-panelists, both Lou Phillipson and Des Schatz, to comment on this patient.
Please go ahead, Dr. Schatz. I'd like to hear what you have to say.
Well, this is why, you say grilling each other. This is wonderful. Firstly, thank you for this invitation. It's incredible to be here with friends and with Lou and Kumar and Aravind and really Sanjay. All really, it's wonderful to be here. This is terrific, and so much you've presented and so much to digest. But I think this should be provocative. So you presented a 7-year-old with classical features of type 1 diabetes. I mean, classical. You've got polyuria, polydipsia, and diabetic ketoacidosis. So to me, immediately, that's type 1 diabetes. Now, what you also show, which really doesn't go at all, is your C-peptide. I mean, you would have thought that with at least some preservation of insulin, I mean, you would have expected not to see diabetic ketoacidosis. Yes, we do see it in type 2, and 30 to 40% of really obese type 2s, particularly in the African American and Hispanic populations in the United States, may present with ketoacidosis. But I have to again ask you, I couldn't remember what the weight was. Where did this child fit, on a growth chart? So that was my first question. The second thing is, don't rule out classical autoimmune type 1 diabetes just on the presence of those antibodies. Remember that if you look at the old classical islet cell antibodies, 60 to 70% of type 1s were positive. If you look at GAD, it's probably about 60%, only 60%. More common, ironically, in older patients than in younger patients, but it's certainly not 100%. When you add insulin autoantibodies on their own are about 40 to 50% in younger patients. And if you add them together, that does go up. But there are other antibodies too. And there are IA2 antibodies. There's also ZNT8 antibodies. So in essence, you really have 5 antibodies, of which you have done 2. If you take all 5 of them, we even don't get to 100%. We're about 90 to 95%. So, depending on the availability of other antibodies, my question for you is, can you do them? Are they available? Where is it? It is quite remarkable to me that you've achieved such incredible blood glucose control soon afterwards in such a young kid. So that to me is, is this a honeymoon period? You're obviously putting this up here, and the family histories you went through a little too quickly for me to really digest both the paternal and the maternal side, because my initial feeling was I saw, the grandparents had type 2, didn't really start thinking anything about, autosomal dominant diabetes, which is Dr. Philipson's wheelhouse. But I would probably say to you that for now, as part of the debate, I'm still pretty, leaning towards classical type 1 autoimmune diabetes. There are some questions, I've never used, and this is another part of it. I don't believe that C-peptide plays a significant role in the classification unless it's really high. So, we see this in type 1. We do see, values, anything from 0.1, depending on a sensitive assay, all the way up to 3. So I still think this is consistent with type 1 diabetes. And, again, congratulate you on the incredible, management to date. And I will punt it back to my very good friend, Dr. Philipson.
So that's terrific. And of course, I also first would like to extend my thanks for being included. I think, these are sessions I think we should see more and more of, actual case discussions. And in this case, perhaps cases that look straightforward but may not be. So everything that Dr. Schatz said, I think I agree with, which is very unusual. So the main points that it would seem to be at first blush a classical presentation of type 1 diabetes in a 7-year-old. That I did notice a few things. I think the anti-TPO antibodies were positive. So even though the thyroid functions were normal, there does seem to be at least some evidence of other autoimmunity. And certainly I agree that the IA2, ZNT8, I mean, those are what we do standardly here, in my practice, although certainly not yet standard of care. And that is something that I'll come back to perhaps later. I did take a quick look at the family history, so that's because that is close to my heart. It looked like to me, neither parent had diabetes. So if that is the case, and then it does rule out, most cases of the autosomal dominant kinds of monogenic diabetes, which we would usually see in at least one parent, assuming, of course, that the parents, are who we think they are. So that's a small issue that is interesting. And of course, then you mentioned quite clearly that there was no consanguinity here. Now, that's an interesting issue, depending on where the parents are from. There are many towns all over the world where even a random met individual is equivalent to your second cousin, depending on sort of the town and how small it is. But we'll assume that that's not the case for the moment. So all of that I agree with. And so now this child is off insulin. So I further agree with Dr. Schatz that C-peptide needs to be interpreted very carefully. So I take this moment to remind people that my teacher, Don Steiner, was the gentleman who discovered C-peptide, and my teachers, Dr. Polanski and Dr. Rubenstein, really much of their career was based on interpretation of C-peptide. And Dr. Schatz is again absolutely right that measuring C-peptide sort of during an episode of DKA or immediately after tends not to be helpful. Now, the leader, I think, in understanding this right now may be Andrew Hattersley and his group at Exeter, who have said that measuring C-peptide in new onset type 1 less than 5 years out, somewhere between 3 and 5 years out, is actually not helpful. And that this may be a honeymoon situation, that the beta cells were exhausted, so that explains the DKA, the insulin, exogenous insulin was able to allow the beta cells to regroup in one way or another, and then later on, they become normalized. So that's what it looks like. Now, from a research level, there's a couple other things we might do. So in our lab, we're now doing something called the type 1 diabetes genetic risk score, which was also contributed by Dr. Hattersley and his colleague, Dr. Richard Oram. And what that does is look for specific sequences in the HLA area to see whether there is at least a tendency for autoimmunity. And there was some concern at the very beginning, a couple of years ago when this was introduced, whether it would extend to non-English populations or non-Caucasian populations. And I do know there was at least one confirming study in Pune, which suggested that it could be useful outside of the UK. And we've been using it with some help. And so the interesting thing there is if the score is very low or very high, just like Dr. Schatz said with C-peptide, very low or very high. So at the moment, pending more information, I'm leaning towards classical type 1 with a honeymoon period, and that farther out, I would anticipate that this child would eventually go on to need insulin, but I'm prepared for a different outcome as well.
Thank you. I will pose some questions to you before I go. The story doesn't end there. Story continues from April to December 12th. I will come back to that. You wanted that family tree. I will show it to you again because maybe I was in a hurry. I will show you again. So what is your interpretation? Paternal family tree. Black is one where affected and white is not affected. As you said, both parents were not affected. Can you see this?
Yeah. Oh, yes, we can see it. Yes. So I mean, again, this is something that we're very used to looking at. It is interesting, you could say. So the one, I'm not entirely sure which side, but at least one grandparent seems to have diabetes, right? And then there is the sister,
yes,
of the grandparent. So is that right? So who has multiple family members on the left with diabetes, but so it does suggest there's a possible recessive cause of diabetes here, which could be very interesting. And then if that was the case, sort of what would those be in this case? So there are now a growing number of recessive causes of diabetes. There are some causes that are also familial autoimmune, but we don't have right now yet a discussion of whether there's evidence of autoimmunity in other family members. So this has become also part of our research interest. And as I teach our fellows that since we do have the anti-TPO positivity, I would go back if this was my family and try to inquire very carefully any evidence of any other autoimmunity, which beyond thyroid and celiac, which often, as you point out in the presentation, indirectly come as a triad, then is there Crohn's disease? Is there MS, rheumatoid arthritis, Raynaud's? So the whole history of autoimmunity in any other family member would also tilt me towards a diagnosis of some form of autoimmunity. I can say our group has also been very interested lately in unusual forms of type 1 that are inherited and can cause multiple autoimmunity. So there are a growing list of genes in that area as well. But that's where we are right now.
But I will not put much emphasis on anti-TPO because 8% of the normal population has got antibody. So I will not take it that somebody has an anti-TPO, whether I look at pregnancy or children or adult old people. This is what we see, especially in South India. There's a very high prevalence of anti-TPO. That does not mean the presence of an antibody will guarantee disease even following 30 years.
So I completely agree, but in a 7-year-old, I would find anti-TPO to be a little bit unusual. So certainly with age and with females, then I would expect there is definitely a background. Just on the other hand, and sort of the opposite of what Dr. Schatz was saying with anti-GAD, not only are only 60% or so people positive, but there's also a false positive rate of anti-GAD, which is something like 1%. So that also becomes something that you have to weigh carefully. But
this
that's
is
not
maternal family tree. How do you interpret this maternal family tree? That was paternal. Now you can see maternal, the child, and then you can see that grandmother, grandfather, diabetic at 40 years, 60 years. And one of their daughters were diabetic, not this parent, this one.
Yeah, so again, it's suggestive that there may be a recessive form, but certainly nothing dominant. And at the moment then so can we sequence? I mean, the question is what to look for if we had the ability to do genetic sequencing. What are some of the things that come up? I mean, that, we have rare forms of, so now we get into the most unusual kinds of diabetes, which may or may not show up to this extent. Some of them are very modest, but we might talk about Wolfram syndrome or Walcott-Rollison. Some of those are very interesting. In the past, we've also talked about GLIS3 as being something that has both thyroid and diabetes. But so at the moment, I don't see a strong reason to think about that. I would follow the child for a while and see what happens clinically.
Now, Professor Deschardt says if he were to be there, he will get the all antibody test.
I actually agree with almost everything that Dr. Philipson said. This is like a first. Just a couple of points. The only point about autoimmunity I disagree with is remember that we rarely, if ever, see generalized autoimmunity in tandem with organ-specific autoimmunity. So you're likely to see patients who have type 1 diabetes, autoimmune thyroid disease, autoimmune adrenalitis, Addison's disease, perhaps ovarian disease, organ-specific, but you rarely see them, with more generalized. You rarely see type 1 diabetes with lupus. You rarely see it with rheumatoid arthritis. You rarely see it with multiple sclerosis, Crohn's, etc. So organ-specific autoimmunity does tend to congregate. And so certainly in this particular case, I would definitely say, before I went into anything, Dr. Philipson's 100% right. We need an HLA here. We really need to know this is a young kid. There's genetic loading in young kids. And, particularly in this group, over 40% are DR3/4. And so that, whether that's as part of a GRS risk score, which, certainly all of us can do for you for free if you probably sent it, to us, or you could probably do it yourselves. But I would say that getting an HLA on here would really help me. I agree with Dr. Philipson. I'm not that impressed with the family tree. At this particular point in time, it's more a red herring, to sort of think about these weird and wonderful causes of diabetes, these inherited forms, these really rare forms. But, I always like to think, what is the most likely thing? You've treated this patient appropriately, and you've obviously feeding us. You're getting ready for the sharks here. I sort of think, here's the beginning, and we're probably digging our holes. and now we're going to have to get out of them. So Kumar, it's back to you.
Okay. He said February is going back to USA. Then I told him, this is what I can do. When you go to USA, there are two top people, I'll give their names, and you can go and meet them, Professor Lou Philipson in Chicago and Des Schartz in Florida. He did not see you, but what happened to this? He went to New Jersey. This is your lab corp in New Jersey. They took the sample, and Des wanted all these things. Insulin antibody 16, GAD again negative, anti-TPO negative, zinc transporter rate, what you are telling was positive, 152, 21 hydroxylase antibody negative, C-peptide was 1.0, and transglutaminase was less than 2 negative, insulin was 4.3, and C-peptide negative, thyroglobulin antibody negative. Now, will you change your diagnosis or stick to that?
Absolutely. Yeah, go ahead, Lou.
Well, I was going to say we go back and forth on, what the surprises might be. So here we have a strongly positive ZNT8. I mean, that's the most impressive positive. For the anti-TPOs was repeated and now negative. So that many antibodies, in fact, and Dr. Schatz has been one of the leaders in figuring out the natural history of antibodies. And so I learned from him, and we know that antibodies can come and go, but this one, clearly the ZNT8 is high. The other antibodies are negative. I think what's also interesting is that, the C-peptide, and of course, measuring C-peptide, is also fraught. I mean, we all, my friend and dean, Dr. Polonsky, would say that unless you measure it dynamically with the glucose at the same time, you really can't interpret it. So, and so exactly what Dr. Schatz said earlier is correct. It's only really interesting if it's very high or very low, unless it's in a dynamic situation where you're stimulating C-peptide. So the C-peptide itself is not terrible. The insulin is reasonable, but it looks to me like there's autoimmunity here, and that it's a matter of time before we'll see a decline in beta cell function. Still, I'm still going to say that.
Des Schartz?
I couldn't agree more. I absolutely agree. So, you do notice the insulin antibody is positive, but anybody who's been on insulin for more than 10 days. So just to let you know that, you're going to get insulin antibodies. These are not insulin autoantibodies. So if you are going to measure insulin autoantibodies, it has to be within 10 days of therapy. Otherwise, it could be positive. And by the way, not all patients on insulin probably, develop insulin antibodies. That's in itself is a separate area for discussion, as to why not everybody develops, an immune response to insulin. It's probably some get very high, some get very low, and some don't even make a response to insulin. So that's an interesting area. But, the ZNT8 and why somebody, this is sort of part, I think, of the future. Why does somebody not develop an immune response to GAD, but does to ZNT8 or maybe to IA2 antibodies? I think that's certainly going to be, I think that's the future, that as, you've heard Dr. Philipson dissecting, the various perhaps recessive causes, there's clearly a heterogeneity of type 1 diabetes. And we're obviously looking for biomarkers. Right now, we're lumpers rather than splitters. But I think the future will be splitters. And it's probable that for those that only have a response to, I'm hypothesizing here, that those who only have a response to ZNT8 may act a little differently, or there may be something else related to both the etiology and natural history of the disease, as opposed to those, that have, let's say, multiple antibodies. I will tell you just from the TEDdy study that there is a different course in early type 1 diabetes, that we think that there's a different etiology for those who develop IAA first, as opposed to those who develop GAD first. IAA certainly occur within the first, let's say, couple of years of life. And that's why people are saying, well, maybe that's enterovirus related, and maybe, an enterovirus vaccine may be effective in a subgroup of people. It's not going to be effective in all, because for some, IAA is not the first, and GAD may be the first. And so therefore, there may be a different course of the disease or a different trigger, if in fact, I've heard people say we should stop talking about triggers because we haven't found, any triggers of type 1 diabetes. But anyway, having said that, I think that this to me is, if it's not a false positive, this is a high titer. I mean, if it's greater than 15, I mean, this is serious positivity. I think this certainly puts us into the type 1 autoimmune, category. But again, the natural history of the disease will be interesting to follow, whether it's the same or different. So yeah, I'm excited to see what happens.
Yes, he came back to India November 3rd week. And from April 1st week till November, the child was off insulin. He came to India in November, the child got fever 2 days, and he was monitoring that, and the blood sugar started 200 to 300. Restarted insulin without asking me on his own. The father started that as per 2 units 3 times a day, and then Glargine 2 units. And this is what you have till 1st December ambulatory glucose profile, as you can see. This is with insulin.
So as I said, I mean, at this point, I think it is as predicted. I mean, so we would expect loss of insulin secretion with time, even though the C-peptide and sort of random insulin levels may not be helpful. I mean, at some point, so it would be interesting to talk about what could be done in the future. I mean, so this is a child who's developing what looks like a low insulin diabetes, which is most likely type 1 in this case. I don't think anything other than that comes out from looking at the CGM, but it is great to see the CGM, and then so we can perhaps tailor the insulin dosing to the CGM, and then the obvious thing eventually, even in a child, would be to use, at least when available, a combined pump sensor for treatment. But then we also have a long list now of potential autoimmune interventions, which are all experimental. Several of them are being spearheaded in Dr. Schatz's shop there. And nothing is ready for prime time, but at our place, we're aware, so we're trying to develop at least 5 different studies, one with the Immune Tolerance Network, one with funding from private philanthropy, and 3 different drug studies from pharmaceutical companies, all of which would have been useful here, perhaps in the early stages, but some of them are phase 1, the others are phase 2. So we're certainly not there yet, unfortunately, for intervention, but this pattern looks like that to me. And so Dr. Schatz, would you say anything else about it?
No, I agree. You're absolutely right. This is not a candidate for immune therapies at this stage. You're absolutely right. Earlier on, and if in fact there was positivity, within the first few, at least, well, it's an interesting theory, but at least earlier on in the disease, I would have said that. I mean, it's clear to me, as I'm just looking at this, if I can see this right, there's postprandial hyperglycemia. So clearly the dose of insulin needs to be tailored. And by the way, we don't know what this kid is eating, right? So, something like learning about carbohydrate counting would certainly be something that I would really emphasize in this particular family, learning to do this, and then understanding, what dose of insulin needs to be given before the meal. So, you had put down, I think it was 2 units or sort of a fixed dose of insulin. Well, it looks like they're certainly starting off okay. In a couple of cases, in fact, in all the cases, actually, there's postprandial hyperglycemia. It also looks like there's nocturnal hyperglycemia as well. So I think that the dose of Lantus needs to be, increased. Obviously, the nutritional practices of this family need to be understood. The exercise, what's happening. I mean, remember that this is a holistic approach. Don't want to just think of insulin as the only tool we have, the only hammer, and that glucose is the nail. That's not the case. We need to understand more. So this patient, this family needs diabetes education, needs a nutritionist, and really needs to understand, but I do think that there's opportunities, certainly for improving this kid's blood glucose management.
I have not seen this child. This is what I got from e-consultation. And please see this, the patient's father started insulin. And the previous one, they have been told about carb counting, how to give the insulin, everything, and how to adjust it. It was all that they have been taught. Now, I don't know what has happened between 1st December 12th. In next 2 days, he'll be meeting me. I didn't advise anything because I thought, let me see this when you come tomorrow. Let me go through the whole thing. Last I saw him was January 2021. And all these things just by mail. And he was out of my contact April till last week when he showed this. So we'll be able to do that, and I'm sure. This is what father thought I should start with a basal bolus, but I don't know, is he getting the same or increase the dose? So this is where it stands. And next week when he comes, I'm sure next 2-3 days he has taken appointment. So he'll be coming. Then we'll be able to see what has happened. Has he done the carb counting, and whether he has given a boluses when it is high, adjusted the basal and bolus. When he comes there, I will know about it. So this is where it stands. And this is the first case.
Well, before you go on, I just actually was interested to ask Dr. Schatz a question. I mean, certainly, I see both adults and children. And so for adults to see a prolonged honeymoon is not at all unusual, but still many adult endocrinologists don't have a grasp that a honeymoon period in adult can last years. And certainly I have several people who are airline pilots who will lose their job if they go on, at least now it's a little bit better in the United States, but at the time, if they went on insulin, they would lose their employment. So they struggled mightily to do everything they possibly could. And that's everything Dr. Schatz said, diet, exercise, religiously, even perhaps more than Dr. Klein. And they were able to stave off insulin in some cases for 5 or more years. Now, many endocrinologists would say, we don't know what that is. I say that's clearly a honeymoon period. It's a slow progression of type 1. My friend, Dr. Harold, our friend, Dr. Harold may say it's a different disease. I mean, and I've heard this now from other people that pediatric endocrinologists see child like this with 1 day, sort of a little bit of weight loss, and then you have the DKA and then it goes back. But Dr. Schatz, I don't think this period of being able to be without insulin is very unusual, but I don't have in my head what percentage of children might have a honeymoon that lasts a year or more. I think it's certainly not insignificant.
Oh, I agree with you completely. Whether the disease itself is different, we don't know, but you're absolutely right. It's definitely slower, and the rate of beta cell destruction is so much quicker in younger kids than in older kids. Couldn't agree with you more, but we do see this, right? So if you were to say somebody who's islet cell antibody positive in the first 2 years of life has a 90% chance of progressing to diabetes. It's about 11% per year in the first 5 years, and then it decreases thereafterwards. In adults, if you test positive at the young or old age of 30 to 40, your risk of developing diabetes is only about 20%. So you're absolutely right that it's much, much slower. We do see this, and I've seen patients, as is Dr. Philipson, very good point, that have had 4 antibodies. And we would tell them, oh, gee, you've got 4 antibodies, you're probably going to get diabetes, certainly within the next couple of years, and 10 years later, they still have 4 antibodies and haven't gotten on to diabetes. I've also seen patients that have presented with DKA exactly like this. And, I've done research on them later on, because I remember one kid, particularly from sick kids in Toronto, in Canada, that came down here, that came in DKA, and I said, I really don't know if I can stop insulin in you. You had DK, you were managed by a guy that I respect very much, Dennis Danneman. He knows what he's doing. This is type 1. We are going to do this. And this person went into honeymoon for a couple of years, to the point that I even used a sulfonylurea after a couple of years. And then after about 4 or 5 years, went back onto insulin. So I couldn't agree more with Dr. Philipson yes, it's not very common, and most kids, young kids, do not have the honeymoon. But this is an interesting way to look at it. Here's a ZNT8 antibody, and I would love to say, are those that have ZNT8 antibodies more likely to enter into a prolonged period of insulin independence? I think that's a good, it's a good hypothesis. I don't know if we can validate it, but those are the kinds of things I really do believe. And this is another debate that I've had with some of you all know Jay Schuyler and others, but I actually believe that we in diabetes need to think more like cancer. And the way we've sort of done this in TrialNet, which frankly I've opposed, is that we have to do phase 3, well-powered, studies that are going to look at, whether you see an effect in a big population. They're destined to fail. Say that right up front. They're destined to fail because look at the disease. As Lewis said, they're different. I mean, I don't know if they're different etiologies, but some are slower, some are faster, and you put these all together and you start thinking about it, it's not like it. If you look at some of the great strides in cancer and you think about, the Philadelphia chromosome and its response to Gleevec, these are specific things. So I actually think that we're going to need to study smaller groups of patients, try and understand biomarkers, try and get them. And here you've got one testable hypothesis right up front. We haven't cured diabetes yet, but at least starting to think outside the box that, are you giving me, yes, I'd like to see the HLA and I'd like to see the genetics and I'd like to see a few more things. But a way out of the box thinking could be that, for those that have ZNT8 antibodies, for somehow it appears that maybe there's a prolonged honeymoon, as Dr. Phillipson said. So I agree with everything that's being said.
Thank you. The longest I have seen honeymoon period was 10 years in an adolescent. He took for many years and we had gone through everything, 10 years. Then suddenly he comes with 300 ketosis. As you said, maybe they are slowly progressing, unlike what we see. We move on to the next and the last case because of paucity of time. I'll quickly finish. Here is a 12-year-old boy, and a few months back he came, 155 centimeters, 58 kg, almost normal weight. Birth weight 4 kg. Mother was diabetic. Both maternal grandparents had diabetes. So 3 generations. A1C 10.2, fasting 155, PP 288, C-peptide 1.4. GAD antibody was again negative. T4 TSH normal, and currently he is taking the insulin 16 units morning, 34 in the night, and he is on metformin and vildagliptin. And now we thought because of this strong family history, we will do the testing, and this is what the report we get from a CAP accredited one. I think Professor Lou Philipson can see. They said no pathogenic or likely pathogenic variants causative of the reported phenotype are detected. And these are all the genes they have sequenced.
So who is doing that? Is this at
MedGenome here in Bangalore?
In Bangalore?
Yeah.
Well, okay, great. I mean, that's an exhaustive list. I mean, obviously there's more, and we're always looking a little bit more down the road to see what else is happening, but these certainly include sort of the more common and even very uncommon causes, and some of these genes are actually not thought to be causing monogenic diabetes at all. So it's an interesting list, and of course, some of them, it's not only the sequence that's important. I mean, if we were to go back and look, for example, HNF1 beta, I would look to see, have they also done a deletion analysis? So usually that's a separate report, but most companies are now also looking at it, because in the case of that particular one, which is also MODY5, there's most of the causes are actually a deletion, so the sequence would be normal. And then some of these others are clearly syndromic, and you haven't mentioned any syndromic features yet. So we need more history.
No, he doesn't have any other feature. As you told you, this is his height and weight. no acanthosis nigricans. He never had ketosis, and I didn't admit him. He straight away walked in, and then these are the things. He's far away from place. He has another monozygotic twin. I asked him to come, and then we will check with his antibodies. He has not yet come. He's about 400 kilometers, but because mother diabetic, both maternal grandparents diabetic, I thought it is worth getting. I mean, and he's still on insulin. Though I have added to see what happens to it, still the blood sugars are okay right now with this regime. I don't know whether I'm justified in using that, but hesitantly I started because of all these things. He's responding well. Whether I'll be able to reduce insulin or he'll be back only on basal bolus regime. I have not put him on bolus basal. He's managing well with it.
Right. So most of my comments so far are with etiology. Even though his antibodies are negative, I still would think about type 1. I think one of the things that we're learning in some of the research we're doing, we have a large multi-center trial called Radiant. And of course, I say we spend a lot of time looking at what other groups are doing, that the monogenic causes are rare. I mean, it's certainly not more than a few percent of the children, although a few higher percentage in younger people than in older people up to the age of 25 or 30. So I certainly would consider them, but in a case like this, I would still do what some of the things we said in the previous case, that looking for specific areas in HLA using a genetic risk score, that might help me. It's not definitive. It only gives you sort of a statistical way of looking at it that isn't perfectly etiological. And maybe Dr. Schatz will comment also on the choice of therapy. I mean, I think for me, in a child like this, I would probably go with insulin alone. I mean, so we can discuss that. Metformin, even though, it's always at the top of everyone's list, even in obese, I'm very disappointed at the effect of metformin in reducing insulin resistance. I don't really get the sense that it's useful. We try it in some of the younger people, if there also is a weight loss issue with giving too much insulin and seeing weight gain because of treating hypoglycemia, then metformin is sometimes tried. I rarely see it effective, and usually people don't realize they're having side effects, that they have mild abdominal pain, they may have occasional diarrhea, they don't relate it to the metformin, and you stop the metformin and they get better. And then the vitagliptin, again, I don't, once you're on insulin like this, I don't see necessarily an adjunctive benefit from a DPP-4 inhibitor, if that's what I think that was. And so that's the extent of my comments right now. We need more information, and we need to figure out a better dosing.
What about the family history with 3 generations having positivity, mother?
So it's very interesting, but so assuming that everyone is from South India, so we have a strong family history, which could be type 2 as we see, and it may be not helpful etiologically. I would want to know more, of course, like what drugs are the parents on, at what age they develop diabetes, what about their siblings. So this is where you can spend a lot of time with the family history. And I often, when we teach, and if we have a medical student or a trainee, I said, you may not think that this is interesting, but you actually can get the patient to tell you what they have if you spend some time and make sure that you get all of that history. So I would delve a little bit more and satisfy myself that that it may be a different kind of diabetes. So that, and now I'm interested to see what Dr. Schatz has to say.
But it's never before have we not been able to argue. I'm in agreement with everything you said. I too lecture to medical students and say, and at the end of it, after your history and physical exam, you should know pretty well what the diagnosis is, without the need for other laboratory testing. And it's a dying art in the United States. Because of time, because of money, because of a whole bunch of things, you're forced to see more patients. You don't spend the time. You don't have the relationship that trying to think of the good old days that we had when we practiced what I would say is during the golden age of medicine and science, but it's very different the way that it is today. So I couldn't agree more of getting a really good history. When did they present? what was the family history of it, are they obese, even by the criteria that you're using, which may not be the US criteria, but are they, certainly overweight, are they obese, how have they been managed, what's going on before, you do this. I mean, you certainly doing this and your understanding and getting this test is quite absolutely incredible. I had to sort of just look, we know of at least 14 kinds of MODI, and you've certainly looked at a whole bunch of other things that we really don't have any idea what they may be doing. But I too would say to you, what was the rationale for using the metformin? Again, I don't have a growth chart because I always like to put people on a growth chart. This is 58 kilos, and this is a 12-year-old. I'd like to just sort of see it. What was the rationale? If you did it at an early stage, even before this, why did you choose metformin, rather than a sulfonylurea? If you were thinking, of an HNF1 or HNF4 alpha, thinking about those kinds of things. And then, the data about, the GLP-1 agonists in type 1 diabetes right now is very soft. There's, very little data to suggest that. And in fact, I'd be personally a little cautious about doing this in kids who are, where you're worried about growth and puberty, that's coming in. So just a hint of caution, and I would have done, exactly the same at this particular point in time, and perhaps even more so now that you have this, negative gene testing, is to, try and put the patient onto a long-acting insulin, basal bolus, and if possible, using, the shorter acting insulins rather than the regular insulin, but understanding whatever is available, frankly, I get it, whatever is available. But I think that you've thought about this, but I think a little bit more, detail, from a student or from someone else will also go a long way towards what I would think is predicting, the likely insulin dependency of this particular patient.
I'd like to say a few words about this list of genes. So there's roughly 40 genes on this list. And 5-7 years ago, this would have been $20,000 to $30,000 worth of genetic testing at a minimum. And of course, many of these we didn't even think about testing more than a couple of. This is a very up-to-date list of, as I say, almost 40 different genes. The problem is, I would have not recommended most of these genes. Some of them are very peculiar, and I could just take a moment. So CEL, for example, is a handful of families, mostly found in Norway at this moment, from Dr. Paul Nolson, and those are, so that's an example of a acinar pancreatic gene. So anyone with CEL, for example, would also have a pancreatic insufficiency and probably a growth disorder. LMNA is a gene associated with lipodystrophy. So unless the child has some sort of obvious physiologic dysmorphology with adipose deposition, I would not have included that in the list. And I could go through all of these. Some of them, KLF11 and BLK, extremely controversial whether they have any relationship to diabetes at all. And the EIF2AK3, that's the gene that underlies Walcott-Rollison that I mentioned. So that's a very interesting thing where often bone lesions can precede the development of diabetes. HNF1 beta, I mentioned earlier, usually renal cysts. There can be other abnormalities. So you can go through all of these things, and I would say of this list of 40 genes in this particular situation, not more than 2 or 3 of them would even be a consideration. But because this is so inexpensive now, and so it's almost like, this is what Dr. Sach is saying. You see the patient and you get a CT scan before you actually, examine them. So this is a very interesting list. In our lab, it's been very difficult to get any sort of standardization of genetic testing as long as we have this in front of us. Many labs are still doing 5 genes, 2 of which are probably not useful. In our research-based platform, we're doing 200 genes as a rule, but 140 of them are imaginary. We have just thought, like, what could possibly be the case? And now it's so inexpensive. For $1,000, which we can do on a research basis, we're doing all of the genes. So we're doing 20,000 exomes. And then in another one of our research studies, we're doing whole genome testing, which just a few years ago was $1 million worth. And now again, it's less than 1,000. But the interpretation is what is now very confusing, because we don't understand many of the findings that actually we're seeing. So that's what we're seeing here. I think it's fascinating. You mentioned this is a monozygotic twin. And so understanding this case is actually very important for the twin, and to understand what the genetics are. So having said all that, I don't know that you have any more. You haven't seen this patient yet, I guess.
No, because the patient was brought by a relative, not by parents. And as I said, they are from a rural area, 400 kilometers. The history I could get was most of them got diabetes between 40 to 50, whether parents, grandparents, they were all on oral anti-diabetic agents. How good is their control? We don't have any information data, because parent did not accompany this child as such. That is how, this is all the limited history what we can. I told them next time to bring their parents. Last time I saw was about 6 weeks back. They are still in touch with me over the e-consultation, sending that every week, sending their blood sugar, adjusting insulin. And initially we thought maybe type 2 diabetes, let me try metformin. That's how it has started. Then I found it is not making any use. I've withdrawn these things and I'm putting them on basal bolus. This is what situation few weeks back. And as you said, that most likely he will benefit only by basal bolus. This is not going to work in this patient. It has not made any dent as such in this patient. Right. Regarding this panel, it comes as a panel, $200. That's what they charge. I can't ask them do only 3 or 4. It doesn't make difference. He will charge $200. $200 is something most of my patients can afford. It is not a big sum as such. So that's why they do it as a package. Even if I say do 4 or 5, they're going to run the whole panel. And it took about 3 weeks for this to get this data.
It's amazing. It's amazing. I have to say, I've had, and as you know, my friends have had many conversations with Dr. Mohan in Chennai and with Dr. Thomas in CMC Vellore. And, what is interesting is that even in families where in Caucasian populations, we would absolutely expect to see a monogenic cause in the South, especially in South India, although I don't know as much about North India. We're not seeing the same sorts of genetic changes that we would expect. So there's something yet understood. I mean, Mohan always makes the point that the incidence of diabetes in the South has increased, 5-fold since he and I started practicing medicine, and the genetics obviously have not changed. So there are other factors here. I mean, again, though, I'm intrigued that it is from a rural area. We have a higher possibility of basically a cryptic consanguinity. So I would continue to think about it as you follow the patient, and there may be some other genes of research interest depending on what else you find.
Dr. Arvind, do you have time or shall we close? It is 9:35 here in India.
I think we were supposed to close at 9:15. I think it's time to close. It's almost 9:40 on a Saturday evening, and I'm sure doctors would like to have a break at this point of time. And it was wonderful, I think, listening to Dr. Lou and Dr. Des, and I miss Dr. Des wearing his RCB t-shirt. I know some of the South African favorites of his are not a part of RCB for the next IPL season. And Lou, thank you very much for agreeing to come in the last minute, because earlier you said you would be doing the inpatient work today and then you would not be free. And then great that I could have both of you and Prasanna Kumar to share all the experiences. And it was wonderful for the listeners. And I just came to know that there were almost about 300 people, even at this time, listening to this particular session. So Prasanna, you can just wind up the session at this point of time.
Thank you, Professor Lou Philipson and Dr. Descharts, for a very interactive and interesting discussion. And we have learned a lot, not only about the diagnosis of type 1, the utility of C-peptide, when to do, how to do limitations, and also the antibody, doing one GAD antibody does not make any difference unless you have a profile insulin autoantibodies, IA2 antibodies, islet cell, or zinc transporter 8, which in this case was positive compared to others. And also clinically, how it is important whether you have acanthosis nigricans or not. Assuming that antibody is negative, C-peptide is high, that it is type 2 is not true. So many times, maybe clinical history, probably with a very good panel of antibodies will give a diagnosis rather than depending on C-peptide, what you said, which is misleading at different stages. I thank both of you for an excellent interpretation of the case, and the knowledge we got from you with an extensive experience. I would like to thank Dr. Arvind and his team for this great opportunity. Hope in future we will have such cases rather than one-sided. It should be bidirectional. Present cases like this intriguing, challenging, and we learn a lot from cases rather than the textbooks. And your wisdom in this, which comes from experience, is really great. Thank you very much.
I think before we close down, Prasanna, I have just one question. I think officially we have closed the session for the day, but on the humorous side, I would like to now know from Lou and Des, why is it that the honeymoon phase is only getting extended for children and not for the married month?
Well,
I don't think that's the case, but go ahead, Des.
No, I agree. I hope your wife heard that question. I hope, Aravind, that she heard that particular question, because I would have hoped that she would say she's been in a honeymoon with you for 40 plus years.
That's right. I mean, this year is we're married 41 years this year. And as far as I can tell, the honeymoon continues. So we're very lucky.
Well, we're 41 too, so that's good. But I also want to say, firstly, I couldn't agree with the session. It was fabulous. And you should have more of these sessions. So I do want to say that. And then I also want to say that, as you probably know, and I didn't wear the shirt deliberately today because you're probably aware that India plays South Africa next week.
Yes.
Oh, okay.
And I also want to say that, as a fan of Virat Kohli, who has just been deposed I think, unceremoniously by the Indian selectors, that in a way we're sort of hoping that he doesn't show up so that South Africa at least have a chance to play against, probably the best team in the world. So we're going to be in touch. And Kumar, I expect to get some texts or emails from you within the next couple of weeks. And as India and South Africa face off in South Africa.
And I could just add, as far as the format goes, this is a lost art, I think. And, so I imagine Dr. Schatz also, like me, grew up with seeing sort of real-time discussion of cases by experts who were prepared to be embarrassed. And yet most of the time they got it. So we're prepared to fail. I think, we're not going to know everyone, but the discussion is often interesting. And I love what you suggested, that it could be bilateral. So we could have a session in the future where we present cases to, a panel of your colleagues, for example, or an international panel, and have another kind of discussion. But I think this sort of thing I've been doing more and more over the last couple of years. When people ask me to give grand rounds, I say, well, can you have some of the fellows at least, or faculty present cases? We can do it that way. And that has also been very successful, and people, it hasn't been done in a long time. So this is great. Thank you all very much. Have a good evening. And I look forward to seeing you again soon.
Thank you.
Thank you.
And then bidirectional, then bilateral. Bidirectional, and also we can compare the resource limited setup to resourceful done. Like we had last week, 6 countries across Asia and Africa, from Cameroon to India to others, that how is it that the care is going on? What is it we can do? Though we didn't discuss cases, I think this is exactly what we need, the real world cases, and then also follow. We can also follow up what happens to these children after 1 month, 2 months when they come. And when we have next meeting, we'll present that. It will be very interesting.
That would be terrific. I look forward to that.
Sure. Thank you.
Thank you, Dr. Phillipson. Thank you, Dr. Datz. Thank you, Dr.
Thank you, guys.
I think with that, we will call it a day for today. I think the session ends. And then tomorrow morning, I just would like to remind all the delegates that we are meeting at 9 o'clock sharp. And that's when the session starts, and it's going to be a half-day session. From 9 to 1:30 is going to be the sessions tomorrow. We'll have 3 brilliant lectures from our American colleagues. And I hope to see you at 9 o'clock tomorrow morning. Good night.
Bye.
Bye-bye.
Bye.